age is 76-year-old, but compared high frequencies are more damaged, so the scores are less compared to discrimination scores is less.
Okay. So recommendations?
Recommendation would be going in for a hearing aid trial.
Hearing aid trial. Both ears or 1 year?
For the right ear.
Right ear. So left ear, no need of hearing aid?
Left ear, we can still give a trial. They should still benefit.
Okay.
Bilateral we can do.
Bilateral. Yes. Which type of hearing aid? RIC. Which dome?
Open dome.
Why?
Because there is low frequencies are better.
So yes. So just to quickly summarize, it is a minimal high frequency sloping in left, and right ear it is moderate high frequency sloping. And yes, as you said, hearing aids should be tried for both ears. Why open dome? Because the low frequencies are better, so that gets automatically moved out of the ear canal. I mean, one thing with respect to presbycusis is generally it is symmetrical, but an asymmetrical presbycusis is rare but possible. But that is something where the patient might have had some history in the right ear, because of which the right ear thresholds could have been worse. And we have different types of presbycusis also. So we have sensory, neural, strial, and other things. So considering how both the sensory and neural presbycusis have sloping hearing loss, but how do we determine it is sensory or neural is based on the speech identification scores. If you are seeing the speech scores in the right ear, it's around 64%. So generally for that loss, if it was pure cochlear or sensory, you should have got around 80% or so. So this is tending more towards neural, and though we are seeing subtypes of presbycusis, generally it is a mixed component where the degeneration happens. It happens in the cochlea and also in the neural level. Okay, so I think you have deciphered it well. So these are the additional. Thank you.
Added that tinnitus evaluation can also be done because bilateral tinnitus.
Yes, ma'am. So, as ma'am rightly pointed out, the patient has bilateral tinnitus, so you can add tinnitus evaluation also, and you need to counsel for management of tinnitus, as in like if the patient starts to wear hearing aid, the tinnitus would start to resolve. Yes, ma'am. So reflectance was done, and it is following the normal pattern. So that confirms that it's a normal middle ear functioning. So that confirms our sensory neural diagnosis.
Any questions from the groups? You want any clarification? We can go to the next case. Case 2. A 44-year-old male. Students, kindly crack it. You can get the best guidance from the professionals. Kindly interact with your group members. Study the case.
Answer was told by ma'am, based upon your diagnosis, 4 frequency average. The classification is WHO classification, or it's so they didn't tell about WHO classification. They just took 4 frequency average and the configuration. So you want to add up on the WHO classification, you need to provide.
According to Goodman's classification is mild.
Okay.
They say moderate.
They told mild, but overall the configuration, we approximated is moderate. The answer was given as moderate or moderate because of the more frequency.
If your group has your answers ready, you can raise your green card.
Are you guys ready?
Okay. Group 5, right is minimal hearing loss and left is mild sensory hearing loss. First, and recommendation would be ENT review and for the left ear it may be hearing aid trial.
Okay, so left ear, you said minimal and right ear, right? You don't want to comment on the type of hearing loss?
There is a connective complaint in low frequency, sir.
So you don't want to call minimal conductive?
No, sir.
Why?
Because we are not usually, we don't usually give minimal.
So we don't write type with minimal. Is that what it means?
No, sir. We after writing impression, creating connective complaint in low.
Okay. But your AC is affected clearly, BC is normal, and you have a clear middle ear pathology. So what's the harm in writing minimal conductive? You can write it. So generally tendency is to not write the type, or sometimes when you have confusions, not writing the type is appropriate. But when you are sure of pathology, writing minimal conductive is fine. And you said ENT review. Why ENT review?
For me, is type of
Okay. So and for what's the pathology in the right ear? Why does a person have conductive hearing loss?
medium.
Right ear. Conductive. Yeah, so the clear perforation, you can see the air canal volume is around 3.9, so that is elevated. Here you see the B-type tympanogram, and the reflectance pattern is also like perforation. If you remember Animation's presentation, so this shows a clear perforation, right? So, and when you kept on saying venous disease, so what made you say it is venous disease other than what is written? What are the indicators for you to say that it is venous?
Rising pattern,
Okay.
oral illness and vertigo, the triad symptoms.
Yes.
And in the multi-frequency component also at 2 kilohertz, only 1 kilohertz pattern is there. That's all, sir.
Where do you see that multi-component? That is a reflectance graph. It's a wideband tympanometry.
Because it is multi-component.
It's wideband tympanometry. And you see fixed does not animation was being describing this way, so it's not multi-frequency. Okay, and can you notice that the word admission scores? It's noted as with masking in left while testing the right ear, and with masking in right while testing the left ear. So is masking needed?
If we see as criteria, maybe it's not needed, but since connected hearing loss is there, it may have an affection with it.
So which year they should mask? The masking is warranted while you speech or electric. When you speech source, which year should be given noise?
We should give it the right here.
Right here, I should be given.
Also, we should give it the right here.
Left ear should be noise and fine pressure in the right ear. Just take an answer. What I told you, ratio was the right answer. Because that's these pressures are better in the right. You need to avoid the participation of that one. Okay? So always keep that in mind. You have to mask the ear where these pressures are much better. Any other clarification required? Can you have a green card? Can you all show your green card if you understood the case?
Good night, sir. Right ear is hearing and left ear is moderate passive hearing loss, and recommendation we have given for the patient is ENT review and for surgery, and if the patient is not willing for surgery and there is no active research, we recommend them for surgery.
Okay, so which
The left ear, left ear.
for the right ear?
It's a normal surgery, it's normal.
So is there any pathology in the right ear?
All the players is there, so recommendation, like ENT recommendations we are giving, and for polycythemia, that comes in for surgery, and if the patient is not willing to go for surgery, and ENT please go ahead, you can go for hearing aid trial also.
So is the tympanogram in left ear fine? What is the type of tympanogram that you see in left ear? Or right ear, sorry, right ear.
So right ear is okay, the left ear is better.
Right ear is okay? Are you sure?
Like C type, sir.
C type, and what about the reflexes? Reflexes are present or absent?
Absent, sir, absent.
Reflexes are absent, and what is the otoscopic examination results in right ear?
Bunch fever.
I mean, a retraction in the right tympanic membrane. So all those indicate, I mean, when do you get a C-type tympanogram? When do you get it? So yes, whenever you have an ET dysfunction, you are getting a C-type tympanogram and reflexes are absent, that clearly indicates conductive, and you are seeing a retracted TM also. So the conductive pathology is there in both right and left ear. So though the audiogram is showing normal, we should not say that it is normal. We should look at the other findings, because ET dysfunction may not lead to a hearing loss as such, but you are clearly seeing a C-type. So that also requires medical line of management. The other thing that you said, and the reflectance is also showing abnormality, and if it's a cholesteatoma, the medical line of management, whatever you suggested, is fine. So one last question, as in like they have done masked AC in the left ear at 3 frequencies. So if it was done through insert, was it required or not required? Not required. Why?
Since the intraoral attenuation is 75,
Yeah.
won't require mask.
Yes, so if you remember Almesa's presentation yesterday, so the criteria would become if it is greater than or equal to 70 and it may not be needed. They have done this masking because they might have done through air conduction or through headphones.
Any other groups? You have any doubts? Also, so why was it done? Any guess? Any groups? Sir, you can point any group or any member, sir. Choice is yours, sir. Any group, you are given the maximum choice.
There is no functional rate of weighted complaints, so there is no need to do that.
You don't need to do standard test.
Maybe standard is principal for Weber, so indirectly we can check the Weber.
Yeah, so assessing the sensitivity of both the cochlear. So there is negative, which means there is no lateral indirectly of assessing. That's what we have to do.
Twice a mark means right.
Very mass basically. Right. Yeah, again, just to see, it's not required actually, but there's a retraction in the TM, which is not, that's greater yargo that will be left. Right? So, cross is also present. So they want to identify whether it is the right is the true threshold or it's because of the real pathology on the left side. That's why the first place they assessment. Kind of. There are masks for both these levels.
Like this moderately severe extent here, this is silent here loss. ABR is also done. At 80 dB, we have got a DP 50 and only left here, right and right, and reflexes are present in both here. Elevated in the right here. So, recommendation is silent hair loss can be treated by steroids.
So how the HCC are absent, so it is the same cochlear. So based on the ABR results, how do you say it is cochlear or epicochlear? So ABR is present, and if you see the interpeak latencies of 1, 3, 3, 5 and 1, 5, all are normals, all of that also indicates it's a cochlear origin and not a retrocochlear. And you have 50 present till 80 dB. So what is your interpretation in terms of the threshold? So if you have got peak till 80, so what would be the threshold? So around 15 to 20 you subtract. So that again correlates with your audiogram test results. So sudden sensitivity, as you said, the management, initially we should not go for a hearing aid immediately. We should send for an ENT review because it can be reversible. So when we say the golden period is like 48 hours, if you are giving steroids, so it can come back to normal. So, but if it's a long-standing and if the patient did not go for it and it tried also, if improvement didn't happen, then the last resort would be to go for a hearing aid. Any group who is ready? This is yeah.
Group 11 is ready. Kindly sit according to your groups.
And right, your hair loss. High sensitivity hair loss. Please stand with them. They want you to really try also.
Okay, so first thing, do you agree that it is ANSC? How are you saying that it is ANSC? What are the indicators?
This is just what are the findings can see to say that it's an ANST. Okay.
Right. In terms of speech score, we can further go for cognitive implantation. When compared to infantile and hearing aid, the performance is better in cases of cochlear implantation outcomes. There are some studies which tell that there are good speech performance scores after cochlear implantation in ANSD. Yeah, and specifically in terms of presynaptic ALSP conditions.
Yes. Yeah. Hearing loss. Okay, whatever you have done, the child is able to hear that some behavioral responses actually being present at close to mild degree. So start with that, how the child is improving, how is the speech perception. So based on that, start with the assisted listening devices and see the improvement. And by seeing those things, then you can decide upon the further management option. So it was pointed out, you can go for cochlear implantation. If the speech perception started on improving and assisted listening is also not helpful, then nowadays we have an option to assess whether it is presynaptic or postsynaptic using EAVR. Okay, so we can design the appropriate management option in a stepwise manner, from the most conservative procedure to the final management. Okay, so starting with the rehabilitation process. Okay. If there are no further questions, shall we wind up this session? Any questions?
The filling of the page, but the lighting of the fire. Let us start with the keynote by Dr. Audiology.
Madam is the Deputy Director of VII Medical College and Hospital, Kirumambakkam, Puducherry, and has completed the OAE. We welcome you, ma'am.
Good morning. Yeah, that's very nice. All of you are awake, and from yesterday, I think you learned to respond to the good morning wish. Thank you for that. And I would like to just brief of OAE. I'm not going to touch on the research aspects of the OAE, only the clinical utility of OAEs. And I would like to thank the opportunity given by the HCC Trichy, and I am also thankful to the Almighty, my parents, all the elders and seniors, teachers, and of course my source of power are my students. Yeah, thank you. So I got retired from All India Institute of Speech and Hearing, Mysore in the year 2021, and following that I joined AVMC, and it's almost 1.5 years since my journey in AVMC, and immediately after I joined, 2 months later I got my successful PhD, Dr. Pradna, and she is also working with me as a professor in audiology, and together we have a lot of dreams for AVMC, and we would like to take it further, and this journey has been good so far. So we will look at otoacoustic emissions from the perspective of clinical audiology. And I remember yesterday even Dr. Animesh was saying about how important the pure tone audiometry from the clinical perspective. So continuing the trend that he left yesterday, we will go further. So this is the university where I am working now presently. This is the Vinayaka Missions Research Foundation. It was founded in the year 1981, and BSc course was started in the year 2004. Prior to that, there was a diploma program in the 2003, and they started the master's program in the year 2021. Right now we have one batch of successfully completed masters in speech and audio, and we were given the recognition of School of Rehabilitation and Behavioral Sciences in the year 21, and we are also one faculty now in the university. Our faculty is called as Behavioral Sciences and Rehabilitation, and the VMRF has 4 campuses, one in Karaikal, Payanur, Pondicherry and Salem. They are giving education for almost different 22 sciences, and we have 4 medical colleges and engineering college and incubation center, and it's very fortunate to be working in a university where we have a lot of encouragement and support from the medical fraternity. So this is the Vinayaka Mission's Research Foundation, the Arupadai Vida Medical College in Puducherry. So let's get on to the topic. We have a small introduction, then the newborn hearing screening and OAEs, early childhood hearing screening and OAEs, audiological diagnostic test battery and OAEs, and other applications and the research advances in a nutshell. So we all know in the year 1978, David Kemp, a British physician who was working with the Royal National Ear and Throat Hospital in London, was the first one to demonstrate that auditory input generated a response in the cochlea which could be measured and recorded. And those days, this was called as Kemp's echoes. And let's see how the clinical audiology developed the OAs on the timeline. So it was the Puritan audiometry. We all know it was given by Bunch in the year 1943. That was during the Second World War. And then the speech audiometry developed during the year 1952, and we can attribute all this to Hirsch. And then the diagnostic site of lesion testing audiometry was due by Johnson in the year 1965, and impedance measurement took up in the year 1970, and we all know the biggest contributor for this is Jerger. And then the ABR was developed in the year 1981 by Moeller, and the autoacoustic emissions in the year 1978 by Kemp. So what are OAEs? The OAEs are the sound generated by the ear, and it is the low intensity sound produced by the cochlea, mainly depicting the outer hair cell function. So it is a functionless leakage of OAE twitch energy, and it comes back to the ear canal. That is what is defined by David Kemp in the year 1978. So we can have a classification based on OAEs as the spontaneous OAE, then we have evoked OAEs, which can be TEOAEs and DPOAEs. So we have the notation as given in the table. The notation for spontaneous is SOAE, and the stimulus is none there. And then the prevalence by the ear is around 50%. Then we have TEOAEs, and the stimulus used is click or tone burst, and it is a 100% prevalent response. Then we have stimulus frequency OAEs, which are known as the SFOAEs, and it is generated by continuous pure tone, and it is also 100% response. Then the distortion product OAE, or which are designated as DPOAEs, and the principle of DPOAE, I'm sure all of us know, it is the interaction of two frequencies. So it is the distortion product by the combination tones. So that also has 100% prevalence. And then we'll just go into the details of TOAE and DPOAE to get an idea about this. The first type of OAE reported in the literature is the TOAEs, and they are frequency responses that follow a brief acoustic stimulus such as a click or tone burst. TOAEs are typical, and they are found in normal ear, and they fall off frequencies which is 2 kilohertz and is rarely present over 4 kilohertz, which is the technical limitation in the speaker at higher frequencies and the physical features of the adult ear canals. So for newborns and infants, it's a more robust and typically can be measured up to 6 kilohertz because the ear canals are smaller and they influence the acoustic characteristic of the standard teeth stimuli much differently than to the adult's ears. So TEOAs do not occur in people with a hearing loss greater than 30 dB. I'm sure you all know about this. When there is a hearing loss exceeding 30 dB, TEOAs cannot be measured, can be absorbed. So this is the equipment that is used for the TEOAs. So you see the stimulus is clicked. You see the probe assembly. It has a receiver and then a microphone, and then there is a amplifier and filter, and it can go to the analysis system and averager, and this would be the response that you get in a TEOAE. The next type of OAE is the distortion product OAE, and it results from the interaction of simultaneously presented pure tones, two pure tones at two frequencies, F1 and F2, and it also has two intensity levels, L1 and L2. So the relationship between L1, L2 and F1, F2 dictates the frequency response. DPOAs allow for a greater frequency specificity and can be used to record at higher frequencies than TEOAs. Therefore, DPOAs may be useful for early detection of cochlear damage. So, the most application of DPOAE would be in terms of noise-induced hearing loss. So, it could be an early indicator for NIHL. Then DPOAs often can be recorded in individuals with mild to moderate hearing loss for whom TEOAs are absent. So, the advantage of DPOAs is that whenever you are not able to measure the TEOAE, you can elicit DPOAs. This is the technique measurement of DPOAE. So, I told there are two stimuli. So, you have receiver 1 and receiver 2. You have stimulus tone 1 and stimulus tone 2. And it gets to the ear and it's picked up by the microphone. Then it's amplified and the analysis system analyzes. And this would be the graph. And this would be the display of what you see as DPOAE graph. And you see that the geometric mean frequency is 2191. The frequency is presented as 2000 and 2400 Hz. So let's move on to the newborn hearing screening and the importance of OAEs. So the newborn hearing screening is abbreviated as NHS, and the importance of OAEs is very, very important for newborn hearing screening. So there are a lot of research evidence which shows that the OAEs can be important tools that can be measured in the NHS protocol across the different countries. So we have some reports about the use of OAEs in newborn hearing infant screening. So out of the 158 countries studied, 87% of the countries used OAEs in their protocol, and 57% used OAE alone, and 30% of the countries used OAE plus AAVR. And yesterday, I think Dr. Animesh spoke about the AAVR and importance of OAE, and he had measured about some of the difficulties in the measurement of OAEs. So there have been some technological advances, and then if we use that, I think that will be an advantage. So this is another article showing the importance of assessment of hearing screening programs across 47 countries or regions, and how the provision for newborn hearing screening is meant. So out of the 42 countries, from the 47 countries where NHS program is run, 40 out of the 42 countries, that is greater than 90%, use OAEs during their NHS. So it's only 5 countries which have not developed the NHS program, and of the 40 countries, in the 42 countries, more than 95% of the countries use OAE in their protocol. So you can see in this India we have the protocol, but then it's not widely used. There is a variant. It varies what are we using. But I'm sure in some of the states like Tamil Nadu, Karnataka, with the introduction of the NPPCD and RBSK program, the protocol is used effectively. I think other speakers may elaborate on those things about the RBSK and infant screening programs run through AISH and other institutes in the Tamil Nadu or Chennai. So what are the clinical practice guidelines NHS and OEE require recommendations? Let's get a brief review on that. So there is a systematic review of newborn and childhood hearing screening around the world and comparison and quality assessment of guidelines. So the study aimed to assess global guidelines for NHS, and 15 NHS guidelines were identified, and 14 out of the 15 guidelines recommend the use of OAEs during the NHS program. So that talks about the importance given to OAE during clinical testing. So again, you see that which are the countries in this table, which are the countries that use the newborn hearing guidelines, and the characteristic key recommendations used by the different countries are given. So it talks about OAE plus AABR or OAE alone, how the recommendation is used in those countries. So look at this. This is highlighting the characteristic that is used in India, and it's given by the Indian Academy of Pediatrics, and it was given in the year 2017, and it was based on the census statement, and we are using OAE and ABR also for our screening protocols. And this shows the other countries which are using the OAE ABR. So WHO says that OAE, AABR and others can be used for the newborn hearing screening program. The next thing would be who should test, when should it be tested, what are the preparations, and what tips and tricks you need to follow, whether to go for DPOAE or TEOAE, and then what is the test protocol for OAE, and how do you consider the pass criteria. So let's look at each one of them. Who should test? This is a very widely open choice question, whether it's the audiologist or others. So ideal is a certified audiologist. Ideal professional to measure OAE is a certified audiologist. But in case of lack of manpower, so you can go for any well-trained healthcare technicians. And however, whatever they do, that should be monitored and supervised by the audiologist. And you can also have well-trained screeners, technicians, nurses, ASHA or Anganwadi workers, midwives, audiology interns, etc. We visited a medical college in Calicut in the month of July, and we saw their protocol. They used healthcare workers for OAE screening, and they did not use ABR. It was only OAE, and they had a good success rate for identification of hearing loss in children. So you can depend on primary healthcare workers for getting the OAEs. And when to test? What is the optimum time to test the OAEs? Day 1 is not generally recommended because there could be debris in the ear. So it would be ideal to measure the OAEs on the second or third day, and it should be prior to the discharge of the baby from the hospital. And when you have to measure, that is when the baby is calm, and it could be after feeding. And then if the baby has had a bath, wait for a couple of hours after to allow time for ears to dry. When the ears are wet, you cannot get good OAEs. So wait for the ears to dry, and that is the time. And how should the baby be? The baby could be in the bassinet, cradle, or it works if it is available. So what are the preparations for measuring the OAE in babies? So the preparations are, start with the equipment check, like how you do for any other equipment you use. You have an equipment check, then discuss the testing that you are doing with the parents. What is it that you are going to measure? What sort of cooperation is required from the baby? And how to keep the baby while this is being measured. All those things can be talked to the parents and then ask if there are any high risk factors, because the baby is delivered in the hospital most of the time, and then it's wiser to get some information about the high risk factors. Then ensure that the room is quiet and place a sign on the door to reduce the interruptions when the testing is going on. Then swaddle to help the baby relax so that you can get good OAEs, and examine the ear for debris, and this will also help you to choose the right kind of tip. What should be the tip size? That could be decided by looking into the ears of the child. Then what are the tricks and tips that you need to take care of while the OAEs are measured? Choosing a probe tip of correct size is the key factor. Snug fit, slightly larger than the canal, but not too large, and snug probe fit will help keep out environmental noise. Try different sizes. Try not to hold tip in the air as it can cause extra noise. Rotate the probe tip slightly as you are placing it in a canal to get a good seal. Insert tip and let baby calm instead of waiting for them to calm first. Rotate baby slightly to side to let gravity help, and if the baby is upset, use a pacifier. Remove if sucking is causing too much noise. So these are the precautions and tips that you need to take while you want to measure the OAEs. Remember, if baby wakes up and is active and upset, pause the test. Don't continue. Testing an active baby can result in longer test times and higher referral rates. I'm sure you can remember what yesterday Dr. Animesh Burman talked about the referral rates. How it can be showing false positives and false negatives. So you have to be careful about the higher referral rates when you are measuring this. Then whether DPOAE or TEOAE, that's the next question. So DPOAE or TEOAE, you should think, if the time permits, use both, measure both. Lately, DPOAEs are preferred over TEOAs because they allow higher frequency band recording. I told you earlier, it can go up to 6 kHz. TEOAE can only be going up to 4 kHz. So, prefer to use DPOAEs, or if time permits, use both. Even with higher noise floor, it can be recorded, DPOAEs. TEOEs are more sensitive to mild hearing loss. So, the choice of TEOAE is not wise. You can go for DPOAEs if there is less time. What is the test protocol for OAEs? The OAE test protocol, I already told that it will be high frequency and low frequency, and you also can have whether it is for diagnostic purpose or for screening purpose. So generally you have two intensities, 65 and 55. For high frequencies you use both 65 and 55. For low frequencies also you use that. For newborn screening it's different. You see the difference between the F2 range and the octave, and what is that we use for newborn hearing screening. For the school screening, it goes up to 2 to 8 kilohertz. So there is a wider range of frequencies that could be covered during the school screening. But for newborn screening, it can go up to 2 to 5 kilohertz. And for low frequency, it is between 0.5 to 1 kilohertz. And for the high frequencies, it can go from 2 to 10 kilohertz. What is the pass criteria? So we have selected the protocol, we have selected which of the OAEs, and then how do you decide what is pass? So that depends on the signal to noise floor ratio. So usually we take 6 dB ascent ratio to determine the pass criteria, and usually 3 frequency pass is required. That is the minimum. 3 frequency pass and 6 dB signal to noise ratio. That will be the pass criteria for OAEs. Next, we move on to the early childhood hearing screening and the importance of OAEs. This age ranges from 6 months to 3 years. So, why there is a need for early childhood hearing screening? What are the existing guidelines? What is the screening tool? Why OAE only? What is the screening protocol? The protocol is given by Hall 2016, and there are some successful tips for OAE screening that's given by Hall. Let's get into that. So why there is a need for early childhood screening? Because we know that NHS is not universal aid. There are not many countries who do NHS. They do not have newborn hearing screening developed in their countries. So at least if you have missed them during the hospital discharge, in the early childhood, if there is any problem, that could be detected using the early childhood screening. So this is another article talking about the importance of global status on newborn and infant hearing screening. So we see that coverage of screening, and then the number of countries using that, the percent of countries which have used, and the percent of world population, and what is the GDP. So if you know that only 64, among the 64 countries, the maximum number of countries which use is only 41. So we have to employ this screening for early childhood hearing loss also. The second factor is that, the first factor is that universal hearing screening is not followed at. The second factor which talks about the importance of early childhood screening is the misidentification during NHS. Yesterday we talked about the false positive and false negative because of the OAE protocols. So those children who missed the pass-fail criteria in the NHS, they could be detected during the detection of early childhood screening. So NHS programs do not detect, they only detect 10 to 20% of the children, and many a times we don't get to know about the children who have permanent hearing loss that cannot be detected with the NHS program. So that is the serious concern that audiologists should take into consideration and employ the early childhood screening protocol. And then many of the NHS programs have very poor follow-up rates. So because of that poor follow-up rates, there could be myths about the children who are getting hearing loss. So that also determines the need for early childhood hearing screening. Then there are certain hearing losses which will have late onset. So not to miss out on the late onset hearing losses, we should include the early childhood screening protocol, because the prevalence of hearing loss in the age range of 60 to 10 per thousand school-going children is 2 to 3 for 10,000 children who are infants. So that talks about the importance, 6 to 10 versus 2 to 3. So I think this should be a serious point that should be taken cognizance of by the audiologist to advocate the early childhood hearing screening. Then what are the existing guidelines for the early childhood hearing screening? So there are guidelines given by ASHA, and this was in the year 1997, and as per the recommendations for preventive pediatric health care, American Academy of Pediatrics has given the recommendations in the year 2007. Clinical practice guidelines for childhood hearing screening by American Academy of Audiology. So this is the later version of the protocol guidelines given by the American Academy of Pediatrics. Following that, the American Academy of Audiology has given in the year 2011, and hearing screening guidelines for the preschool and school population is the modified one that is given in the year 2016, and hearing screening consideration for implementation was given by WHO, and that is the latest. 2021 is the WHO guidelines given for hearing screening in the early childhood population. So we can adopt this guidelines given by WHO to make our programs very effective. Then what is a screening tool? It should be hearing screening which is quick and simple. It should be also a behavioral technique which is, when not feasible, for routine hearing screening of children in the range of 6 months to 3 years, and that is the guideline given by Hall in the year 2016. So the earlier guideline was given by the authors Northern and Downs in the year 1991. So we know that OAE is an objective technique, and findings are not influenced by many variables like chronological age, cognitive level, language skills, motor abilities, and visual distractions. And sensitivity to the types of auditory problems commonly encountered in young children, that is abnormal OAE findings, are very likely in children with mid-ear infection and or with cochlear hearing loss involving outer hair cell dysfunction. Most etiologies for childhood hearing loss affect outer hair cell function, and this is a study done by Sumitra Jiddar and Hall in the year 2012, and hence OAEs offer the most promising option for systematic hearing screening, and this is envisaged by Hall in the year 2016. This is Hall. So he has given the effective and efficient screening protocol in the year 2016. So what are the guidelines according to 2016 Hall's guidelines? So it talks about 6 months to 4 years age children. Primary screening technique as recommended is DPOAE, and the stimulus intensity should be L1 at 65 dBSPL and L2 at 55 dBSPL, and F2 frequency region should be between 2000 to 5000 Hz, and frequencies per octave should be 4, and the pass criteria will be DPOAE amplitude is equal to greater than 0 dBSPL, and DPOAE and noise floor difference is always greater than 6 dB. Secondary screening techniques for refer outcome according to Hall 2016 recommendation is that tympanometry, acoustic reflex with broadband noise, and otoscopy is always a must. So we have two protocols. One is the primary screening protocol and the secondary screening protocol given by Hall in the year 2016. And for children greater than 4 years of age, the primary screening protocol and the secondary follow-up protocols are different. You can see that primary screening technique is the advocation of DPOAEs. Stimulus frequency intensity would be L165, L255. That's widely accepted and used. F2 frequency from 2000 Hz to 5000 Hz, and frequencies per octave as in the previous it's 4, and pass criteria is 0 dBSPL, greater than 0 dBSPL for DPOAE amplitude, and DPOAE versus noise floor should always be greater than 6 dB, and the follow-up techniques for children who do not pass DPOAE is that you should include tympanometry, pure tone hearing screening at 20 dB HL if possible, and acoustic reflex for broadband noise if indicated, and then otoscopy is a must. So this is for children greater than 4 years. So we have now what is the protocol for 0 to 4 years and what is the protocol that should be used for children above 4 years and up. So 3 highlights in the recommendations are that tympanometry is performed for all young children who do not pass the initial OAE screening to identify those with middle ear dysfunction. So the importance is for the identification of middle ear infection. We all know very well that children in the young age are more prone for the middle ear infection. So if we can identify that, we are going to lessen the burden of APD. I think Dr. Sandeep did a PhD on the importance of the middle ear infections and how it could lead to the APD, if I am right. So I think during interactions you can talk to him and find out what is the significant findings he did find in his PhD study. So that is the importance of tympanometry. Middle ear dysfunction identification is very, very important in young children or school-going children. The second thing is the immediate follow-up screening technique for preschool children who are less than 4 years of age is acoustic reflex measurement with broadband noise stimulus. So if you can measure the acoustic stimulus, acoustic reflex with broadband noise, you are going to have an idea about their threshold, hearing threshold. So that's the second important recommendation. The third recommendation, which is important, is about the pure tone hearing screening in the follow-up screening technique for children who are above 4 years of age and who do not pass OAE screening but who have normal tympanometry. In the screening, you find that there is normal tympanometry findings, but then they should be tested with follow-up pure tone hearing threshold measurement. That's very important. Then what are the tips for successful OAE screening? We were talking about tricks and tips. So we come to the tips for successful OAE screening. So it is very important to build rapport with the child. So most of our techniques are based on how we build rapport with young children and their parents. So it's very important you build a good rapport with the child and create a fun feeling. For example, you may tell a child that you are going to play a listening game and include another adult, first person to be screened, placing the probe near their ear and asking them if they heard the song or sound. So that will motivate the children to become active and get involved in the screening process. The phrase like test your ears, don't use that. We are going to say that we are going to play a game. We never use the phrase that we are going to test your ears. So that should be carefully handled. And you start the activity and say that it won't hurt, all that things should not be disclosed to the child. Position yourself to the side of or slightly behind the child to facilitate probe insertion. So probe insertion will be easy when you stand in a position just behind the child to the side. Okay? And if possible, have another adult hold the child snugly or keep the child distracted, hands occupied with another activity. So don't use the probe just by standing close to the child without changing your position. That may not facilitate easy recording. So use toys and distractors for children, and visual inspection is for drainage, and if there are any evident malformations that should be checked. And the important guide is good probe fit. You should make sure that there is a good probe fit and you will be able to measure OAEs appropriately. And always remember, hygiene is very important. So when you use these protocols with children, make sure that the technique is hygienic. So let's move on to the audiological diagnostic test battery and the importance of OAEs in our test batteries. So we know that role of OAEs in audiologic test battery, and then we have 4 fundamental steps before OAEs. Then there are some common diagnostic application of OAEs, and then what are the clinical cautions. So the first thing is OAEs are a valuable and essential component for evaluating everyone from infants to adults. So that should be always remembered in mind so that we will have an opportunity to obtain the OAEs wherever possible. And it cannot serve as a standalone test. OAE is never a standalone test. The results of OAE should be complementing other audiological tests. So remember that. That is very important. And cross-check principle is given by Jerger and Hayes, and that is in the year 1976. So you can go check what is the cross-check principle. And otoscopy, middle ear measurement, stimulus calibration, and monitoring noise level in the canal are the very important guidelines as given by Hall in the year 2015. What is wrong in this DPOE recording. There is something wrong in this DPOE recording. Yeah, that's a very good observation. Let's see this one. How about this? Is it good?
No.
Not good? What is the noise floor difference here? Less than 10 dB? We said it should be greater than 6 dB, no? So this is applicable, this is acceptable. If there is a difference of 10 dB between the signal and noise, that's acceptable. So whether OAEs can be used for the differential diagnosis of CPs and RCPs. So the important thing is the identification of pseudo-hypothesis. Then what are the population which is difficult to test. So we'll see the differential diagnosis of CP versus RCP. So RCP will present with the normal OAE but abnormal audiogram and ABR. Can you remember where you find this? Yeah, that's a very good answer. ANSD is one of the most common RCP which can be having normal OAEs but abnormal ABR. And that's the signature finding in ANSD. There are a lot of ANSD experts here. I may be immature to talk about the characteristics and other things about ANSD. So let's remember that the OAEs are present, the ABR is absent in ANSD. Then it often presents with absent or severely abnormal ABR, poor word recognition, and absent stapedial reflexes. The speech in noise performance is always a good indicator for the identification of ANSD. OAE also may disappear over time in patients with ANSD. So initially you may find that the OAEs are present, but as the disorder is advancing, the OAEs may disappear, and OAE may also disappear in patients with ANSD over time, and it may be absent if RCP masses impinge on the internal auditory artery and compromise the blood flow. So there are two conditions when OAE can be absent in RCP. When the time is progressing, the OAE can be absent, and then the tumor is impinging on the blood flow. In that case also, the OAE could be absent. So this is one important feature for differential diagnosis of CP and RCP. So then how is it useful in the cases of pseudo-hypothesis? And this is one important clinical entity we encounter in our everyday life. So how well we can use the OAEs to distinguish the pseudo-hypothesis cases is one important thing. It is a quick and reliable test for both adults and children. So you can depend on OAE, and patients' behavioral responses are not required when you measure OAE. So depend on OAE. Then it gives you specific information, and hence it can be used in identifying both unilateral and bilateral cases because it's giving ear specific information. And then discrepancy between pure tone thresholds and OAE results. OAE results might be an indication. However, we need to rule carefully out the other possibilities like headphone problems, neural dysfunction, etc. while we identify the pseudo-hypothesis cases. The assessment of difficult to test population. the usefulness of OAE in this should never be underestimated, because there are a group of patients, both in adults and children group, who will not be cooperative for your behavioral testing. So then you use OAEs, and the example for this would be people with intellectual disabilities and autism spectrum disorder. Then some of the patients will always give very inconsistent findings with behavioral testing, and you can never condition them. So in such cases, you fail to get conditioned responses or behavioral responses in some patients. In those cases, always use OAEs as an alternative tool. And some children, it may not be possible to have sedation. Medically, it may not be feasible. So in such cases, OAE could be an option. And remember, the very important striking point to remember is that OAE is a complementary test. You cannot depend solely on OAE findings. So you have to interpret it in the light of the results of other testing. So the last thing is about the cautions and clinical things that you need to take care of. So over-reliance on screening protocols is not advised. So recording within a limited frequency range, simple pass versus fail is not a good idea. And then questionable techniques for measurement and analysis. So you should depend on multiple trials, not a single trial or run. So then remember that if your OAEs do not repeat, your test is not complete. Always make it a point to repeat the OAE recordings. Then the third thing is never have false assumptions. It may not give the valuable information. You can never say, I know the patient has a sensory neural hearing loss. Why should I perform OAE? That should not be. That's an over assumption. You should never take that. And remember this, OAE complement the audiogram, and sometimes they disagree with the audiogram. That is why the OAEs are providing value. They are not making your diagnosis easier. They can complement by adding some value to your diagnosis. Remember that when you are using OAE as a tool. So the last part of the presentation is about the other applications of OAE. So it is useful for monitoring cochlear function in cases where ototoxicity is suspected, and some of the antibiotics like aminoglycoside chemotherapeutic agents are used. And then it's also used in interoperative monitoring in cases of acoustic neuroma. And then it is a very important tool for measuring noise versus music exposure and hearing loss related in that. And then the sudden hearing loss. And now the advocate thing of OAEs for tinnitus and hyperacusis, I think Dr. Prashant Prabhu would touch upon it. So that is one area emerging to be very important. So we come to the last part of the take-home message. OAE, the benefit versus its clinical utilization. It is the tip of the iceberg. It is the wisdom of the clinician which decides how much you should utilize it and how much clinical benefit you should take from the interpretation of the OAEs. Whatever purpose you are using it, take it with the tip of the iceberg message. Thank you for your patient listening. I'm very grateful to the organizers of this FlaSH 7 series, the management and the team of FlaSH 7, the team of HCC in special in particular. Thank you very much.
Thank you, ma'am. That was an informative session.
Came early morning. So the topic that I would talk now is basic audiological evaluation. This is primarily the pure tone audiometry and speech audiometry. As all of you know, the pure tone audiometry is one of the gold standard and bread and butter of audiologists. Everyone does pure tone audiometry for every patient that comes into your clinic, or when you start practicing, the first test that you would be doing on each one of your patient without a miss is a pure tone audiometry. So I think the one test that you should be a master of it is a pure tone audiometry, because that is a one test which gives you a lot of information. It's usable. That information it provides is usable in multiple ways, starting from just knowing the patient to counseling the patient, making a diagnosis, selecting a hearing aid, counseling about the hearing aid, seeing the hearing aid benefit. So everything boils down to how well you have performed pure tone audiometry, and your skill of performing pure tone audiometry is what distinguishes you from the technicians. The big existential challenge that all of us are facing today as audiologists are, what are we doing, or what is our scope when somebody else does our job? What should we do, or how should we stand out? The skill that we possess in doing these basic tests are the one what makes us stand out from the technicians or the people who does diploma or quacks who claims to do that, claims to do know our profession and does our test. But if we don't know the basics of that, and if we also perform at a same level as them, then it becomes very difficult for others to distinguish between what skills we have and what skills are required to be good audiologists, and how to differentiate between the technician and professionals, or technician and audiologist, or quacks and audiologist. So by the end of 4 years course of your BASLP, and probably at the end of this talk, the one thing that I want all of you to know is how to do speech audiometry and how to do pure tone audiometry. This has got a lot of face validity, and this is the one which is very essential in the survival skill and standing our profession apart from the technicians. So I think a part of this is covered yesterday as well. In fact, this talk was supposed to be yesterday, but my iPhone broke. Did it break? No.
Thank God.
Yeah, thank God. I should have thanked God in the beginning. Shouldn't have dropped it. Okay. So, some portion of it would have been covered yesterday by Anipesh sir. I wasn't clear what he spoke, but when I asked Sundaresh, he said he primarily spoke about masking. So when it comes to masking, we will skip that portion. You would have learned that yesterday. So what is a threshold? How many of the question that I asked is primarily for students. The professionals need not answer. If students don't answer, then you can answer. What is a threshold? The last benches. What is a threshold? Can anybody speak loud? Huh? Okay, is a threshold a concept in audiology? Is the term threshold, is that a concept in audiology? Yes or no? It is in audiology. Is it only in audiology, or it's in other fields as well? Other fields as well. So basically, threshold is nothing but some minimum amount that we can see, hear, or feel. So when it comes to audiology, it is about hearing. Can all of you see this dot? The red dot on the screen. I was thinking I was controlling everything. This is the false hope all of us live with, that I am the controller. In fact, somebody else is the controller. I was thinking I am doing everything here, but she was quietly. Okay, we'll come back to the red dot again. Now I am controlling, hopefully, let's see. Sam won't control, right? You're Sam, right? Yeah. Huh? Yeah, yeah. No, if it doesn't, if it change, if it not changes, you touch. So all of you can see this dot, right? Yeah. Can you see this dot? So what is the difference between first dot and the second dot? The second dot is smaller than the first dot. You can see this one, right? Can you see this one? This one? All of you can see the back ones also? Maybe. The other dot came now. Can anybody see this? One more came. There are two dots in that block that I have drawn. Can anybody see that? Many of you may not see. Somebody in the front may see. So basically what I wanted to show is this is the threshold. The minimum size that you can perceive is the threshold in case of vision. So similarly, minimum intensity that you can hear is the threshold in case of audition. Now threshold is a point which is not a singular. Now in this case, some dots, some of you can see, others might not see that dot. And the same person, if he sees again, he may be able to see a dot which was not seen earlier. So threshold is a point where at times you can see, at times you cannot see. Okay, so likewise even in the hearing, threshold is a point where at times you can hear, at times you may not hear. So when we say that a patient is inconsistent, we are making fools of our own selves because the threshold is defined as a point where there is an inconsistency. At times you should hear, at times you should not hear. That point is called threshold. So we want to measure that point, and if you want to measure that point, there has to be inconsistency because at times the patient should hear and at times the patient should not hear, because we want to find out that minimum level where it arises a confusion or where there is a confusion of hearing, how there is a confusion for seeing over in this slide. So what are the standard procedures that are used to establish threshold? Usually we have something called clinically defined procedure which is taught in the class, but when you go to the clinics, we did a small survey to see how many people follow the procedure that has been taught in the class. More than 75% of the master's graduates use some or the other variations of what is the procedure they have learned. And when you ask about what is the variation, it is usually increase, decrease, and find out some point where the person raises his finger. Now, what is the? I'm not saying we shouldn't be doing that. We will get thresholds even with those techniques. There are hundreds of techniques which are valid, and we can get thresholds with all of those techniques. But the problem is, from one technique to the other technique, when we estimate threshold keeps changing. Why does the threshold keep changing? As I said, threshold is a point where there is a confusion about hearing. So if I use a technique A, I'll get one value. If I use a technique B, I'll get another value. If I use a technique C, I'll get slightly other value, because all of that will boil down to the points where there is less or more confusions. Okay. So what happens with that if we use these kind of non-standardized or keep on changing our technique every single time? We get different values of thresholds every time, and so what happens? Threshold from one clinic is not comparable to the other clinic. Or if a same patient comes back to you, the threshold you obtained in the same person a month back or a week back or maybe even a day back, not comparable to the threshold that you get now. So this is just an example of the variation that happens because of the differences in the technique that has been shown. A person whose thresholds are this, like this, if I use another technique, we will get the same pattern, but the thresholds would be different from this. So if I choose a hearing aid, or if I program a hearing aid, or even if I send this for an ENT doctor for the who has referred to us and diagnosing this as a SN hearing loss and probably this as a conductive hearing loss or something. So what happens? There is lot of inconsistency because of because we use non-standard or we keep on changing the techniques that we use to estimate threshold. So what is advised all over the world is a modified version of Hudson and Westlake, which is being adapted by Isha. Is what is Isha stands for? Huh? Indian speech and hearing, Indian speech language hearing, speech and language hearing, speech language and hearing association, and also adapted by ASHA, American Speech Language and Hearing Association. So this technique is taught in all classes, but when it comes to clinics, nobody practices this technique. So we will go through this technique in detail. So at the end of the presentation, I am very happy if you are thorough with this technique. Go back and practice the same technique. I am not saying whatever the technique that you use in clinics is not correct. But as an audiologist, we should have a same technique across everywhere. All of us should be using the same technique so that when a patient comes to your clinic versus somebody else's clinic, we get a same value. We shouldn't be in a position and saying that, okay, that person did something wrong, his value is wrong, my value is correct. That it's wrong or correct because he used one technique and you use another technique. So what is this technique? First, you need to decide whether the person has normal hearing or he has a hearing loss. So how would you decide? You just talk to him. So you would know whether you have to raise your voice or don't have to raise your voice. He can understand your conversation level. So if you understand your conversation level, you can start it at 30 to 40 dB, that initial level where you set it. If he has hearing loss, you set it at 70 dB. And if it doesn't respond at this level, you go on increasing in 20 or 30 dB steps till you get a first correct response. So we'll take an example of person with hearing loss. Let's assume that first we started at 70 dB and we got a first positive response. Okay, this is a positive. It's coming on this screen. It's not coming on that screen. I don't know why is that. It's you can see positive. Okay. Huh? Okay. I can't see from here. So fine. So basically, according to Hudson and Westlake procedure, threshold is 3 or 2 positive responses on an ascending run. Every word in this sentence is crucially important. It is 3 or 2 positive responses in an ascending run. What's an ascending run means? What is descending run? You go from high to low. All of us have done this in our second standard, third standard, arranging ascending, descending, right? Or maybe teaching our kids at this point in time. Ascending run is from low to high. Okay. So remember that it is a positive response in an ascending run. That is, we should go from low to high and we should get a positive response. So we would assume that we are doing it on a hearing impaired person. So we started at 70 dB HL. So we got a positive response. So always we decrease the intensity by 10 dB. Many of us do this thing right. Decrease by 10, increase by 5 is there in the mind and all of us do that correct. But after that, I think it goes all over the place. We'll see that. So the person responded, it is a positive response. So we would decrease the intensity and get it to 60 dB. So again, there is a positive response. So when there is a positive response, what we do? We would still decrease the intensity by 10 dB and come to 50 dB. I can see all the arrows here, it's not coming anyway. So we will do it at 50 dB. Once there is a negative, this is a negative response. When there is a negative response at 50 dB, the increase is by 5 dB. That is, whenever there is a negative response, we will increase it by 5 dB. So this is a positive response. From negative to positive, we increase by 5. Then again, because this is a positive, we increased it. Sorry, this is a negative, we increased it by 5. So here we got a first positive response in an ascending run. Now there was a positive response here. There is a positive response here. Now these two responses are not considered to estimate threshold because those are the positive responses in a descending run. It is not in an ascending run. Okay. Now, what happens if you mix ascending and descending? You have two types of errors: habituation and anticipation. Those comes in, and you get different values every time you track or every time you measure it differently. So this is the first positive response. We got it in an ascending run because here we increased it from 50 to 55, 55 to 60, which means we went from low to high, and we obtained first positive response. This is negative. This is negative. This is positive. Okay. So because we got positive now, we will decrease by 10 dB again. So we came to 50. again positive, so we came to 40. Now here negative, we would increase again in 5 dB steps. Again there is a positive. Now this positive response, this is negative, this is negative. So we increased in 5 dB step twice, we got a second positive response. So this is the first positive response, this is the second positive response. So when we get a positive, we will decrease it by 10. This is a negative response, so we'll increase it by 5 till we get a positive. So we got the third positive response over here. So we got 4 positive response. Now look at the definition of threshold. What is that? 3 or 2 positive responses on an ascending run. So we got 1 positive response at 60 dB, 1 positive response at 50 dB, 1 positive response at 60 dB, another positive response at 60 dB. So what is the threshold now? 60 dB is the threshold because we have 1, 2 and 3 positive responses at 60 dB. Okay. At 50 dB also we have positive responses 1 and 2. But this positive response is on a descending run. We are coming down. We are not going up. Okay. So that can be considered. And at 50, and over here also we have 1 positive response, but again that is on a descending run. So we have 3 positive responses, first, second and third. The second positive response is at 50 dB, but we don't have a complementary other positive response at 50, so we can't consider. So 60 becomes threshold. So when you are going from low to high, you should get a positive response, and that is considered as a threshold. Now if you use this technique, it doesn't take time at all. You may think that you have to remember so many things and all that. You don't have to remember anything. Only thing you need to remember is where I get a positive response when I am increasing the sound. That is the only thing that should be there in your mind. So at any level where you get 2 positive responses when you are increasing the sound, that is taken as the threshold. Now you repeat this on the same person any number of times again and again, you will get the same value within 5 dB of difference. It may be increased by 5 or decreased by 5, but it doesn't change a lot. But you use your technique, go back and use the same technique again. The difference will be because your technique is not consistent. Whatever in clinic you just go and do increase, decrease, increase, decrease. What happens when you increase, decrease? You also get confused at a point. Patient is totally confused at a point because he doesn't know what is happening. So finally you get a value and you repeat it. You get a different value which is like 10 or 15 dB difference from your first estimation. And just imagine when this happens for every frequency. You have 8 frequencies you have tested and you have 10 or 15 dB of difference every single time you test for 8 of these frequencies. So your entire configuration of the audiogram changes, or your the Newton average changes, or sometimes even the type of hearing loss itself might change. But if you follow exactly this technique on all frequencies every single time, the difference wouldn't be more than 5 dB. All this is clinically proven. There are a lot of research which backs that the difference that you get is minimal when you use this particular technique. In fact, you can use any of the techniques, but you have to use the same technique on every single patient, and everyone else also should use the same technique because this is internationally accepted technique. If you use that, you will get a same value. Any doubts in this? So 2 key things to remember is positive response, ascending run. When you are increasing intensity, the patient should respond, not while you are decreasing the intensity. And one of the very common thing most of us do is, okay, we increased, we got a positive response. Here, what we do is we present 3 times, 1, 2 and 3, and ask him whether he is hearing. If he says twice he is hearing, we will take that as a threshold. Even if he is hearing thrice, we will take that as a threshold. You did not give a option to the person to see whether there is a confusion or not. The threshold definition itself is a point where there is a confusion. Sometimes or 50% they should hear, 50% they should not hear. Means there has to be a confusion, so you should provide an adequate opportunity for the patient to experience that confusion, and you are deriving this threshold using some valid or a standardized procedure. The patient is undergoing some confusion because sometimes he responded at 50, sometimes he responded at 60. It is not that we are getting the same point, but because we are using a standard definition, every time we do, we will come or we will boil down to a same point because of this standard technique. The confusion is still there. The patient has undergone that confusion because that is the whole concept of threshold. But even with that confusion, we are getting a consistent value because we are using a standardized technique. Any doubts in this? So I hope once you go, this is very easy to do. Actually, it saves a lot more time than the non-standardized techniques when you use it, because there is, you don't know when to increase, you don't know when to decrease. He responds you decrease and he doesn't respond you increase, and at some points you press 3 times and ask him whether he hears or not. Then you will think that okay, this may be wrong, come back and do it again, and somebody else does it. All that time can be saved if you just concentrate on this two words: positive and ascending. Okay, so that is one thing about the thresholds. The other thing to remember is all of us have seen that the threshold is not same across different frequencies. We have higher thresholds at lower frequencies, better thresholds at mid frequencies, and lower thresholds at again high frequencies, which means ear is more sensitive in the mid frequencies, less sensitive in the low frequencies, and again less sensitive in the higher frequencies. That is mostly in the region of speech, wherever the speech frequencies are there, we are more sensitive. One of the reason for this is the middle ear resonance, or how the external ear and middle ear transfers the sound. But recently it has been shown that not only that, but even the cochlea and its innervations are also in a way supporting the speech frequencies than the high and the lower frequencies. Now this shows an electromicroscopic images of the cochlea at different points. At the apical most region, this is the apical most region. This is the basal most region. From this portion, it is shown over here. Okay. This is in the middle portion. This is also in the middle portion. So this and this is the middle portion. This is the apical most. This is the basal most. So you can see from this diagrams, the purple one what you're seeing is the hair cells. The green ones what you're seeing is the number of auditory nerve synapses. Now we have 30,000 auditory nerve fibers. Now these 30,000 auditory nerve fibers are distributed throughout the length of the cochlea. Now auditory nerves are innervating the inner hair cells. Now each inner hair cell receives more than one auditory nerve. If you see over here, the inner hair cells, the purple ones are the inner hair cells. Inner hair cells which are in the apical portion are receiving apical or basal portion are receiving less or have less green dots compared to the ones which are in the middle ones. This is from the middle or this is from the middle. So if you compare the green dots over here to green dots over here, or green dots over here to green dots over here, you will see that this green dot or this green dot is more than this or this, which means the number of auditory nerves are more in the basal portion of the cochlea compared to apical portion of the cochlea or basal portion of the cochlea. So which means in high frequencies and low frequencies, the number of auditory nerve fibers that are available is less compared to the mid frequency region. And so when that is compared, that is number of auditory nerve fibers available on this axis to the threshold, the graph that we get is exactly same as the graph that we get it over here. That is, mid frequencies are more sensitive, high and low frequencies are less sensitive. So along with the middle ear, another reason why we have difference in threshold across frequencies is because the auditory nerve innervation and the number of synapses per inner hair cell, or the number of auditory nerves in the inner hair cell is more in the middle region of the cochlea than compared to the basal and the apical regions of the cochlea. I think masking Anime sir has done. Should I be doing it? We'll skip that. I'm skipping this with a primary. One intention is masking is one of the very hard. There was a survey among audiology graduates carried out. What are the subjects they think that which is more difficult? The most difficult thing in audiology, what people rated was impedance and its the physical aspects of impedance. What you study like compliance, reactance, resistance, those things. Second was masking. So it's not only with us, but across the world. In fact, this was done in US. So across the world, everybody feels that masking is the most toughest concept in audiology. But with the advent of newer technologies and use of more and more insert earphones, the necessity to do masking is becoming less and less as the day goes. Why? Because when we are using the headphones, what happens? A lot of, for example, when you're using the headphones, the ear and the mastoid bone is touching the headphones, so the vibrations are getting transferred into the PC easily. But when you are using the insert and directly putting inside the ear, the contact area is very less, so the energy that is going into the bone is very small. So because of this, what happens when you use insert, the sound that goes from one ear to the other ear is very less compared to when you use the headphones. So the necessity for masking becomes very less when you start using the insert earphones. So because masking is hard, if you cannot learn it, you buy the insert earphones. 90% of the time you don't have to do the air conduction masking. Still you will have to do the bone conduction masking, but at least you can avoid doing the air conduction or an SRT or a speech identification masking. The bone conduction you still have to do, but bone conduction masking is slightly easier than air conduction masking. So you can still do that. If you find it difficult to understand and perform the air conduction masking, if you replace the headphones with the insert earphones, most often you don't have to do the masking unless there is a unilateral severe to profound hearing loss. Unless the other ears, the one ear is normal, other ear threshold exceeds 70 dB or plus, then only the masking would be required. If the other ear threshold is lesser than 70 dB, the air conduction masking is not required. So in all clinics, if you start using insert earphones, the mistakes that happens because of not knowing the masking properly gets reduced. And I hope yesterday Animesh sir told you masking, and you have also learned in classes. So you will not go into that category. You will know the masking, but still to save time, you can still go ahead and using the insert earphones. So that's about the basics of pure tone audiometry. One, finding out the threshold, that is the most important thing, because this is the one test which everybody undergoes. Every patient that comes into your clinic will undergo this particular test. Without this test, and none of the audiological evaluations are complete. So if you know that, a lot of things are sorted out. Any doubts in this? So we'll move on to the speech audiometry. We'll start from basics to the higher order diagnosis. As we know, the audiogram is the gold standard to determine the degree of hearing loss, to say what is the amount or magnitude of the hearing loss. The audiogram is again used to calculate the percentage of disability with which the different government benefits and all of that are given. But what the audiogram doesn't tell is, with that threshold or with that degree, how much the speech is understood by the person, or where is the lesion in the auditory pathway, or whether the person can benefit from the hearing aid or not. The ultimate goal of any of our assessment or evaluation is not to just assess and say that you have hearing problem, because when a patient comes to us, in the case history, most often he would have said, I have a hearing problem or I have a hearing loss. You spend 1 hour, 1.5 hours and tell the patient back, yeah, we did all this test, you have hearing loss in both ears, which he told us in the first minute itself. So we need to say something more than that. What the patient, as a patient, when you have some issue, what are you interested? You are interested in the solution, not the problem. Problem, you know what? I have a stomachache, I have stomachache. If the doctor says that, yes, you have a stomachache, what would you do? You won't go back to that doctor. If he gives a solution, then you go back to him. So the patient from us also, what he expects is not that he has a hearing loss, which already he knows, because of which he came to you. You have to give a solution, which is most often it's a hearing aid. In 80% it's a hearing aid. So audiogram doesn't tell about whether the patient gets benefit from hearing aid or not. If he gets benefit, how much benefit does he get from the hearing aid or not is not shown by the audiogram. For example, these are the audiograms of two different people, And the hearing aid benefit that these two people, though they have a very same audiogram, may be very different because of multiple factors. We will see what are all the factors that can cause this difference. There are two types of hearing loss. One type of a hearing loss causes loss of audibility, which means you don't hear at lower levels, but you hear pretty well at a higher levels. For example, conductive hearing loss is one such type of a hearing loss, where when you raise your voice, the person understands everything. So these type of hearing loss can be easily assessed with pure tone audiometry. But when there is a loss of clarity, or if there is a distortion added because of some sensory cell pathology or auditory nerve pathology, those type of hearing losses cannot be easily identified by a test which test only the loss of audibility. So there are two tests that I discuss under speech audiometry: speech threshold testing. I'm not calling it speech recognition threshold. We will see why it is. One is speech threshold testing. Other one is speech understanding testing. What? Threshold testing means, like audiogram, we will measure what is the minimum level at which the person can understand speech. Other one, we will measure how much the person can understand speech. Earlier, the speech threshold testing was primarily done to cross-check whether the pure tone audiometry is right or wrong, because there were no other tests like autoacoustic emission or ABR and all of that. But nowadays, we have a better technique. So generally, the cross check is not a primary thing why we would do speech audiometry. The most useful thing of speech audiometry is hearing aid fitting. The information that we get it from speech audiometry can be used to determine how to fit a hearing aid, how much benefit he gets from a hearing aid, and which hearing aid settings to use. Apart from this, you can also use for increase your billings, which would give you more money, increase your face validity, all of that. But the main thing is the hearing aid fitting. So in the speech threshold testing, let's say first is speech recognition threshold. So how would we use? Like audiometry, we have a procedure which is prescribed by book and taught in the class. But you have another procedure which we follow in the clinic. So what we do in clinic, we take up this spondyls, we start at a particular level, we will say something and ask the person to repeat it. If he repeats it, we will present at the same level again. If he repeats this, go on decreasing, like 2 or 3 spondyls you present randomly at every level, and find out minimum level at which he can respond 2 spondyls or 3 spondyls, and take that as a threshold. Again, with this technique is what is speech threshold testing or speech recognition testing. As the name threshold stays here, the same concept holds good here also. In audiogram, what was a threshold? The point where there was a confusion. So here also we should find a point where the person can recognize or understand speech only 50% of the time, and 50% of the time he should not understand speech. Okay. It doesn't mean that he understands 3 out of 2 spondyls. If you understand 3 out of 2 spondyls, at least 2 he is understanding 100% of the time. Okay. And if you use this technique again, every time you get a different speech recognition threshold values. So there is a standardized procedure which can be used to find out speech recognition threshold. And following this procedure is useful, like I said it for pure tone audiometry also. It gives very highly reliable results, and the same technique we can also use it for testing speech perception in noise. So what we do first, like how we did it for the pure tone audiometry, same procedure that we have to use. We will find out the starting level. If it has a hearing loss, you start at 60 or 70 dB. If there is no hearing loss, we start at slightly lower level. So let's say we are testing a person with hearing loss. So we started at 60 dB. Present 2 spondyls. We can use any material, monosyllables, spondyls, sentences. There is nothing called we need to use only spondy. That is why I call it as speech threshold testing. We are finding the threshold for understanding speech, or the confusion point where the person can understand speech. So let's say we presented 2 sentences or 2 words or anything. So 60 dB we presented 2 words, the person correctly repeated. So we will decrease it by 5 dB. 55 I will present again 2 words, person correctly identified. 50 dB he identified only 1 word. 45 I will present, he identified no words. 40 dB I'll present, he identified no words. As per the standard definition of speech threshold testing, we have to get 6 wrong responses to stop the testing. Now I started from 60 dB, went up till 40. So here I got 1 correct, which means 1 wrong response. Here I got 0 correct, which means I got 2 wrong response. Here I got 0 correct, which means I got 2 wrong responses. So 1, 2 and 2. We got 5 wrong responses, and this is the point where we should stop the testing. Now, how much time did I take in doing this? Maybe 30 seconds, 40 seconds, not more than this. There's just two words or 2 spondees or 2 sentences. If you're doing sentences, it will take slightly longer time. But if you use words or spondees, like you would present 4-5 seconds to this, 4-5 seconds to this, 4-5 seconds to this. In a row, you finish everything and you end it over here. This is not the threshold, but I'm saying this is the procedure. We could calculate threshold using this. I'll tell you how is this. But when you use a technique that you commonly employ, what happens? You increase, decrease. At times, you will ask for a repetition, you repeat. Generally, it takes more than 5 minutes in getting an SRT or a speech threshold in 1 year. Okay, this gets over in like 60 or 70 minutes. Now, I stopped it at 40 dB because I got 5 wrong responses. Okay, so 1, 2 plus 2, total 5 wrong responses. So how would I calculate the threshold or SRT with this? I need to know all of this information. The total words presented per level. What is the total words I presented per level? 2, correct? Every intensity I presented 2 words. Total correct responses are how many? I stopped after 5 wrong responses, but in this total correct responses are how many? 2 plus 2 plus 1, 5. Total number of words that I presented is 2, 2, 2, 2 and 2, 10 words. Starting intensity is 60 dB. And what is the step size? In what intensity I decrease the sound? In 5 dB steps. Okay. If I know this information, we can calculate what is the threshold for speech, whether it is spondy or whether it is monosyllable or words. So what is the formula? This is the formula which is prescribed by ASHA and should be using to calculate SRT, which is starting level plus half the step size minus step size into correct number of items divided by numbers in each item. This formula seems difficult, but when you apply it is very easy. Starting level is 60 dB. Half the step size, always it is going to be 2.5 because in clinical audiometer you use only 5 dB as a step size. So this entire thing can be replaced with the 2.5 minus the step size is 5 dB always because the clinical audiometers gives only 5 dB step size into correct items. You just have to count in this how many correct items the person repeated. You presented 1, 2, 3, 4, 5. In 5 items, you should know how many times the person repeated it correctly. So into 5 divided by 2, so it comes to 47 dB. So in this case, the speech threshold of the person is 47 dB. If you see this also, you can like give a wild guess saying 40 dB he did not do anything, so that can't be threshold. 45 also he did not do anything, so that can't be threshold. 50 dB he said 1 correct. 55 he said 2 correct. So threshold should be somewhere between 50 and 45, which is coming around 47. So 47 dB is the threshold. This is the recommended procedure by ASHA to find out speech recognition thresholds. Now this is taught in the class, but when it comes to clinic, we use a method which is I don't know what we should call clinically acceptable or commonly used. But again, as I said, when we do a pure audiometry, use a non-standard technique. You may be doing the same technique again and again and very highly consistent in your clinic, but somebody else will not follow your technique because this technique is your own. Okay, and there are other methods also to find out SRT, but the standard recommended protocol by ASHA and AAA, American Academy of Audiology, is this. ASHA doesn't have a standard guidelines for speech threshold test technique. Speech identification scores, ASHA has a standard material to be used, and all of that is there. For the speech recognition testing, there is no standard method as such is given, but we can follow ASHA because widely this has been tested, validated, and proven. And then the advantage of this is exactly same technique we can also use for testing speech in noise ability. Now I said one of the main goal of doing speech audiometry is not cross-checking anymore, because cross-checking we have much efficient tools. One of the major goal of doing speech audiometry is hearing aid fitting. So to fit the hearing aid, it's very important we do a testing in noise, because one of the major concern or major factors why because people reject hearing aids are they don't perform well in noise. Understood this? To perform this, it takes half or even less than half the time what you would do otherwise clinically. Only thing you need to remember is this formula, but this formula can be replaced with the standard number, because always the step size is going to be 5. You don't have to remember what is that. It is 5 all the time. Okay. So starting level plus 2.5 minus 5 into correct items divided by number in each item. Number in each item also you can fix for your clinic 3 or 2. You won't be presenting like 5, 10 and all that. That would unnecessary lengthen the test. Fine. Do you need a break now? Huh? Continue? No, they should say. Do you need a break now? Should I stop? Or we will finish it? You want to get over once and go, right? Okay. So I said the same technique. One advantage is there is a reliable and there is a consistency across clinic. Another advantage is we can use the same technique to find out something called SNR50 or to test in noise. What is SNR50? SNR50 is the point where, or the signal to noise ratio where the person can understand 50% of the presented speech. Can you click on that? From the beginning. Okay, there are some sentences will come.
You for medical advice.
Start from the beginning.
Advice. He has little appreciation of good poetry.
No, it will
The
come.
knowledge of carpentry that he
Start from the
possessed
beginning.
stood him in good stead.
All of you listen to
Future
the
I shall
sentences.
charge.
See how many sentences you understood.
In future, I shall charge you for my medical advice.
Sentence 1. Did you all of you understand? Fine.
He has little appreciation of good poetry.
Did you all understand? So sentence 2.
The knowledge of carpentry that he possessed stood him in good stead.
Did you all understand? Everyone? Sentence 3.
It is a strange thing how little in general people know about sky.
All understood? Maybe some portion you understood, some portion you did not understand.
Sky is largest extends in every country.
Understood? 1 or 2 words you would have heard somewhere here. There.
He neglects the trending charge. What does it take?
Understood? No, I don't think anybody understood. So what's happening in this test? No, let go. I think it's okay. Okay, what's happening in this test? We started from very quiet. It was not in fact quiet. It is plus 20 dB, where the noise is 20 dB less than the speech. All of you understood. First 1, 2, and 3. I think nobody had an issue. Everybody understood the whole of the sentences. 4, 5, 6, and 7. Some people understood some portion of it or heard of words here and there. So what was happening from 1st to 7? Noise was becoming louder and louder. Speech was kept at a same level. The level of the speech was not changed. The noise kept on increasing. Now, what is SNR50? We want to find out the point where the person can understand speech 50% of the time at what noise level? For example, if I present speech at 50 and start the noise from 30, 35, 40, 45, 50, 55, 60, 70. At 70, you will hear only noise, you will not hear any speech. But at 30, you will hear clear speech, no noise. But as I go on increasing, there is a point where you can understand 50% of all you will hear. If I present the sentences at 4 words, you will hear 2 words or 3 words. So SNR 50 is that point where what is the signal? All of you understand what's the signal to noise ratio, right? The difference between signal, which is speech, and the noise. So find out the signal to noise ratio where the person can understand 50% of the speech. The concept and the technique is exactly same as SRT. What did we do in SRT? Instead of noise, we had white condition, went on decreasing the intensity, find out the 50% of the point where person can understand speech. Here what we are doing, we have speech and noise, going on increasing the speech and finding out the noise level at which the person can understand 50% of the speech. So exact same formula we can use to find out this, because there also we are finding the minimum intensity level. What is the minimum intensity? Minimum intensity of speech. Here also we are finding the minimum intensity level of noise with reference to speech where the person can understand 50%. In both, the concept is same. We are trying to find the 50% of the point where person can understand 50% of the time. So in this example, what you just heard, we started at 20 dB SNR, and every one sentence to the other sentence, SNR became poorer. Noise increased in 5 dB steps. So half into step size is 5 minus 5 into total number of correctly identified words. So if you identify 5 sentences, each sentence had 4 words. So 20 would be the total number of correctly identified. Or if you identify 3 sentences completely, 4th and 5th sentences, 2 or 3 words you picked up, you just calculate how many number of words that he repeated. So that gives you the total number of corrected items divided by, there were 4 words per sentence. Every sentence had 4 words. The sentences were constructed in such a way that every sentence had 4 words. It doesn't matter, you should have an equal number of words, that's all. 4, 5, 6 doesn't matter. It should have an equal number of words. So we get a value of minus 2.5 dB. Now what does it mean? Minus 2.5 dB means the person can understand speech even when the noise is 2.5 dB higher than the speech. The SNR 50 of minus 2.5 means the person can understand speech even when the noise is 2.5 dB higher than speech. That is, the noise is louder than speech, but still the person can understand 50% of the speech presented. Now this information is very useful because now this will tell how much he can understand in noise, and if you have a 2 hearing aids, you can compare hearing aid 1 and hearing aid 2, and you can find out with which hearing aid he can understand better, or in which hearing aid you are getting a better value. Okay, I'll just give you another example. So this is one person where we got a SNR 50 value of minus 2.5. Same thing I did it on another person. This person repeated only 12 words. The first person repeated 20 words. Second person repeated 12 words. The SNR 50, if you calculate, comes to 7.5. Now what does this mean? First person could hear speech even when the noise is 2.5 dB higher than speech. But the second person requires speech to be 7.5 dB more than noise, or noise to be 7.5 dB less than speech. Then only he can understand speech. So which person is doing good in noise? The first person or the second person? Huh? First person, correct? Because he can understand speech even though the noise is more than the speech by 2.5 dB. That is why we got a negative value. Whereas the second person can understand speech only when the noise is 7.5 dB less than the speech, or he requires noise to be less, speech to be more. So the first person does well in noise than the second person. Instead of person, if it is 2 hearing aids, first hearing aid does well than the second hearing aid. If it is the same hearing aid with the 2 different processing, one is with a noise reduction, other one without a noise reduction, you can show the patient that See, with the noise reduction, this was your performance. Without noise reduction, this is your performance. Directionality versus no directionality. Any of the hearing aid benefits, you can show the patient with this technique. What is the technique we follow? Same as SRT. There is no difference. SRT, what we do clinically, exactly same thing we are doing over here also. The difference is we are adding the noise. That's all. We are finding the threshold again. Is that clear? Should I repeat? So, with this, there is another associated concept called SNR loss. Now, we had two people. One person is this minus 2.5, other person is 7.5. Now, what is a SNR loss? SNR loss is how much a person whom you are testing requires more SNR compared to normal hearing person. Let's say the first person who heard it at 2.5 dB is a normal person. So, second person whom we are testing is a hearing impaired person who got 7.5 dB as a SNR 50. Now, what is an SNR loss? How much SNR a hearing impaired person requires more than the normal person? How much he requires more than normal now? He requires 10 dB more than normal hearing person, or the SNR hearing the hearing impaired person require the difference between normal person and the hearing impaired person is 10 dB of signal to noise ratio. The hearing impaired person requires 10 dB higher signal to noise ratio to perform same way as that of normal hearing person. What information it gives? Now this gives us like how an audiogram gives us a hearing loss. What is a 30 dB of hearing loss means? The person requires 30 dB more intensity to detect the presence of sound than a normal hearing person. In an audiogram, 0 dB HL means what is the normal people can hear. 40 dB HL means 40 dB above the normal hearing person. Over here now when I say 10 dB SNR loss, which means the person requires 10 dB better signal to noise ratio than a normal hearing loss. So how we calculate degree of hearing loss, degree of speech understanding deficits also can be quantified using the same technique. Technique is the SRT or the speech recognition threshold, but we are just not extending that into all of these. Is that clear? So with this SNR loss, we can compare anything. We can compare two hearing aids, two hearing processing strategies, one CI, 1 year CI with the 1 year hearing aid. Means anything that you want to compare how the person understands speech, you can use this technique. Okay. Understood that? So that is one of the primary major thing that I wanted to talk in this presentation. So this is just an example of showing the same audiogram. Person can have two different types of speech understanding and two different types of SNR loss. This person has more SNR loss. This person has got less SNR loss. So whom do you think would benefit more from the hearing aid? This person or this person? This person would benefit more because he has less SNR loss. Like how somebody has a lower degree of hearing loss is more close to normal. The person who has got a lower SNR loss is more close to normal and likely to perform better in all management options. So you can use this for the counseling even before you decide on the hearing aids. Okay. So that's about the speech threshold testing. So we saw SRT. The concept of SRT can be extended to find out SNR 50. With the SNR 50, you can calculate SNR loss, which is equivalent to hearing loss, which we calculate using pure tone audiometry. Then in the supra-threshold speech testing, we can do all of this speech identification or recognition testing using nonsense words, and we won't go in. I won't go into details. Basically, you present and you ask how much the person understands. Another concept of speech audiometry, which is not so much used, is called acceptable noise level. Now, in all these tests, what we are doing is how much a person can understand speech, or what is the levels at which person can understand speech. But what is the noise that the person is ready to put up with? There are some people who can tolerate more noises, and there are some people who get annoyed with a little amount of noise also. So the acceptable noise level gives you a value, how much the noise the person is ready to put up with or ready to bear. More the person is accepting the noise, better is the management of the rehabilitation. So how we find out? You find out most comfortable level, then go on increasing the noise called BNL or background noise level, where the person says that this noise is too annoying and I cannot put up with this. So find MCL, find background noise level. The background noise level is nothing but the noise level where the person says that the noise level is too annoying. He cannot concentrate on speech. You're not asking whether he can understand or not. It's about annoyance. Can he tolerate the noise, or can he put up with the noise or not? So MCL minus BCL, BNL gives you the acceptable noise level. Higher the acceptable noise level, the person is a better candidate for the hearing aid fitting, or he gets more benefit with the hearing aid, and that person is more likely to use hearing aids for longer duration. So this information you can use it for counseling and hearing aid selection and all of that. Combining SNR loss with the acceptable noise level, you can divide the patients, or you can categorize the patient into. For example, if somebody has got this is SNR loss, this is ANL, y-axis is acceptable noise level, x-axis is ANL. So when the person has lower SNR loss and lower acceptable noise level, it's a clear zone, or he gets more benefit from the hearing aid. If the SNR loss is less but the acceptable noise is more, he understands speech well, but also he gets annoyed with the speech as soon as he go into the noisy area. So the counseling is one of the most important things, because he is understanding speech, but his problem is he cannot put up the noise level. So the desensitization or counseling is important. Person is ready to put up, he tolerates lot of noise, but he doesn't understand because SNR loss is more. He has problem in speech comprehension. So you can categorize, if the person is at this level, that is struggle with both, that is he has a high ANL also, acceptable noise level also, and very high SNR loss also. He has problem with tolerating noise also, he has problem with understanding speech in noise also. These are the people who are very difficult to manage with or fit the hearing aid. So you can use this information to see what sorts of problems the people might have, and counsel them accordingly or prepare them accordingly, so that they are better prepared to face those situations. I have 10 more minutes. I'll just cover one more aspect of speech audiometry, which is not very widely used. We all focus on how much the person can understand speech in speech audiometry, or SRT or SIS. But when understanding speech, now all of you, I don't know how much effort are you all putting into understand my speech. But when I talk like this, what happens? You need to concentrate a lot. You won't be able to talk to each other if you want to understand me. And you have to exert lot of effort to understand my speech. Now, if I talk like this for an hour, at the end of 1 hour, you would be very tired. I don't know whether you have experienced this or not. If you are using a mobile phone, all of you are supposed using a mobile phone. If your receiver is not working, or if it is slightly old, you will have to press it hard and hear because it is faint. Okay. Within 5 minutes, you get irritated with the person whom you are talking, because you have to put lot of effort, because the speech is not clear in the beginning, or it's not understandable in the beginning itself. You have to exert more of effort. Now this effort is called listening effort. That is the effort you put in while listening. Now why is this important? Though you understand speech 100%, now you are all understanding speech 100%, but somebody has to put more effort compared to somebody has to put less effort. There are higher chances that the person who is putting less effort is more likely to listen to me longer compared to person who is putting more effort. Because you put more effort, you will get fatigued very easily. Once you get fatigued, you stop listening. The same thing happens even with the hearing impaired listener. If they have to put lot of effort to understand and hear speech, less likely that they will hear speech for a longer time. They just switch off, thinking that this is too much for me to do, so I won't hear or I won't use the hearing aid. So measuring listening effort is also one of the use of speech audiometry. I'm not going into the details. The listening efforts can be measured with the simple questionnaires, like just asking you how effortful it was, rated from 0 to 12, 0 being no effort and 12 being mostly highly effortful. Or we can use the apps, the National Aeronautics and Space Administration. This is from US. They have given an app to measure the listening effort. There are dual task paradigms. That is, I can ask you to do two things. Maybe what we can do is I ask you to understand speech, as well as I'll ask you to sort out some flashcards based on colors or based on animal, or take out only the animal flashcards or something like that. So when I do that, what happens? When you put more effort, you will likely to make more mistakes on this sorting out the flashcard, because all of your energy and focus would be towards understanding speech. If the effort is less, you would do better in this task. So doing two tasks and seeing what is the effect of listening on the secondary task. And there are physiological measures like pupillometry and all. Like when it is said that, it is shown that when we listen carefully or put more effort, pupils will dilate. Like when the darkness is there, pupils dilate. Same way, when you concentrate and put effort, pupils will dilate. So measuring the enlargement of the pupils with an instrument. So all of this we can use it for the measuring the listening effort. So finally, so this SNR loss, acceptable noise level, listening effort, and one more thing that I didn't cover is the working memory. All of this in tandem together would decide whether the person is happy with the hearing aid or not. Of this working memory is a different thing, but 1, 2, and 3 all can be done with the speech audiometry, not with the classical speech audiometry, just an extension of speech audiometry. So speech audiometry, which was initially started for cross-checking, has extensions in lot of management and rehabilitation aspects of individuals with hearing impairment. Now, other use of speech audiometry is diagnostic testing. I am not doing this. The all APD test also an extension of speech audiometry, but that itself is a one big presentation. I think that would be too much. So speech audiometry is not merely checking SRT and SIS at 2 level. Even checking SRT is very useful in both determining threshold and determining the hearing aid usefulness, which hearing aid, what signal processing strategies, and all of that. Thank you. I have finished 10 minutes.
Sir, in speech threshold testing, no, sir, you gave the formula. In that into step size, you put it off into 5, but while calculating it changes 0.4 in the slide.
Yeah, maybe it's a 2.5 actually.
Okay.
It's not 0.
Any other questions from any group?
Rounded or flat, so that can indicate miliar diffusion, but in that case static compliance should be lower than the normal value. Ear canal volume should be normal. If it is not, means there is no perforation as such, then tympanic width, if it is rounded AS type or CS type, usually you will have wider tympanometric width, and RF will be very low to about 250 to 300 hertz. Okay, these are the certain publications which they have made, like with the sensitivity, how much sensitivity is there for this. If you use tympanometry as a criterion for differentially diagnosing condition. Then ossicular chain discontinuity, we saw this, usually we get AD type. Okay, there it was AS type or CS type, and here it is AD type. So sharp peak with higher admittance value. Static compliance is high, ear canal volume will be normal because tympanic membrane is intact or thin at least. Then width will be very narrow because the height of the tympanometric tympanogram increases, the width, because you are taking half the value, so the width will reduce, it will be narrower. Then RF will be lower again because this is like more like in stiffness dominated pathology. In effusion, we usually see under 500, but in this discontinuity, we'll see somewhere between 500 to 700 hertz. So that you can use it as a differential diagnosing tool to differentiate that. Obviously, the static admittance would clearly differentiate what kind of pathology it is. One is very low and the one is high. then you can use resonant frequency to differentiate whether it is just the tympanic membrane issue or it is actually what OCD is there. Then moving on to tympanic membrane perforation, as we told, it is more likely to be a flat. There is no peak. Ear canal volume will be either normal or usually high whenever there is perforation. But very long-standing CSOM condition, you can see tympanic membrane being perforated, but still because of some growth of like cholesteatoma which is started to grow, you can still get normal ear canal volume. So B type with normal ear canal volume, but perforated TM is possible. Okay, only thing is the usual complaint that they tell is the infection is existing from more than 5 years or 10 years, or post-surgery failure there is a perforation. In such conditions, you can see such conditions where perforated TM without increasing the ear canal volume, you can get B type. Obviously, if the ear canal volume is high, it can clearly indicate there is an infection which is there present and tympanic membrane is perforated. Then cholesteatoma is basically a growth which will come from the inner part of the middle ear and it will grow towards the tympanic membrane. It can perforate tympanic membrane. It could also cause due to complications of otitis media. In such condition, peak is reduced. That is, AS type or CS type is usually expected. And because of that, static admittance will be very low. Ear canal volume usually will be normal, and tympanic membrane width will be wider. As I told, it takes more energy to reach that low or high values. So width will be more, and RF will be again low, and it will be equivalent to like somewhere around 200 to 300 Hz. Okay, in this condition, usually people get confused to whether to take it as B type or CS type. So where okay, something like this. So you can still record some amount of static admittance, but this is more or less like a B type. Okay, so this is a possibility in cholesteatoma condition. So then tympanosclerosis is basically a scaling on the tympanic membrane where you can have normal middle ear functioning, okay, where peak can be reduced or normal. Static admittance is normal or low, AS type or A type is possible. Then ear canal volume is normal because tympanic membrane is intact, and width will be normal, and usually you will see scaling on tympanic membrane. Which will help you to diagnose tympanosclerosis. So in this condition, you can basically record A, AL and AD type. All of them are possible. I told that whether it can be normal or reduced, but there can be possibly like just marginally higher value of static compliance. That is 1.7, 1.8. That's the level you can get. But thin tympanic membrane with sclerosis is the usual condition in such cases. Then otosclerosis, reduced peak with with low static admittance, and ear canal volume will be normal. Tympanometry usually will be normal if it is otosclerosis. Very rarely, that is very advanced conditions, if you are going, you can get narrowed down, or it can go totally flat at at the very later stages. Okay, but only thing is higher resonant frequency is an indicator to differentially diagnose between the other conditions where you got static admittance lower with normal width. How to differentiate? You can use resonant frequency. Usually occurs in ossicular fixation or any kind of condition which can cause stiffened middle ear system. So this is like pinhole perforation. Means this is the otoscopic examination, and this is the pattern that we usually record in pinhole perforation. So there is peak which you see, and your values, all of them will be normal. It is technically it shows A or AS type of tympanogram, but you will start recording this jagging at extreme pressure. If you change the direction, the jagging shifts to the other direction. So when we saw one of our cases being recorded, usually this looks like this in when you record. Okay. This is another condition where it is petalous eustachian tube or glomus jugular tumor. basically this when we did the tympanogram in faster rate, we recorded this normal width. So whenever patient complains that his own voice is heard louder in such conditions, or he is feeling that tinnitus, pulsatile tinnitus, it is mandatory that you run a tympanogram with very slow rates where you can record these kinds of jacks, okay, which will indicate glomus jugular tumor, okay. But when you hold the breath in Petrus eustachian tube, this will be normal. There is no gyring. But in glomus jugular tumor, even if you hold the breath, it will be this pulsation will be there. So, can you just play this video? This is glomus jugular tumor in one of the conditions we try to record. This is basically pulses which were coming, blood pulse rate of blood circulation that we recorded in TIM. But very low rate, that is 50 dapa per second, we could record this one. So when we recorded from the opposite direction also, we recorded the same thing but in the opposite direction. You can see this peak. Here also peak is there. But only thing is in the outer rates, we will record this child. This is again B type. The instrument is showing B type here with volume of 1.6. When we saw it was pinhole perforation, basically. So only in the extreme negative pressure we got the peak, but at the end there was a jagging. This is like example, like you could see that jagging in the first stage. Jagging is too much in this kind of pattern, or in this video how we recorded, only one or two jaggings can also be seen. Then you can use this tympanometry even for differential diagnosis of eustachian tube dysfunction, or it is functioning of the eustachian tube is normal or abnormal. Basically, we saw if you are if you are getting C type, it indicates eustachian tube functioning being affected. But technically, if he swallows and it becomes normal, C type to normal, you can basically consider it as normal ETF. But only if there is no shift even after swallowing or blowing up the in Valsalva or Mani when you do the manual, then we can conclude it as eustachian tube dysfunction. So at least minimum of more than 10 decapascal change is expected to take it as whether eustachian tube is functioning normally or not. So this is the baseline deflection. This is the baseline we saw, and when we inflate, that is building up the positive pressure, will shift the peak pressure to positive side. When we swallow, it deflates, which will shift the pressure to this thing. This indicates normal functioning. When this does not happen, you can conclude it as eustachian tube dysfunction. So basically, again, it is with ETF functioning. So whether it is normal compliance or reduced or increased compliance, you can conclude ETF functioning whether it is normal or not. But if it is CS type, it is more likely to be a case of middle fluid. Okay, if it is C type, it is just the middle eustachian tube dysfunction, and if it is CD, then usually there is a healed tympanic membrane along with eustachian tube dysfunction. So that clarity also you will get if you are getting different patterns in C, CS or CD. So problem with just doing with one particular frequency is that even though majority of you could differentiate different conditions, but you cannot pinpoint. If you just look at unless until I told you that the resonant frequency was increasing, that means unless until you do at multiple frequency, you will not be able to conclude what exactly, because AS type can occur in 3 different, AD type can occur in 3 different conditions, A type also can occur in normal and abnormal conditions. So now just doing at one particular frequency, it can mislead your diagnosis. So then for that purpose, you can use multi-frequency tympanometry, where measurements are done at different frequencies from 200 Hz to 2000 Hz. There are we usually take it as two different components. We usually take it as Y in standard low frequency, but when it comes to multi-frequency, we'll split up the values into B and G separately for clearly understanding how is the functioning of the medium. So in multi-frequency interferometry, it is basically either you can use sweep frequency or sweep pressure. So technically now these two are gone. They have started using in both the conditions. They used to use probe tones of different frequency. Nowadays they have started using click as a stimulus so that they can finish up the testing. Testing time is reduced by almost 1/10 of it. Okay, and you can measure the values much quicker without risking the without making the media multiple times. So in multi-frequency to differentially diagnose, you can use this Van pattern, that is BNG patterns, and resonant frequency as an independent value, and phase angle at 45 degree, at which particular frequency this 45 degree occurs. So we can differentially diagnose different conditions. We just see different all of this. Basically, different patterns that you are going to get at in which particular frequency you are going to get these patterns will help us to differentially diagnose whether it is stiffness dominated or mass dominated pathology. If you are getting this pattern at normal frequency 226 Hz, it is normal. If you are getting same pattern at 1100 Hz, it is abnormal. It indicates otosclerosis. Okay. So, and if you are getting this pattern at very low frequencies at 500 or 400 Hz, it will indicate oscillatory discontinuity. And if you are getting this pattern at 200 Hz or 300 Hz, you can conclude it as otitis media with the fusion. Then this is 3B. This is 1B 1G we call it as, and this is 3B 1G, and this is 3B 3G. And this is 3B 3G again. It's 5B 3G, which is the most complex pattern that you can tell. Okay, so only thing is at which particular frequency these have happened. This is the normal values. You can get up to 560 Hz 1B 1G in normals, and 1000 Hz you can get this 3B 1G, and 1250 you can get this 3B 3G. And after 1600 you will start getting this very complex pattern. So this is a normal routine frequencies at which you will get. If these are occurring at very low frequencies or very high frequencies, it will help you to differentially diagnose whether it is condition of stiffness dominated pathology or mass dominated pathology. So next, moving on to resonant frequency. So basically, this is the frequency at which B value, that means susceptance value, because we are dividing this one as susceptance and conductance. Whenever this B value becomes 0, we consider that particular frequency as resonant frequency. So that is the frequency at which our medial vibrates at its maximum. So if you are measuring some value at a particular that particular frequency, it will help you to differentially diagnose, again to differentiate whether it is mass dominated or stiffness dominated pathology. So this is like with sweep pressure, if you are measuring different means at different frequencies. So this is measured at 1000 Hz, which is 3B 1G pattern, and we have got resonant frequency of B becoming 0 at that particular frequency. And these are different conditions. This is occurring at 1500, which will indicate otosclerosis. And this is the pattern that you get in 3B 3G at 1500 Hz when you do. And this is again 1050, it's a normal milia. Okay, where resonant frequency occurs at that particular frequency. So this same pattern will be repeated at 1050. So if you repeat at 1500 Hz, then definitely this pattern will be more complex, which will be 5B3G pattern. So again, means we saw that resonant frequency is a frequency at which susceptance becomes 0, but when susceptance and conductance becomes equal, we take this particular value as F45. Okay, again it's a frequency value that we take, and what they have found is like when compared to normal to otosclerosis ear, usually IF45 occurs at a higher frequency when compared to normal ear. Again, it is like either you can use resonant frequency or F45, but resonant frequency is more handy and directly it can be measured in many of the commercially available tympanometers. Then these are the normative values of when we use sweep pressure and sweep frequency. The range is between 400 Hz to 870. Anything less than 400, and of course there are this is sweep frequency method, and sweep pressure it is between 355 to 68. So this is again this is MFT of otitis media, which has occurred at 226 Hz. This thing. So when we did it at different frequencies, means they have did it at different frequencies, 500 Hz in right and left. So right is otitis media and left is normal. So 500 Hz showed 1B, 1G, but otitis media showed 3B, 1G at the same frequency. And this complex pattern at 1800 Hz when we saw it was just 3B, 3G, but it was all flat. It was becoming B-type in case of otitis media. This shows just that resonant frequency is reduced. Okay. So then otitis media, again it's the same, means you can correlate with audiogram with tympanogram results, and the pattern at which 678, this is otitis, both are otitis media with high frequency tilt, that is OCD with otitis, just otitis media. This is affected more. So then this is like ossicular chain discontinuity. So this is just the tympanic membrane pathology, that is healed tympanic membrane or thin tympanic membrane versus OCD. You can see this is like hearing loss is lesser, there is no ABG, and here a huge ABG is there. So if you compare to 678 Hz multi-component, you will see very complex pattern, but here you will get 5E3G. So basically, to check on these parameters whether you have done it rightly or correctly, that is selection of correct tip size is one of the important thing, and then repeat tympanometry after swallowing or yawning. If in between, if patient swallows, coughs or yawns, it is always better to repeat them. Then if you use along with otoscopic examination, audiometry, that especially the ABG and presence of acoustic reflex, then it will help you in a better way to differentially diagnose. Okay, if you just use tympanogram, you might end up confusing yourself to under which particular pathology you want to put that one. And so if you just use tympanometric values as a diagnostic criterion, again you might fail to differentially diagnose between normal and pathology also, especially otosclerosis or tympanosclerosis. If you just look at the TIMP, you might get confused like it is normal. So just compare it as we saw in the previous point, that all the other things also should correlate. So basically, can we identify and can we differentiate mass and stiffness pathology, and can we differentially diagnose among different mass and different dominant mass dominant and stiffness dominant pathology? Can we precisely identify and differentiate different pathology? Is the thing that we saw in the previous slides. Basically, we can do all this with the help of other parameters. It's just not one parameter, you have to use multiple parameters. Then only actual utility of the tympanometric measure would be more effectively used. Any questions?
Good evening, sir. First of all, thank you for that beautiful presentation. So I have one concern, which is like in different clinics we use different normatives. Different clinicians are using different normatives for tympanometry, classifying the patterns of tympanometry. So with that, there can be a different opinion on like for one patient, I might diagnose it as according to whatever normative I am following. I might diagnose it as maybe AS type, and maybe another person who is using another normative, they might classify it as A type. So there can be different opinions on the classifying tympanometry. So and the normatives that we are using is based on the Western norms and like and the ear canal volume and the admittance can change with respect to races. So wouldn't that cause a conflict between whatever findings we have?
So that's what we saw. In majority of the conditions, we could see normal being got, means normal person getting AS type, A type or AD type, whatever. But the main parameter was, other thing that we used was the audiogram, what you have got, and correlate it with the reflex, whether you are getting or not, and the complaint and otoscopic examination. That will clear up the doubt. Whether it is A or AS type is not the problem there. You can put it as AS type, whether it is 0.3 or 0.5 to differentiate whether it is AS type, that's not an issue at all. Basically, if the hearing loss, there is no hearing loss, no complaint with normal TIMP that you see, and reflex being present, whether it is AS or A type, you are going to diagnose it as normal mid-ear functioning. So at the end of this thing is whether mid-ear is functioning normally or not, whether it is affected is what is major thing. Which particular type you are quoting is should not matter a lot. So just having like 0.6, 1.6 is the condition. Okay, next it is AD type. If you are taking that, but if reflexes are there, even though it is AD type, you can take it as normal function.
Thank you, sir. My second question is, out of all the audiology equipments that we use, I think the tympanometer is one equipment that goes out of order very frequently. So, since this conference is about bridging the gap between practical and theory, I want some of your guidance on how, as a clinician, how can we manage the issues that we faced with respect to the tympanometer technical aspect?
It depends on what exactly the problem is. Usual means what we see it in training institute is basically wax blockage, or the probe is not cleaned regularly, or regular calibrations are not done in terms of admittance and other things. Usually they will give a cavity which has to be, the calibration has to be done regularly, so that admittance calibration is done, so that you can measure, means you can maintain the equipment in a right way. So other than that, if there is any problem with the pressure unit or in the control processing board or something like that, you just have to replace it. There is no repair option at all for that.
Sir, because most of the time, getting a technician, requesting them for a visit to look at the equipment, and all those takes a long time. And as a clinician, how can we troubleshoot if they are not available?
So technically, you just have to usually inspection is one thing, and doing the admittance calibration the other things. If these two can solve your problem, you can sort it out. Otherwise, it has to be sent for the major repair.
Thank you, sir.
Sarga, with respect to the type of tympanogram and the normatives, I think when we start in the second year bachelor's, we understanding the normatives and the type of tympanogram is important. But as audiologists, we should stop looking at the type of tympanogram and interpreting the results. We should look at what is the gradient, what is the static admittance, what is the peak pressure. Okay, so it's only for others to understand the tympanogram results that we have different types of tympanogram. Otherwise, for an audiologist, what is important are the specific values, admittance values, peak pressure values, ear canal volumes. Yes, there are some differences in terms of the ear canal volume because of the head size and all, but in terms of the static admittance and peak pressure, there are no big differences. At least not to the extent that changes the clinical interpretation between the Western studies and the Indian studies.
It's okay. This introduction is there. Yeah.
Learning is a lifelong thing. There is always something new to learn. We have Dr. Arunraj sir to talk.
Sir has completed his PhD in Audiology, MSc in Audiology, and BSc in Speech and Hearing from All India Institute of Speech and Hearing, Mysore. Highly accomplished audiologist offering extensive expertise in clinical audiology and communication disorder prevention, having earned a distinguished 14-year tenure at the prestigious All India Institute of Speech and Hearing. Throughout Sir's illustrious career, Sir has demonstrated a strong commitment to excellence by actively participating in intramural and extramural projects, 10 proceedings, 14 publications, 35 presentations, and conducting groundbreaking epidemiological research. Sir has been invited to 72 talks and has been an eminent speaker for 14 conferences. Sir's passion for enhancing the quality of life for individuals experiencing communication challenges has driven him to make significant contributions to the field, possessing a solid foundation in audiology and an unwavering commitment to driving impactful change. I request Dr. Arunraj K to enlighten his ideas on the topic, application of wideband tympanometry in diagnosing middle ear pathology. We welcome you, sir.
So I move on to the topic here. So, guys have understood about the power of tympanometry. Whatever we thought now. As Ajit sir morning itself said, it's the most difficult topic, the emittance and the masking aspects. To look into the concept, because if you ask me, to be frank, for me also emittance was one of the big challenge. When I was taking the PhD also, I was thinking so much that, oh, emittance, I hate the topic, to be frank. So but finally I fell into the PhD of doing an emittance and on the wideband observance tympanometry. I am forceful to learn the concepts of emittance. That's the, maybe I don't know, it's fortunate, unfortunate how it's going to be. So more to it, here the applications of wideband observance tympanometry in diagnosing a middle ear pathology. So what I wanted you guys to know about is the stiffness and the mass dominator. So guys know about the stiffness, what is going to happen for the stiffness dominator system and the mass dominator system, and with respect to the frequencies. You always know about it. What will happen to the stiffness if it's the stiffness dominator? What is going to happen with the low frequencies and the high frequencies? If you understood the concept of this, then the wideband observance tympanometry is going to be very easier. And compared to the tympanometry, standard tympanometry and 3B, 5G, 3G, 1G, 2G, all those things, more than that, this is going to be much more easier if you understand the concept of the the stiffness dominated and their relationship with the frequencies. Okay. So I'll come to the inner sides will be there. So remember that the mass dominated, stiffness dominated, low frequency, mid frequency, high frequencies. So these concepts you understood it, then the wideband absorbed tympanometry is going to be much more easier for you guys. Okay. That we are measuring it. And how much energy is reflected back is that what we want to measure. Right? Next slide. Yeah. So this topic, what I want to look for is the observance. The major focus will be on the observance, that is the observance or reflectance. And I want to talk about what exactly it is and then the how it differs from 226 Hz and multi-frequency tympanometry. The other one is the norms of WBT. I just touch it because that's not so well established as such. So I just have a brief about that and the clinical application, which is the major one. Okay. So observance or reflectance. As I said, the amount of energy transferred or absorbed by the middle ear. The amount of energy which is entering into the middle ear is being measured. That is called observance. And if you want to measure the reflectance, the amount of energy which is getting reflected back, hitting the tympanic membrane, and what is the energy getting reflected back, that is going to be the reflectance. So the observance is nothing but the observance, the amount of energy going inside the ear divided by the actual original sound which has been given to them. That becomes the observance. While the reflectance is amount of energy reflected back by the original sound. So that becomes the reflectance. So it is just exactly opposite of it. Observance is just exactly the opposite of it. So 1 minus observance will be of the reflectance. And majority of the equipment which is been available right now measures an observance, not the reflectance. Okay, even if you took the tympanometry, 226 tympanometry, though we call it the impedance or whatever it is, we actually measures the admittance, how much energy is going inside of it. Okay, so that's the same concept is going to be there. The main difference between the 226 tympanometry, where we measure the compliance or admittance of it, where here we measure the observance or reflectance part of it. The major difference between these two is this. The compliance is have a unit. This is being measured by the amount of volume that is being changed with respect to the pressure. So it is being measured in either the ml or cc component of it, cubic this one. Whereas observance we could do it is the logarithmic scale. So it is measured in the logarithmic scale. There is no unit as such. There is no unit for observance. As you say, 1.5 to 1.5 cc or say in the compliance part of it, whereas observance doesn't have a unit. It is an arbitrary value where you have measured from 0 to 1. What do you mean by 0? What do you mean by 1 is 0 indicates the maximum energy is getting reflected back. That indicates 0. As you move on to the higher value, the maximum energy is going inside the middle ear. That becomes 1. So 1 indicates most of the energy is going inside the middle ear. 0 indicates most of energy is reflected back. Okay, so your value ranges from 0 to 1. Okay, so it's the observance values. Okay, so you have n number of terms is used in the literature. We look at any of the articles. You have the ambient reflectance, then WATF, WBR, wideband energy reflectance, power reflectance, transmittance. So there are power transmittance. So a lot of the terms have been used in the literature. You look for is searching of articles, something like that. So all of them are going to be said. It has an observance, wideband observance or wideband reflectance of it. Okay, this I already told it. So it ranges from 0 to 1. Whereas compliance we look into it, it is 0.5 to 1.5 is a normal range. It should always be known about it. So it's measured in the unit where observance doesn't have a unit at all. Okay. So why do we choose wideband observance rather than the 226 tympanometry? The first question was there is a lot of difference in the normative values is being there. And when Dr. Sharath was presented that time, he already said you have A type with so much of pathologies, AS type with so much of pathologies, AD type with so much of pathologies. You have 4 to 5 pathologies which comes with the same A type or AS type or AD type. So we may not know what exactly the pathology of it. Second thing is until unless we correlate the Puton audiometry and other findings of it, so we'll not come to know what exactly the pathology behind it. Okay, so that is the most the disadvantage of having a tympanometry aspect. So it has though it is widely been used, the accuracy in identifying the pathology is less, and there are a lot of overlaps between the disorders. The types are being overlapped between these things. And when you go for multi-frequency tympanometry, it's much better than the single frequency tympanometry in identifying the pathologies, especially the otosclerosis cases or OCD, stiffness or mass diameter system. But here it goes till 2000 Hz, and majorly it is being beyond that, it is going to not give a valid measurements of it, and the standing waves is going to affect the responses or the functioning of it. Okay, and then we don't have as standard calibration for a multi-frequency tympanometry, especially beyond those frequencies of it. So there's a limitation even for the multi-frequency tympanometry findings of it. So there are a lot of misdiagnosis happening with the impedance measurements, and until unless you are correlating with the audiogram, all those things, you'll be able to get the better one. But if you use a wideband observant tympanometry, which has been there, which has been the recent boom in the audiology field as of now, gives much better sensitivity and specificity in identifying the disorders of it. Okay? So these are advantages of having it. One is it uses wide frequencies. So if you look at the 226 tympanometry, it uses only either 226 Hz as a traditional tympanometry or the multi-frequency tympanometry from 226 Hz to till 2000 Hz, right? So whereas in the wideband observance tympanometry, we uses the wide frequency range, either chirp or at the click stimulus. These are two stimulus which has been used in the wideband observance tympanometry, and it is fast. It is just a fraction of a second. You will get all the frequencies observance values across the frequencies. And the most advantage of having a wideband observant tympanometry, even without building a pressure. You guys all know, right, that without pressure we cannot measure the impedance, right? Here, even without the pressure, we can able to identify do a tympanometry, okay? And the sensitivity is much higher, and the probe placement doesn't make much sense. Doesn't affect the values. The other one is the no interference of the movements as such. When you are having a movements or imagining responses as such, that doesn't have much variation in your wideband observance values of it. So this is the major advantages of having a wideband observance tympanometry. And the other one is the every frequency, every test which you are using it starts from 250 Hz to till 8000 Hz. Whereas the tympanometry is the one which always focus on one particular frequency, as 226 Hz. Where this wideband observance is going to fulfill that by taking the values across the frequencies from 250 Hz to till 8 kHz. Okay, so these are the properties of it. As I said, the click is being used for wideband observance tympanometry. The bandwidth, that means say the frequency we measure from 226 to 8000 Hz. The intensity is a fixed intensity from 65 dB, and the pressure as usual. The remaining is going to be the same. Pump speed is going to be almost same, but the number of stimulus here, because we use the chirp stimulus, it is going to be, the average is going to take is around 32 stimulus per second, and then the repetition rate of 21.5. It's almost like an ABR. When you're doing an ABR, you have a repetition rate and averages, right? Because the chirp stimulus will not be a long-standing one, so have the click or chirp stimulus, so you have the number of stimulus here as well as the repetition rate of it. Okay. So these are the equipment which is being used as of now. These are the research equipment. The first one is Mimosa Acoustics, which uses the term transmittance there. They uses the term transmittance for the term observance. Okay, and the wideband acoustic emittance by the intra-acoustics, which they majorly uses observance as a term there. Okay, so these are Titan which is being used there. It's the Autostat which is being developed by the Mimosa one. So these are two available equipment as of now, and JSA Timstar also has the wideband observance tympanometry recently has been introduced part of it. Okay, so this is how the wideband observance graph looks. Okay, Sam, just play them. Only this one. It's more of kind of the colorful graph, 3D graph, looks so amazing. Okay, but it has a lot of information inside it. It doesn't have just only the 226 tympanometry of it. It has the response, to be frank, if you look at the 226 tympanometry, a compliance of 250 Hz, 500 Hz, 1000 Hz, 1500 Hz, 2000 Hz, so all the admittance values will be recorded through this one particular graph of it. And if you look for the two-dimensional one, the graph look like this, start from 250 Hz to 8000 Hz. Okay, this is the observance graph of it. Okay, till now any doubts? Clear? Fine. So in this graph, we look into it, the low frequency, the mid frequency, and the high frequencies. Okay. Now you guys tell me what will happen at the low frequencies. Usually what happens, sir? Why energy is going at the mid frequency region, not at the low frequency, high frequencies. The resonance frequency, majority of energy in the mid frequency region, the phase cancel out, both mass dominated and the stiffness dominated equals in the mid frequency region, both get cancelled out and most of energy get transferred to the middle ear in the mid frequency region, whereas the low frequency region is a stiffness. Stiffness play a major role, so it reject the low frequency sound, so majority of the energy is getting reflected back in the low frequencies. Similar the high frequencies, which is more of the mass dominated, so mass play a major role of it. If you understood this concept, your white band is going to be easier. So it is the low frequency stiffness, which is getting reflected back. High frequency is a mass dominated, mass effect, so that gets reflected back. The mid frequency, both mass and the stiffness are equal, so it get cancels out, so you get maximum energy is going inside. Okay, the morning presentations. These are so at lower frequencies, the impedance is much more because of the stiffness. At high frequencies, the impedance is much higher because of the mass. In the center, the mid frequency regions, the maximum gate both get cancelled out. Okay, this is the wide band observer's pattern. So you are able to measure both stiffness dominated, mass dominated, as well as the maximum energy which has been reaching into the ear. Not just the 2-digit tympanometry, it only measures the stiffness dominated for adult, and for 1 kHz, which is the mass dominated for infants. It measures both stiffness and the mass dominated one. Okay. And morning, if you look into the graph, yes, Dr. Ajit sir has told about the physiology behind the human audiograph, the thresholds level, right? So he said the inner ear, where the auditory nerve fibers are maximum in the mid frequency regions, low frequencies and the high frequencies has a limited nerve fibers, right? But doesn't start from there. Okay. Maybe I being the white band, whatever it is there. So it starts from the outer ear and middle ear itself, where you have here the stiffness and the mass dominance is going to control the amount of energy which is going inside the inner ear, transferred to the middle ear and the inner ear. And the resonance frequency of the middle ear also contributes some amount to the passage of the mid frequency regions of it. Okay. Apart from that, the physiology behind the outer nerve fibers also plays the role about it. So the amount of energy reflecting back starts from middle ear itself. That's why even the curve, look into it, the human audiogram, MBP, F curve, the first BSc have read that. The pattern, if you look into it, does it look the same? Almost same, right? So it's exactly a replica of the human ear which has been responding for frequencies across the frequencies of it. Got it? Clear? If you don't understand, let me know about it. So low frequencies, high frequency, mid frequency, if you understood that, then we'll move on to each one of it. So why don't observe some, I just move on with the much faster. So one of the study by Shanas is the pioneer in the wideband observance implementing. A lot of studies has been done by him. So here I didn't check out whether these establish normative data and then to try to check whether there's a significant difference between the gender, year and then instrumentation and the race, all those things. So what he found was between the ethnicity, there is no much difference between, there is a difference between the different Chinese population and Caucasian population. Okay. Whereas if you look into the gender, there is no much significant difference. Okay. And then similarly with the equipment wise, mimosa and intracost doesn't have much significant difference. Similarly, the peak pressure and ambient pressure, that has a slightly significant difference in the low frequency regions. Okay, and he established normative values. So look at normative values. These are normative values which has been taken out there. Okay, you can see the peaks here. Got it? This is a peak here. So you have 1 kilohertz and 3 kilohertz. So around that region you have so 1 kilohertz and the 3 kilohertz you have a major peak which is being seen in the part of it. So the mid frequency region, majority of energy is going inside the ear. Or low frequency, high frequency is getting reflected back. So this is a normative peak which is being seen. Okay, normal peak. There is no values as such for an observance. Look for the pattern rather than going for the values of it. Okay, as of now. Okay, so this is my PhD work which has been done, similar kind of thing. So you look into the ear, right ear and left ear, there is no significant difference between these two. Similarly for the gender, doesn't have any significant difference. Whereas look at the peak pressure and the ambient pressure, there is a significant difference in the low frequency region. the low frequency region has a slight significant difference of it. So your normative will be such a way that there is no specific normative for ear, gender, or the equipment wise. It's a common normative has been established. But any research to look into it, you always have a normative or a peak separately for a peak pressure, separately for the ambient pressure. Because there is a significant difference between peak pressure and the ambient pressure, especially at the lower frequency of it. Okay? Okay, so you should look into it. The difference you look into it for any of the research articles you look into it, they mostly focus on the race, the ethnicity, and the pressure aspect. Pressure in the sense peak pressure versus the ambient pressure of it. This is the one thing. The other one is the test retest reliability. Look at the test retest reliability. If you do n number of times with wideband observance tympanometry, that doesn't make much difference. Okay, so even though the first trial, even at the ninth trial, there's no significant difference between those two trials. So this is a study done by Sun, Zio means Sun. If I'm not pronouncing correctly, you guys pronounce yourself. So the Sun who has been done this. So there is no significant difference between the trials. He has done 9 trials and there is no significant difference between these trials. So the test retest reliability is very good, especially in terms of wideband observance tympanometry of it. Okay. Similarly, my study also looked into whether the flat line indicates the test retest reliability of it. It is almost at a straight line, so there is no much difference between these two of it. This is one of the added advantage of it. Okay. So the test retest is also not a problem at all for wideband observance tympanometry. The other one is the insertion depth. So usually people say, I also said the first slide that insertion depth doesn't matters a lot. To be frank, matters a lot. There's a study done which the insertion depth was being given from 8 mm to 28 mm, which is almost near to the tympanic membrane. So they found that the more inside the tympanic membrane, the placement, the graph is going to be much more easier, okay? Better one. Whereas when you have a towards the cartilage region or something like that, cartilage region, where placing it just placing above the ear canal, your low frequency is going to get affected part of it. So that becomes the that might reflect that person might have a medullary dysfunction or medullary pathology of it. Okay. So until almost 14 mm we can go for it. So more deep in the insertion, you have a better wideband observance tympanometry. Okay. Similarly, ear leak. So here the advantage is ear leak is not a major problem because we are able to measure even without the peak pressure. We are measuring even with the ambient pressure condition. So ear leak is not going to be a significant factor. But they also done the study stating that they have done the probe has been placed. They have started making a small hole with the number of sizes. One is without any leak. Other one is 0.01 inch hole has been made. And according to it, there are a lot more holes has been made in the probe, and they checked out the changes in the medullary, the observance values across the frequencies. If you look into it, the low frequency is going to get affected when there is a ear leak. Okay. So ear leak is also one of the major factors we are doing in wideband observance tympanometry. Okay. So better thing is use deep probe insertion you are doing in wideband observance tympanometry. Otherwise, it's going to affect the wideband observance results. The other one is a good fit is also an important factor for it. So these are two things. Okay. Just a glimpse. I doesn't want to move much into it now. On the main topic of it. Okay, we have hardly some 5 disorders we have it, major disorders. Okay, so hypermobile ear drum, monomeric memory, a single ear drum. So what will be the emittance? What research will be getting it? A type, AD type, C, A type, AD type. Okay, group 2, ADD. Okay, ADD. Actually, what happens? Is it stiffness or the mass? Stiffness, going to be stiffness, single membrane. Right? So it is more, the stiffness is not going to be a major factor here because a single membrane, so you don't have flexibility, elasticity of it. So more mass is going to contribute for this. Okay, so that's the reason your most of energy is going to be inside because it's not stiffness control at 226 watts. So most of energy is going to be inside. So what will be any type? Okay, so what will be the observance values? If you look into the low frequencies is a mass dominator. So what is going to happen? The observance is going to be increased at low frequencies or decreased? Increased, low frequency increased? Yes? how the pattern is going to be. Exactly. The low frequency is going to be increased because you see the pattern, normal pattern is going to be at the mid frequency regions. If you look into it, since it's the mode of mass dominator, the low frequency is going to be increased. But it's not purely of the exact mass dominator. Okay, some amount of stiffness will also be part of this. Okay, this is what is going to be the hypermobile membrane, where your region is going to be the maximum energy is going to happen at 500,000 hertz, which is the maximum peak or the maximum energy is transmitted to the middle ear. Whereas high frequencies, there is no much energy which has been transmitted inside part of it. Okay. The other one is also shape discontinuity. This is also going to be stiffness dominator or mass dominator pathology. Mass dominator pathology. So what is going to happen here? Again, you get an 80 type of tympanogram. The resonance frequency is going to be reduced for this the OCD pattern, right? What about the observance? Again, the low frequency is going to be higher. Okay, the center part of it, the low frequency is going to be, the maximum energy is going to be inside the ear, high frequency is getting reflected back of it. Okay, so that's why I said frequencies, stiffness, mass. Remember that. So you'll be able to identify the pathology of it. Okay, this is OCD. So this is a study has been done that they cut the ossicular chain discontinuity and checked out. Okay, baseline they've established with us, and then when they cut the ossicular chain discontinuity, you can see the sharp peak which has been there. With the reflectance, I want to speak about only the observance. So I just make a ulta of the up down of the graph. So if you look into it, it has the when the OCD is being cut. Okay, so there's a sharp peak in the low frequency region of it. Okay. Similarly, with the ossicular chain discontinuity, this is going to be of mass dominator, stiffness dominator. Stiffness dominator, right? So AS type of tympanogram, right? And then the impedance is going to be increased, the compliance is going to be AS type, and the resonance frequency is going to be much more higher than this one. And what happens to this? Wideband observance. Higher high frequencies of it external. So you have a high frequency, which is the opposite of that particular graph. So high frequency is going to be improvised, whereas low frequency, most of energy is getting reflected back. So the autoclaves conditions, high frequency has a maximum observance of it. Okay? Similarly, these are number of different graphs in red. Low frequency, this is a normal one, the black color indicates a normal one, the round symbol looks the autosclerosis patient. So there's the difference between low frequency energy is getting reflected back most of the things. Okay? This is also one of my studies which has been published. So which also says the blue line indicates the normative region and this orange or red color indicates the otosclerotic patients. So this low frequency is getting shifted towards the high frequency region of it. Okay? So because of stiffness dominator. Okay? But remember there is no significant difference between the peak pressure and ambient pressure in the otosclerotic patient. This I will come to it when the other pathology comes to it. Remember that none of the pathologies will have any much significant difference between low frequencies and the peak pressure versus the ambient pressure of it. Okay? The OCD, if you look into it, there is no much significant difference. Similarly, for the hypermobile tympanic membrane, all those things will not have much significant difference between these two. Okay? Now tell me, which is the one, the first one, second one, third one? Which disorder is this? You have options being here, autosclerosis and OCD. Which one is autosclerosis, which one is OCD? The last one is OCD, ossicular chain discontinuity. Okay. The second one, autosclerosis, and the first one, normal. Okay. So the session took this function. So this is what is the tympanometric findings will be getting it. The maximum is C type, right? The C type indicates the tympanometric took this function. Okay. Here what is going to happen with that? Here there is a simple difference between the wideband observance tympanometry. Here if you look into the pattern here, the orange indicates the normal pattern. Okay, see normal. This the first graph indicates the normal group for peak pressure and the ambient pressure of it. Whereas the second graph indicates is the essential dysfunction individuals. Okay, if you look into it, the peak pressure is going to be almost same. The wideband observance measured at the peak pressure is going to be almost same in the essential tube function, almost near to the normal. Whereas look at the ambient pressure conditions, there is a greater absorbance at high, not greater, the reduced absorbance at the low frequency and mid frequency regions. Okay, these are absorbance values. This is the ambient pressure condition. This got reduced drastically. Okay, whereas at the peak pressure, it is almost same like a normal individuals. So this can differentiate between is a normal condition or a extensive dysfunction of it. Where if you look at the otosclerosis or OCD, the peak pressure, ambient pressure doesn't make any difference. Whereas if you look into the extensive dysfunction, the peak pressure and the ambient pressure make a lot of difference. What is the reason behind it? Why it can be? So applying a pressure, make the tympanic membrane again stiff, we are inducing the stiffness. Okay, so it comes back to normal stage. But at ambient pressure, we are not doing that. In that way, the most of energy is getting reflected back in the low frequencies and the mid frequency region. So this is one of the indication for extensive dysfunction when there is a significant difference between peak pressure and the ambient pressure. Okay, so this is again the graph of one of my PhD study. Okay, this is a normal. The peak pressure condition is the ambient pressure condition. So there is no much difference in the peak pressure condition, okay, between normal and the extensive dysfunctioning. Whereas the ambient pressure condition, there is a significant difference between peak pressure and the ambient pressure conditions. Okay. So this is also study being done by Aikal et al. And they also find significant difference in the same thing. Okay. And this I already told it. For a peak pressure, we apply inducing the pressure so that the tympanic is stiff enough, so that it allows most of the energy is inside. Whereas ambient pressure, we are not inducing any pressure, so it is most of the energy is getting reflected back because of the pathology component of it. Okay. What will happen to otosclerosis in the ECG? Comes a combination of it. Otosclerosis, high frequency is going to be boosting, low frequency is going to be reduced. One, the station to dysfunction, peak pressure is going to be normal kind of thing, whereas an ambient pressure there is a low absorbance, right? So the low frequency is getting affected in the otosclerosis pattern. So both peak pressure, ambient pressure, low frequency affected, high frequency got boosted up. Okay. And for extensive dysfunction, your peak pressure and the ambient pressure. The black line is the peak pressure, and the blue line is the ambient pressure. So there is a significant difference between these two. So this is the combination of it. This is where we are going to do a differential diagnosis of each of the disorders of it. Okay. Okay. Medullary effusion. Those things is as simple. So if you have medullary effusion and the perforation kind of thing, in the tympanometry you get, what do you get? B type or A type? CS type. For medullary effusion, Botticelli's media. B type, right? So here you can differentiate between the tympanometry perforation as well as the medullary effusion part of it. Okay. So this is a graph you look into it. I go for observance graph. So this is a reflectance graph, just make a other way around. Okay. So in the effusion part of it, it depends on the amount of fluid which is been there. So in the ear canal or in the middle ear, you have a fluid which has been filled in the bed. The amount of fluid which is been present makes the difference. More the energy, more the reflectance. Okay. More the fluid, more the reflectance. Okay. Any bowl where the water is being placed inside, so most of energy is going to reflect back. Okay. So here the absorbance is going to get reflected back. So most of energy is getting reflected back of it across the frequencies. This is going to be different patients has been done with that. Okay. So we have this is the severity of the loss. Where if you look at the orange line and the black line, it's almost most of energy is getting reflected back. Whereas if you do other things, some of the energy is going inside, depends on the amount of fluid of it. Okay. This gives a better picture of it. So in the medullary effusion group, your entire frequencies, the absorbance value of the frequency is going to be reduced. So most of energy is going to reflect back across all the frequencies. So that becomes the medullary effusion part of it. Okay, this is understood. It's not a B type where you get a straight line of it, whatever it is there. Here you have the compared to the normal absorbance values, this will be getting reduced across the frequencies of it. Okay. So when you look at the tympanic perforation, it becomes the other way around. So what happens to tympanic perforation? B type frequency tympanometry, where you have the normal one here. So you got a black line. The black line indicates the normal value. The black line is the normal wideband absorbance tympanometry. So is it stiffness dominator or mass dominator? Tympanic membrane perforation. Stiffness or mass? stiffness, mass. So you have two ways of looking for it. So it can be either stiffness or the mass dominator, depends upon the amount of perforation which is happened to it. Okay. So here look into it. The smaller the perforation, the pinhole perforation, pinhole indicates the pinhole perforation. Smaller the perforation, you have a large effect. That means more energy is more energy is getting reflected, transferred. Low frequency is getting reflected back. Why it is so is, the pinhole perforation have a small hole which is being present in the tympanic membrane, right? So that small hole act as a mass. Okay, thus mass will boost the low frequency energies and reduce the high frequency energy of it. Okay, this is one concept. Even the small hole will lead to the stiffness is going to be reduced for it. In that way, the mass is going to be increased. In that way, you have a maximum energy in the low frequency region, but the high frequency there is no much affected in that. As the hole start, the hole start increasing it larger the perforation, it reaches to the normal values of it. Okay, this one way of looking at it. Okay, that is because one small hole they say there's a mass which is being acting because of the small hole. Okay, as the hole become larger, entire tympanic membrane is going to get open. So whatever the energy is you have sent inside, it is going to be with the middle ear. So every energy is going to get transmitted back. So it comes back to the almost kind of a normal level of it. Okay, this is the contracting results here, the tympanic membrane. This is one way of looking at it. Okay, the other way of looking at this is the reduced absorbance compared to that of this one. So any perforation happens to be the reduced absorbance part of it. Okay, so this is again, so this kind of more into a kind of pattern where when there is a hole in the tympanic membrane, so the most of energy is getting reflected back because the whole of it, the tympanic is not able to vibrate properly. So it gets struck and reflected back. The amount of energy is getting reflected back, that is lower absorbance values. So there are two ways of looking at it. Similarly, this is the work done by Ashok and Berman, the recent dissertation topic of it. They have tried about the central perforation and the marginal perforation of it. Again, they also found that the observed values are much reduced compared to that of the normal values of it in both the conditions. Okay, both the observance and the across the frequencies got reduced because again there is no tympanic membrane which just vibrates or takes back the equipment of it. So this becomes the problem of the observance values of it. The last one is the superior semi-synodical dehiscence. Okay, so here I just look into it. I don't want to go much into it. So these are very rare cases where you get into it. A third window opening in the semicircular canal. Got the conditions right? Third window opening in the semicircular canals. Okay, so it is the inner ear disorders. Okay, it's not a middle ear disorder. It's going to be pure of inner ear disorders. But still we will be able to tap the inner ear disorders through wideband absorbance tympanometry because the concept of wideband absorbance doesn't restrict only with the middle ear disorders. It also tap the inner ear disorders also. So here what is going to happen with that is the wideband absorbance here is increase the low frequency region, especially at 1 kHz region. Okay. In the otosclerosis pattern, the OCD pattern, it is around 500 to 8,800 Hz. The peak will be you have seen it. Whereas here it is around 1000 Hz, which indicates that the person might have superior canal dehiscence. SCD part of it. Okay. Okay. So this is a significant difference. If you say in the way, there's a difference between OCD and the SCD. OCD is more at 1 kHz is the peak, whereas for the SCD is a 1 kHz peak, whereas OCD it is 500 to 800 Hz peak will be there. So this differentiates between the OCD condition and the SCD conditions of it. Okay. This is again the SCD condition with each patient. There's a lot of variations here listening to it. But the peak major you can see in this around that 1 kHz region. There are a lot of variations here. When you look at the average part of it, it comes around 1 kHz region, around 500 to 1 kHz region, but majority seems the 1 kHz region of it. Okay. So this is one of it. And the last one is going to be Meniere's disease. Okay, if you look at the Meniere's disease, the last one, the gray line which is being there here, this part is going to be of a normal value, the control group of it. Okay, this part. Okay, so if you look into it, you have two peaks which is being present here, one at around 1000 Hz, other one around 2000 to 4000 Hz of it. Okay, in the Meniere's disease, what is going to happen with that is one with reference to a control group. The control group usually the peak is present around 1000 to 1500 Hz, whereas with the the venous disease, okay, your peak is shifted to around 2000 to 3000 hertz. Your peaks are getting shifted to 2000 to 3000 hertz. Okay, this is the peak which is being shifted there. Okay, so there are two observations here. One with responsive control group, the peak is going to shifted to higher frequency region. One thing, okay, because in the venous disease there is an increase in the pressure, right? There is an increase in the pressure in the intracranial pressure where endoluminal pressure has been there. There will be increased endoluminal pressure, so it's a stiffness dominator. So here the high frequency is getting better here, okay. And because of the low frequency is getting reduced here, so that's the one concept which is seen in the venous disease. The other one is the difference between peak pressure and ambient pressure. In the venous disease conditions, the peak pressure, the usually peak pressure what happens is goes to shifted to the higher frequency, higher region. That is more than minus 100 hertz, 100 Kappa effect. Okay. So in that region, there is a significant difference between peak and the ambient pressure of it. Okay. So here it is a combination of essential dysfunction pattern as well as the otosclerosis pattern of it. So in a venous disease, what you get the pattern is it's a combination of otosclerosis as well as the essential dysfunction pattern you'll be getting it. Difference between peak and ambient pressure, there is a significant difference will be there. We reduce here, look into it. Okay. Whereas the high frequencies, because of stiffness dominated, it becomes high frequency boost of it. Okay. These are about wideband observance, tympanometric significant pattern of each of the conditions. How many of you have Tamil here? Punjada, Pocha, Madhyana, Kalyana, Samayal Sadhaman, Nariya Softa. We ate so much of marriage kind of food. So, even I am sleepy actually. So understood. Something is going inside. This is a recent topic, so if you look at the pattern, you'll be able to identify what exactly it is. Okay? So now, move on to this. With this, we'll wind up the presentation. Okay? Now, guys, let me know which are the disorders here. I pour in the color also. The thing is a green color, I think. Kind of green. The black. Black indicates the peak pressure, and the green indicates the ambient pressure conditions. So I'll tell you, first graph is going to be a normal. The normal pattern has been established with that. Okay. So we move on one by one. The second pattern. Okay, my third pattern. Third one. Across the frequencies, all the observed values are reduced. What condition is that? Across the frequencies, everything is reduced. Mediate effusion. Okay. The water is medium. All the observed values have been reflected back, right? And then this otosclerosis, and then this I didn't tell you, this is not required. This one, peak pressure, ambient pressure difference. What is that? Essential dysfunction. Okay, and this is the tympanic perforation plus otitis media. All the energy is getting deteriorated, and you have a number of peaks is being present there. This is the combination of that. I have not thought that. Okay, so any slides will be available. So how do you differentiate in each of the conditions I have given it here, the writing and the graphs have been here. Okay, so this can be used as the pattern where you can identify each of the disorders and correlate to that. Okay, thank you and all. Last slide.
Any questions from the audience?
Can I step down? Right.
Thank you, sir, for spending your valuable time and providing a final insight on wideband tympanometry for the learner minds. Thank you.
I would like to invite Dr. R. Sundaresan, Head of the Department and Associate Professor, Department of Audiology and Speech Language Pathology, to facilitate Dr. Arunraj K., Clinical Audiologist, All India Institute, Speech and Hearing.
Dear delegates, we have an announcement. We have a banquet night tonight. The theme is Glitter Glam. The whole art of teaching is the only art of awakening the natural curiosity of young minds. Now we have Sharad Kumar sir to share his ideas on the topic clinical utility of reflexometry. We welcome you, sir.
The first topic was basically the TIMP, and then we saw the WBT. Now the last part of imitance is how reflexes can help us in differential diagnosing different middle conditions. So topic is basically clinical utility of acoustic reflexes. So basically middle muscle reflex is basically the reflex which will happen when the or the ear is exposed to very loud sounds. There is a reflex arc which will contract the stapedius muscle, which will reduce the intensity of sound which is reaching cochlea, by thereby protecting the cochlear hairs. So basically middle muscle reflex testing can be used to cross-checking the behavioral results and to correlate with the tympanogram results that we have got and the audiogram results that we have got to differentiate middle ear disorder versus inner ear issues, or in some cases to differentiate between cochlear and retrocochlear function. So basically there are two major muscles which are there which will help for reflexes, middle ear muscle reflexes, that is tensor tympani and stapedius muscle. Major middle ear muscle response is from stapedius muscle, especially for sounds. The tensor tympani muscle is basically for tactile stimulation, but stapedius muscle reflex is usually for acoustical stimulation. So this is the pathway that is activating for acoustic reflex. That is, it will move from middle ear to inner ear to auditory nerve, then centers cochlear nerve, and then medial superior olivary, and you have facial motor neuron of 7th cranial nerve, and then that will stimulate the stapedius muscle. So contra pathway, again in this it's clear that this is IPSI, the cochlea, 8th nerve, cochlear nucleus, SOC and 7th nucleus, 7th nerve and middle muscle reflex. This is IPSI. Then contra is basically middle ear, inner ear, 8th nerve, cochlear nucleus. Then opposite ears, SOC and the 7th nerve nucleus. then cervical nerve and middle muscle response of the contralateral side. So this is right IPSI and right contra. So again, this the testing is basically done with 226 Hertz probe tone. So when we are measuring reflexes, there are two basic frequency tones that are given. One for monitoring the admittance, that is the probe tone, and the other one is basically to check what is the amount of admittance change which is going to happen when the ear is exposed to loud sounds. So one is probe tone to monitor the admittance. The other one is to elicit the reflex. We are using reflex anything, that is the stimulus frequency or activator frequencies, which is between 500 Hertz, 500 Hertz, 1 kilohertz, 2 kilohertz, 4 kilohertz, or broad spectrum BBMs can be used. Usual presentation duration for this one is 1 second. In some cases, rare cases, 2 seconds. And there are certain special tests which is there, which will be exposed for 10 seconds. So this is how when you measure reflexes, this is how it is going to look in the equipment. So you start from the low level of 70 dB. Usually the reflex starts from thresholds plus 60 dB. So that means 70 dB, 75 dB there is slight reflection, and 80 dB there is slight reflection, and 85 it is increased, 90 it is increased, 95 again it is increased. So again here it is thresholds that we are taking. So minimum amplitude of more than 0.03 will be considered as reflexes. So there is increase, that is one thing, and the pattern of the reflex that you are going to get cup shape, and the minimum amplitude to consider it as threshold level is more than 0.02, that is 0.03, or anything more than 0.025, and present day equipment are there between 0.021, 2, 3, 4 like that. Means 0.0001 accuracy is there, so you can get anything more than 0.02 can be considered for threshold distribution. Of course, more accurate is 0.03, that is what is used. So, so this is the actual equipment measurement that we have done. So this is again normal ear, and we have done it for this is for contra and this is for IPSI. Then this is for 226 Hertz. This indicates the frequency at which we have measured the reflexes. Okay, this is for 500 Hertz that we have got. This is the contralateral and ipsilateral thresholds that we have got in this particular study. So it is like contralateral is around 85 for 85 to 90 in contralateral, and 75 to 80 around in ipsilateral reflexes. Of course, if you see frequency when compared to frequency specific stimulus, broadband BBMs have lower thresholds than the frequency specific signals, and low frequency has lesser thresholds than high frequencies. Then means this is to understand how the IPSI and contra measurements are done. So where the activator signal is given, where the probe, which is the probe here, and where the measurement is done. So this is like right contralateral, left ipsilateral, left contralateral, and left ipsilateral. So when if you are presenting the probe frequency and activator frequency both to the same ear, it becomes IPSI. And if you are presenting probe ear to one side and probe tone to one side and activator signal to the other, it becomes the same ear contra. So that's all it is. So for measuring, so what should be taken care to measure a good reflexes is basically, again, correct tip size is the most important thing as we discussed in TIM. Again, for this one, airtight seal is one basic important thing. Then depth of the insertion of the probe, and then repeated means means make sure that the peak pressure that you have got is maintained across the measurement. So if there is any kind of movement because of these things, your reflex elicitation can get affected. So you have to repeat the tip and then redo the reflexes. Then reconfirm the placement of the probe. After the entire reflex is done, please reconfirm it by repeating the tip so that you are sure that whatever tip that you measured first and the last is same, so that you are more confident in what kind of reflexes that you have got is right or wrong. So and monitor the stability of the compliance across the pressure till the reflex is complete. So make sure that the compliance is stable and the pressure is maintained at the same constant level. So this is means basic function of reflex is, as we told, we could not identify just with TIM, we could not identify whether it is normal mid-ear versus abnormal mid-ear. So this is one slide which will show, irrespective of which particular reflexes are there, whether it is IPSI, what level it is there, whether all frequencies are there, one particular frequency is there, whether it is IPSI or just contra or all of it, all these patterns indicates normal mid-ear. Okay, we saw this all frequencies are normal, then also mid-ear is normal, and then elevated levels, then also it is normal mid-ear. Okay, then only IPSIs are present, contrasts are not there, then also it is normal mid-ear. Of course, the other conditions of neural involvement or cochlear pathology we are not considering. We are just talking about the mid-ear pathologies. And then only contra being present, whether it is elevated or at the normal level, again mid-ear is normal. And only one particular frequency, IPSI contra is there, IPSI or contra is there, then also mid-ear is normal. Whichever side you have reflexes, you can conclude, closing your eyes, that mid-ear functioning is normal in that particular ear. So then basically we saw whether reflexes are there and what level it is there. Those are the two things. And the other thing is Jarger box pattern. Jarger has given different patterns of that can be plotted, whether reflex is there in IPSI or contra in right and left. You can conclude different conditions. Okay. So first thing is in cochlear hearing loss, basically the affected side IPSI and the other side contra, either it will be elevated or it will be absent depending on the degree of hearing loss. We get something called as diagonal pattern. So that means unaffected side IPSI and the other side contra will be normal, and only affected side IPSI and other side contra will be elevated or absent. That is basically because of the hearing loss. Okay. So irrespective of this one, again this confirms mid-ear is normal just because of the hearing loss. You have elevated or absent reflex. This is with 50 dB of hearing loss in left ear. Then in profound degree of hearing loss with moderately severe sensorineural hearing loss. In profound degree, both IPSI of that profound degree and contra of the other side would be absent, but the other side which has 65 dB of hearing loss, you will be having elevated. Okay, so even the same thing happens in unilateral profound also. The affected side, both diagonal pattern will be there. The other side IPSI and the other side contra, unaffected side IPSI and the other side contra will be normal. Then if it is facial nerve paralysis, then it will show vertical patterns. Basically, that means the ipsilateral. Basically, the problem is in the pathway. So when it is facial nerve paralysis, it is basically this nerve which is paralyzed, or you have some problem in this nucleus. Okay, in such conditions, you will get vertical pattern. Okay, vertical pattern where the affected sides, seventh nerve is involved. So IPSI of that ear and IPSI of that particular contra of that particular ear is affected. Usually, you can monitor this reflex in order to see whether how is the recovery pattern of that the facial nerve paralysis. Okay, if it is like absent and it became elevated and then it became normal, it indicates that facial nerve paralysis is healed. There are certain conditions. Bell's palsy is one such condition where it will show absent. Then with the treatment, it will the reflex can come back. Okay, so you can use that one as a monitoring tool to check whether the treatment efficacy of that Bell's palsy. Then conductive hearing loss. If it is, of course, because as I told, if there is mid-ear pathology in both ears, then everything is absent. But only in cases with unilateral conductive hearing losses, you get something called as either vertical, if the hearing loss in the unaffected side is very less, or usually you will regularly, if you have more than 30 dB of hearing loss, you will get inverted L pattern. Okay. So inverted L, when you are getting it, it confirms unilateral conductive hearing loss. Obviously, if it is bilateral conductive hearing loss, everything will be absent. So this is bilateral, irrespective of the degree of hearing loss, whether it is 30 dB of hearing loss or 20 dB of hearing loss. If there is medial pathology involved, then entire reflexes will be absent. Then looking into vestibular rapid and brainstem disorder, vestibular schwannoma, that is 8th nerve is involved there. So in such conditions, you will get the same pattern of diagonal pattern, where you, in this particular case, it is like 40 dB threshold. This is measured for 1 kilohertz. So the 40 dB threshold is the in behavioral threshold is 40 dB, and left ear it is 50 dB, and the difference between in terms of threshold it is not much, but one side it is affected, means it's totally absent. Just for the 10 dB of difference in the thresholds, one side it is affected and the other side it is normal, which will indicate vestibular schwannoma, so diagonal pattern. Then auditory neuropathy spectrum disorder. In this condition, TIMP will be normal. Reflexes, either it will be elevated, usually it will be absent majority of the time, or in some cases one frequency might be present, but it will not follow a very regular pattern. The shape will not be there. The increase in the amplitude is not very evident. So in such cases, you usually take it as absent, even though you see some deflection in the reflexes. But reflexes will be absent, but autofocus emission is normal. So that should trigger to you that to confirm auditory desynchrony in such cases, do ABR in order to confirm whether it is an auditory desynchrony case or not. So then extraaxial brainstem lesion. So that is basically, it is within the brainstem if you have, that is intraaxial brainstem lesion. So you will get horizontal. The contra of both the sides will be absent. IPSI will be working, contra will be absent. So we call that particular pattern as horizontal. So then we have superior canal dehiscence. Basically, it is third window syndrome, where you will see ABG, which will make you think that it's a conductive hearing loss, but you will elicit reflexes at lower levels in cases like cochlear pathology. So if that is the case, it will help you to differentially diagnose dehiscence. And the other symptoms they usually see is they will start getting giddy when you try to maintain the pressure at particular pressure. So in that case also it will help you to diagnose superior canal dehiscence. So this is again this is one such condition where superior semicircular canal dehiscence exactly normal, means even though you see about 30 to 40 dB of APG low frequencies, 250, 500 and 750 Hz, you could really record the OEs, reflexes completely at normal levels. So usually, as we told, it is conductive pathology. If BC will be normal, AC will be affected, ABG is seen clearly, which will indicate conductive pathology. As we told, if there is conductive pathology, reflexes will not come. But if you're recording reflexes very successfully and consistently, then it should trigger that it could be a case of semicircular canal dehiscence. So this is again summary of different patterns that you have got. Cochlear pathology, diagonal pattern. Facial nerve damage or palsy, it will be vertical pattern. Medial pathology, either it will be inverted L. Again, if 1 year hearing loss is, the conductive hearing loss is lesser, then you can get vertical with just elevated reflex in the other side contour. So this is for intraaxial and extraaxial. So intraaxial is horizontal, and extraaxial very unique. That is outside the brainstem, we get it something like unibox pattern. Basically, if you observe, we are marking the pattern with respect to which are absent. It's not about which is present, it is which all are absent, we are measuring that way. So inverted L is an indicator. Otherwise, usually it gets confused whether it is because of affected cell, whether it is absent that you are considering or present you are considering. Only with respect to this one, inverted L and this extraaxial, it will confirm that you have to always consider which is absent, not which is present. So functional hearing loss is another this thing. So to correlate to behavioral thresholds, if it is not correlating, then this is one such condition where we got behavioral responses this way, and he was technically giving very confidently his responses were at this level. Even masking, he was quite confidently giving at sensory neural hearing loss. But when we did reflexes, we got this one, which we indicated that there is some issue with the behavioral responses that we got. And we did ABR, and it was present till 60 decibels in left ear and 70 decibels in right ear. So which will correlate to the degree of loss in that. Means if it's a cochlear pathology, you can get near nominal thresholds. Then acoustic reflex adaptation, that is reflex decay. Means the other test that I was telling is, means usually the regular reflex thresholds were obtained for 1 to 2 seconds. But if you are using the same protocol for 10 seconds, you can measure the auditory nerve firing, okay, continuously, how long it can sustain. So if usually for normal ears, we can get a sustained elicitation of reflex which is maintained for 10 seconds, okay, which is usually done for 500 Hz and 1 kHz. Okay, and it is done at threshold, means ART thresholds plus 10 dB, and you are going to get something like this. So 10 seconds, there will be a flat response of elicitation of reflex, and after 10 seconds, it will move back to the normal levels of admittance. So this is normal, and this is 50%. Okay, when there is decay, means if the amplitude is reducing more than 50%, okay, that is the initial amplitude versus the final amplitude. If it is less than, I mean, if the amplitude is reduced by 50%, at what particular time duration it is getting 50% will be calculated. If it is within 5 seconds or within 10 seconds, it will differentiate what is the extent of the auditory nerve dysfunction. Okay, this is like steeply reduced adaptation is there, and this is slow adaptation is there. So this is one of the normal ear. So this is at 500 Hz and this is 1 kHz. This is at 90 dB, 90 dB, and this is one such condition where we recorded positive reflex decay, which was there till 4 seconds. So this is also because we usually do this reflex decay in contra. So unless until you place that contra phone, we have seen this same pattern because of inappropriate placement of the contralateral probe. They would have placed a bigger tip, slowly it will lose out. Okay, in such conditions also we have recorded this kind of patterns. Make sure that is placed correctly till the end of the testing. Okay, so at the end also it should be in the same position. So otherwise you will get positive, okay, but it might mislead you considering that it's a case of RC. Again, we saw jagging in tip, okay, same jagging can be seen in reflex decay, okay, again because of glomus jugular tumor or petalous tissue tube, there is compliance variation or admittance variation which will happen across the time duration, okay. To differentiate that one, as we saw in the previous listing also, if you hold the breath, petalous tissue tube jagging would stop, but the glomus jugular tumor jagging will not stop. So this is one such recording, petalous tissue tube we recorded. So other use of acoustic reflex testing is ESRT, that is for cochlear implantation. They use reflexes which are electrically evoked through cochlear implant to set the upper limit, okay, so that the C levels can be set in few companies, okay, which will ensure that whatever electric current that are given through cochlear implant is sufficient enough to elicit the responses. So basically it is like you place the probe in one ear, and the contralateral ear where the implant is done, opposite ear probe is placed, and you stimulate. So basically it is something like contralateral recording that you are doing, but you are not providing acoustical signals. Instead you are presenting electrical stimulus through cochlear implant, and the change in the admittance is recorded in different current levels. Okay, so the current level at which you elicit that change in the admittance can be recorded. Minimum change again 0.02 is considered here. So if there is that deflection, you can set that particular level as C levels. So this is the connections for this thing, that is from PC or the software which is used for mapping the CI. Then TIM is placed on the TIM probe is placed on the contralateral side. Then present the electrical pulses from the computer and record the TIM reflexes. So this is like there is a deflection in the admittance value that you're going to record. So this is how it will look. So anywhere, of course, you can use 500 Hz and 1 kHz again here. Even for one frequency, if you're doing, that is sufficient to mark. Means 500, 1K, 2K, 4K. You can set current levels across the frequency for different frequency. You can set that. Because pulse also you can give it for different this thing, and you can get that record. So again, means summary total. It is basically to differentiate midlife pathology. It means basically if TIP is showing A, As or usually A and As or C type with reflex present indicates normal media. Okay, irrespective of the frequency, irrespective whether it is C contra, that confirms midlife pathology is not there. Then cross check the neural integrity of reflex pathway, that is neural adaptation using reflex decay. So using different, if it is a unilateral condition, you can use Jaeger box pattern to point out the lesion or diagnosing different types of hearing loss or cause of hearing loss. Then you can use cross-checking the threshold, whether it is consistent, whether it is reliable or not reliable. The behavioral thresholds are reliable or not reliable, and it will also assist in CA mapping for setting C levels. So, any questions? Any questions?
We immensely thank you, sir, for the informatory session. Your contribution has deepened the understanding of power of tympanometry and utility of reflexometry and has provided valuable takeaway for all the delegates gathered here. Thank you once again for sharing your expertise with us, sir. Very much.
Okay, so I know all of you guys are tired. It's been 3 lectures. It's difficult to continuously sit through. I can give you 2 minutes. I'll close my eyes. Those who want to run away, please run away. Anyway, I don't know you guys. Whether you're here or not there, I don't realize. Okay, so I can actually convince Sundaresan for that. First of all, I would like to thank the organizers for having given me an opportunity to come and present here. I was here for the FlaSH 1 and I get to see that this is FlaSH 7. So 7 years back again, I was there for the FlaSH 1. I want to start off by saying sorry to Miss Vinci, who kept on asking me for my PowerPoint. But I must tell you that it's highly confidential. To an extent that even I won't know what is there in the PowerPoint till I come here. Okay, so I'm really sorry, but you have the slides now and you can access it. I was given the topic, I'm given 2 topics. One is before tea and one is definitely after tea. First topic is do's and don'ts of auditory brainstem responses. So when I was given do's and don'ts, I opened my slides. This is for Miss Vinci particularly. I really made an attempt to make the slides much before I came here, but somehow I was blank whenever I opened the slides. I didn't understand what is do's and don'ts of auditory brainstem responses. It sounds more like traffic rules. In traffic rules we have do's and don'ts. Okay, so I did not know what to cover under do's and don'ts because the next topic was challenges and scope of auditory brainstem responses. And I could actually feel that there were a lot of things that were overlapping between the 2 topics. So I asked a couple of my friends, I genuinely called them up and asked them, but again, they did not help me. I think that was more intentional because they were also presenting here. They wanted to do a job better than me, or they wanted me to do a job poorer than them. So I thought, okay, let's start. I called up Sundaresan and found out that there is a variety of audience. So he told me there are about 50 practicing clinicians, which means to say they have done enough of auditory brainstem responses on different kind of patients. Probably they would have done in newborns, they would have done in children, they would have done in adult patients. Probably they would have used it for hearing threshold estimation, as well as they would have used it for site of lesion testing. And I was also told that there are students of first year who are sitting at the back of this room, I was told. Am I right? If it is yes, you have to show green card. If it is not, if it is no, you have to show red card. Are the last people sitting in this room first year UG students? You are scattered in the group? Okay, no. Okay, good. Okay, so there is first year, second year, third year and fourth year UG students, which means to say there is a variety of audience. Those who don't know theory and those who know theory but have not done it in practicals and those who have done it in practicals. So I actually thought, I will start it like this. I will start it from start to end. How the process of auditory brainstem starts. When I'm recording an auditory brainstem responses, from what cases I record auditory brainstem responses till the analysis and interpretation of the auditory brainstem responses. So I actually thought, I'll narrate it like a technical story because I have a lot, I pity the first year students who are here in this room who don't know even the theory of it. So I thought, I will narrate it like a technical story. Start from in what cases we actually do auditory brainstem responses and in which cases we actually don't do or we should not do auditory brainstem responses till the analysis and interpretation of the auditory brainstem responses. Before you actually understand the do's and don'ts of auditory brainstem responses, you should know some amazing facts about auditory brainstem responses. Number one, AEPs of microvolts are picked up and visualized. Imagine the signal of microvolts 10 to the power of -6, a small signal that is there getting generated from deep within the auditory brainstem, maybe at the level of the cochlear nerve, maybe at the level of the pons, medulla oblongata, that is being picked up by keeping an electrode here, and we are looking at the waveform that represents these auditory brainstem responses, and we are interpreting something about the neurophysiology of the auditory nerve or auditory brainstem response. That's an amazing and fantastic thing, right? You looking at something that is in microvolts. More astonishing is the input that comes at the electrode. See, when I place an electrode on the head to pick up an auditory brainstem responses, this electrode is dumb. It just knows to pick up some electrical activity. It doesn't know to differentiate between auditory brainstem responses, a signal, versus a noise or other electrical activity. When I'm moving like this, there's a lot of EMG activity happening in my body. That also, if I will be picked up if I place an electrode here. So when I'm blinking my eyes, there is some electrical activity generated because of that. When I'm speaking, there's a lot of oral musculature moving around, or to an extent, even for me to speak, there is a lot of the upward and the downward neural circuitry that is active, and all that generates an electrical activity. There is nothing that happens in a human body without generating an electrical activity. So all that electrical activity is available for this electrode that is kept on the scalp. Along with that, there is some stimulus evoked auditory brainstem responses that is coming up. Now, you should know relatively what is the strength of the auditory brainstem response that we are picking by through this electrode, or what is the strength of the other electrical activity which is so-called noise, so-called artifacts. What is the strength of that? And only then you will be able to appreciate how challenging is the recording of auditory brainstem responses. So you can actually see that the amplitude of the AVR that we pick is only about 1 microvolt, whereas the amplitude of the other noise, electrical noise that is there within the head which the electrode is picking up,
that is about 200 microvolts. Imagine you screaming among 200 people. If 200 people are screaming and you are one among them, is it easy for anybody to locate you just by recognizing your voice? Yes or no? Green card or red card? Yes or no? No, right? Okay, so it is going to be the same kind of a challenge, identifying an ABR among that immense, large amplitude, other electrical activity. That is what we are doing while recording auditory brainstem responses. But you should understand that in spite of all these challenges, if you can successfully record auditory brainstem responses, ABR has got exceptional temporal resolution. What do I mean by exceptional temporal resolution? When I record an ABR for a 90 dB signal in a normal person, I get a fifth peak at around 5.6 milliseconds. If the same person gets an acoustic neuroma, the ABR gets shifted to 6.1 milliseconds. Now this shift is only about 0.5 milliseconds. From 5.6 to 6.1 milliseconds, the shift is about only 0.5 milliseconds. But this 0.5 millisecond shift in the auditory brainstem response is actually accurately reflected in the waveform, and through that AEPs have got way better temporal resolution, whereas MRIs have got better spatial resolution. Because of this remarkable temporal resolution, AEPs are preferred over the other techniques. Now it has got a high sensitivity and specificity to detect hearing loss. You know that's why we are using it for threshold estimation, and also to detect space occupying as well as diffuse lesions. And very importantly, we have electrophysiological tests for all kind of behavioral tests. You take, Ajit sir was talking about speech perception in noise. We can actually assess the neural processing underlying speech perception in noise using auditory brainstem responses. In APD, we have gap detection test. You can actually design a paradigm to assess gap detection using the auditory brainstem responses. You can assess temporal integration. You can assess binaural interaction. All that using auditory brainstem responses. So we have electrophysiological counterparts for all behavioral tests. That's what makes ABR a very, very strong tool. Now, this is what these are the structures that are involved in the generation of the auditory brainstem responses. Basically, the first peak is this is for the first years and the second years. So, first peak is generated from the distal portion of the auditory nerve. Second peak is generated from the proximal portion of the auditory nerve. Third peak is from the cochlear nucleus. Fourth is from SOC, and fifth is from LL. So nobody, if you go and talk to a neurologist about this cochlear nucleus, superior nuclear complex, and lateral nucleus, because they won't really know about it, because auditory nuclei only audiologists know. There when you go and talk, you have to talk about medulla oblongata, pons, and midbrain. And I should say that ABR only gives you information till pons. It doesn't give you information beyond pons. That is, you don't get any information about the midbrain in auditory brainstem responses. You should be aware of this. So any information, or when you are looking at an ABR, the information that is available is only till pons, not beyond that. So any damage beyond that will not be reflected in the auditory brainstem responses. Okay, now candidacy. So in whom do we do and whom do we not do auditory brainstem responses? So when do we do? So we should do in every case that requires and not in every case. Sometimes, AISH is a government institute, so there are a lot of cases coming for disability certificate. I'm sure in many of the private institutions it must be happening there now. So when we are issuing disability certificate, it's not necessary that every case who is coming for disability certificate we do auditory brainstem responses. It's only in those cases where you find that the behavioral thresholds are not reliable. Okay, wherever you suspect that the behavioral responses are not reliable, you go and do auditory brainstem responses for hearing threshold estimation. Not in every case. If you are doing in every case, it shows your low confidence in the behavioral testing. Ajit sir was telling that he was saying that pure audiometry is the bread and butter. He was saying that that is the test which you should master as an audiologist, which is very, very true. The behavioral test, you should have confidence on the behavioral testing that you do, because ABR may come or may not come, but behavioral responses shows the responsiveness of the individual. ABR will not show, it's just an objective test. It just shows the neural function. It doesn't show the responsiveness of the person. Whereas pure tone audiometry shows the responsiveness of the person. So never trust objective test more than behavioral test. That's a lesson that you should learn right from the beginning. So not every case that has giddiness. For example, whenever there's a patient with giddiness, we suspect acoustic neuroma. We need to rule out acoustic neuroma. But we need not do ABR in every case to rule out acoustic neuroma. Okay, so we have to do in every case that requires, but not in every case that comes into our audiological training. It's not a test of hearing sensitivity. These are two cautions, most important cautions. ABR is used for threshold estimation, but it is not a test of hearing sensitivity. Two examples for it. For example, a cortical deafness. A person met with a road traffic accident and has got cortical deafness. Everything below cortex is normal. What do you expect ABR results to be? Normal or abnormal? Loudly.
Normal.
I can't hear.
Normal.
Still louder. Young. Others can copy some voices that you are hearing. In a cortical deafness, if you do ABR, what results do you expect? Normal or abnormal?
Normal.
Normal results. Okay. So because ABR only assesses, you are giving a stimulus here, it goes to the mid ear, cochlea, auditory nerve, brainstem. Everything here is normal. So everything, all ascending pathway till the brainstem is normal. So ABR comes normal. So it won't be able to detect a damage at the cortical level. But the person can have profound hearing loss in case of cortical deafness. Okay, so if you go by ABR, you will call it as a normal hearing, but that's not the case. But if you do pure tone audiometry, you will identify that it to be a profound hearing loss case. So always believe in pure tone audiometry more than ABR. That's my suggestion, advice. ANST. What do you expect in ANST? Can ANST person have a normal or near normal hearing sensitivity? Yes or no? Green card, red card? Green card, yes. So what do you expect ABR to be in an ANST case? Present or absent? Absent. Okay. So ABR is absent, but hearing sensitivity is normal. Now, if it were to be a true test of hearing sensitivity, that cannot happen, right? So ABR is not a test of hearing sensitivity. Of course, in case of conductive hearing loss and cochlear hearing loss, there's a good agreement between the behavioral thresholds and the ABR thresholds. So I can actually use, there is a scope for me to use ABR for hearing threshold estimation. Now let's start. Okay, I decided in which case to do. Okay, so I have a case with me in whom I have to do auditory brainstem responses. Maybe it is for hearing threshold estimation, or maybe it is for site of lesion testing to rule out acoustic neuroma, or maybe to rule out ANST. What is the first step? We have to first instruct the patient. So what do we instruct the patient? We have to, you know about the instructions. You have to first explain them the purpose due to which you are doing that particular testing. What is likely to happen in that test, and why are we doing that test? That is what we are going to explain the patient. So you will explain that to the patient and make him sit. Now, one instruction that I see a lot of students doing while doing ABR is, we insist on closing the eyes. So, what is important is, the person should have a relaxed musculature. Whenever you are doing auditory evoked potential, the person should have relaxed musculature, because if the person is tensed, maybe his neck muscles are tensed, maybe his jaw muscles are tensed, maybe his limbs are tensed, but if he keeps his muscles tensed, EMG activity will be more. If the EMG activity is more, then what happens? The electrical noise, the amplitude of the other electrical noise will be higher. So it is difficult to record auditory brainstem responses. So if you want to have good recordings of auditory brainstem responses, the person should have relaxed musculature. Now, that doesn't mean that while doing ABR, you ask the person to close the eyes. Eye blinks do not affect auditory brainstem responses. That's a very important point that you should note down. Eye blinks do not. Whether the person is blinking his eyes or not blinking his eyes, it makes no difference in the auditory brainstem responses, because eye blinks have got a frequency activity of about 10 to 14 hertz, whereas ABR, when we are recording, we are concentrating somewhere between 1000 to 2000 hertz, 100 to 2000 hertz. The frequency component of eye blink and the ABR is completely different, due to which eye blink will not interfere. So never insist on closing the eyes. But if the person gets into sleep, when he closes the eyes, you should encourage them. Okay, for example, some of us, you make us close eyes for 10 seconds, we go asleep. If that is going to happen with the patient, please encourage them, because when we sleep, we have a relaxed musculature, and that is going to elicit better auditory brainstem responses. So what is more important when you are recording auditory brainstem response is the head and neck muscles, jaw muscles, lip muscles, and the neck muscles are very important. If the person, you have put the person in a reclining chair, but the person is resting his upper body, but the upper neck, the shoulders, but not resting his head, then what is likely to happen is he's keeping his head front like this. So that is going to make the neck muscles tensed. When the neck muscles are tensed, ABR recording is going to be challenging. So rest the neck very well, relax the jaw. Make sure that the person doesn't move his lips. That is more important than in ABR than the person not blinking his eyes. So as I said, sleeping is good, but not forcing to sleep. So don't force the patient to sleep. But if the patient sleeps, it is actually good. So we have actually shown that systematically, scientifically, we have shown that eye blinks don't affect the auditory brainstem responses. I'm not going into details of that. So next, I instructed the patient. I need to pick up few electrodes which I need to keep on the scalp. So what kind of electrodes do I pick up? You know that electrodes come in different colors. Does the color matter? Green card, red card. Does the color of the electrode matter? No. Okay, I will say it matters. Red card, good. So I will say it matters. Okay. Now if you take all three electrodes are of the same color, actually in the ABR recording as such, if you do every other thing right, it makes no difference. ABRs will be good. Just that you need to, once you place the electrodes, later if you want to go back and check whether you have placed the electrodes in the right places, it is easy to track if you have three different electrodes. Okay, if you have one color for the right mastoid, another color for the left mastoid, third color for the forehead electrode, it is easy to, the patient is sitting there, I am sitting here, so I can just look from here, and looking at the colors, I can actually track the electrodes and say whether the electrodes are placed in the right place or not. Not otherwise. Not otherwise. So I would prefer code the electrodes. Just the way you have your headphones, no? In headphones, red is always right and blue is always left, right? So you can do the same thing for the electrodes. Suppose in your clinic you have the same colored electrodes. What you do? Put a red tape around the one electrode, blue tape around the other electrode, and a black tape around the third electrode, so that it's easy for you to monitor it. So the third thing is, okay, I picked up the electrodes. Now I need to place the electrode sites. Where do I place the electrode sites? You know there are different kinds of montages. There is vertical montage, there is horizontal montage. Basically that depends upon where is the non-inverting and inverting electrode. I'm not going into detail of that. Now, why do I clean the electrode site when I want to place the electrode? What is the need for it? Quick answer. To reduce the impedance. Okay, so when I am recording ABR, that is of 1 microvolt, which is a very, very small amplitude. I place the electrode on the skin. If the resistance between, the impedance between the skin and the electrode is high, can I pick up 1 microvolt signal? I won't be able to pick up 1 microvolt signal. Can I pick up 200 microvolt signal? Yes. So if the impedance is high, what is likely to happen? I'm less likely to pick up the signal, more likely to pick up the noise. Overall, the signal to noise ratio is going to be poor. And if the signal to noise ratio of the recording is going to be poor, the ABR that you are going to get is not going to be that great. It's not going to be that beautiful in terms of its morphology. Okay, so having low electrical impedance is very, very important, and you guys know, you can read it in the books, it is less than 5 and less than 2 for absolute impedance and relative impedance. So you can use different gens. What we use at ICE is NewPrep. I'm not promoting any particular brand, but over the years when we have used a variety of skin preparation gels, we have found that this one is very good. So we just pick up a little of this in the cotton, and wherever I want to place the electrode site, when we are cleaning the electrode, we don't rub it like this. Okay, that is very important. So we don't rub it like this. We just do it in one direction. When we are cleaning the electrode site should be cleaned in one direction, from left to right. Or if you prefer to do right to left, there's nothing wrong with that. But do it in one direction, and don't rub it till the skin burns. Okay, so I have seen some students, they did ABR on their classmate, and that memory of that remained for 1 year on their forehead. Okay, so always instruct the patient to indicate if it burns before you start cleaning. That is very, very important. So that is about patient preparation tips. There is no relationship, okay, between electrode impedance and the rejections. This is another very important point that you should understand. Lot of us, we place the electrodes, start the recording, and if we see lot of rejections happening, what is the first thing that we do? We go back and check the impedance. Till now, I have not understand why we do that. Because, see, when does the rejections happen? If the other electrical activity is large in amplitude, right? If the electrical impedance is high, the activity picked up will be high in amplitude or low in amplitude. If the impedance of the electrode is high, whatever is coming from the head, the electrode will pick it up with smaller amplitude or larger amplitude? Smaller amplitude. If it is being picked up in smaller amplitude, do you expect the rejections to happen? There is no relationship between electrode impedance and rejections. That is something that you should understand. There is some amount of relationship between relative impedance and the common mode rejection ratio. Okay, so if you are interested in it, we can actually discuss it over the tea, but I'm not going to tell you the details here. Okay, some amount of relationship between relative impedance and the common mode rejection ratio, but there is no relationship between rejections and the electrode impedance. This is one of the most commonly misunderstood concepts. Okay, now if the impedance is high, I took a baby, I'm doing AVR on a baby. I started cleaning in the electrode, I cleaned the electrode, placed the electrode, and I'm seeing that impedance is 7 in all 3 electrodes. Now my textbook says that it should be less than 5. What should I do now? What should I do? Go back and clean. It's a 15-year-old baby. We are doing a lot of newborns these days. We test 10-year-old, 15-year-old. Do you want to go back and rub them again? No. My advice to you is go ahead and do the AVR. Now, the AVR that I'm showing you here, is it a good response or a bad response? It's a wonderful response because a rare response where you're actually seeing first peak even at 30 dB. The responses are 90 dB, 70 dB, 50 dB and 30 dB. Are you seeing a response at 30 dB even for first peak? First, third, fifth, all are there? Okay. Now this is a AVR that I recorded with an impedance of 20. Okay. So there is a chance of you getting good AVRs, particularly this happens in infants who have got a smaller head size. There is a chance of you getting good AVRs even at higher impedance. Okay. Don't straight away go and start cleaning. That is a blind approach. Always give it a try. Do a recording. If the recording is good, then you can proceed with it. In this case, I did the first recording. I found it beautiful. I kept on going down. Even till 30 dB, I was getting very good response. Why should I get the impedance to a lower level? Not at all necessary, right? So never do blind jobs. Do smart jobs. That is what is my recommendation here. Okay. Now I cleaned the electrode site. I got good impedance. A little about electrode sites. As you know, there is a vertical montage and horizontal montage. Generally, what we use is vertical montage, and that's because most of the time I'm looking at the wave file, be it threshold estimation or site of lesion. The lowest peak in majority of the cases, even in case of infants, okay, is wave 5. So you get good wave 5 if you use a vertical electrode montage, and that's why we use vertical electrode montage. Now, can I use a horizontal montage? Yes or no? In which cases? When will you use a horizontal montage? Now, below? Okay, do you, whenever you see a baby of below 18 months, do you straight away start with horizontal montage? How many times have you seen an infant having a first peak better than a fifth peak? Out of 100 cases that you do, and 100 infants if you do, in how many cases are you likely to see first peak better than the fifth peak? My experience is, even in infants, even in newborns, it's fifth peak that is more robust than the first peak. A rare case can have a first peak better than the fifth peak. So you can straight away go for vertical montage without much of thinking, even in case of children and infants. That's my advice to you. And theory says that the horizontal montage gets you better first peak, but you have an experience by yourself. Place it on few people, horizontal montage, and establish that the first peak is better than the fifth peak in your setting, and only then you can go ahead. Don't just blindly follow what's in the textbook. Now, when I'm placing electrode, one important thing is no two electrodes should be close by. Now, this is not a problem when I'm placing a single channel or a 3 electrode array. It is a problem when I'm placing a 4 electrode array. When I'm placing a 4 electrode array, what people do is, instead of placing non-inverting here, they go for non-inverting on the forehead. Where is the ground electrode placed in a 4 electrode array? That is also on the forehead. So what they do, non-inverting electrode and the ground electrode, they place very close by. See, what is important is, no two electrode when you are recording an AEP should be close by, because we are taking the relative potential difference. Therefore, it should not be close by. It is taking with reference to the ground electrode. It is taking with reference to the inverting electrode. Therefore, no two electrodes should be close by. That's very, very important. So try to keep, if you keep the ground electrode here, non-inverting electrode should be as high as possible, ideally at the CZ electrode or the vertex. That is very important. A lot of us make this common mistake. We keep the two electrodes close to each other. When I'm doing AVR, it's been established very well that there is not much difference between CZ and FPZ. All of you know this is FPZ. A lot of people call this as FZ. But this is not FZ. This is FPZ. FZ will be within the hair. Of course, for people like me, not for bald heads. Okay, so it will be within the hair. That is 20% in front of the CZ will be FZ. So it is FPZ here. So you don't see much difference in the clinical recording between CZ and FPZ. That's a very important point to be understood. Now, know the names properly. 1020 system. This is very, very important. When I take what is the reference points for the on the sites for defining the 1020 system? Any idea? From here to here, when we take the measurements, what are these reference points called? Not sure, no? Okay, know the names of the electrode sites. 1020 system is has very beautifully defined it. Now, is it a good APR recording? Yes for green card, no for red card. Is it a good APR recording? Sundaresan, I think they have lost red card and green card. Nobody is, except one person. Nobody is showing. Show me all your red cards. All of you. Sundaresh, I take back my complaint. They have it. Okay. Green cards. Nice. Okay. Is this ABR fine? Is it a good recording of ABR? Yes for green card and no for red card. Or red card for no. Green. Okay. All of you say it's a good recording. Okay. It is the same recording. What is the difference between the two recordings? Which is inverted? First one or the second one? First one. Okay. This is another common mistake that people do. That is, when you are placing non-inverting and inverting electrode, sometimes what happens, non-inverting goes on the master, inverting goes on the CZ. That's a very common mistake that people do, particularly during the learning years. So if you do that, what is likely to happen is the whole waveform is going to be ulta. Except the polarity of the waveform changing to the opposite, except the waveform becoming ulta, there won't be any problem with that recording. So all that you can do is just invert that waveform. You don't have to go back and do the re-recording. You can just invert the recording. In terms of the amplitude, in terms of the latency, in terms of the morphology, there won't be any difference other than just the polarity inversions. Okay, so you should form a template. See, when I showed you this waveform, I expected all of you to say, very first go a opposite polarity waveform or a reverse waveform. Okay. Now, why were you not able to do? This is going to happen in your clinics. It happens in our clinics. Many a times, we do record opposite polarity waveforms. Okay. But we have formed a template to this. The moment we look at it, we understand that it is ulta, and we just invert it and we start marking. Okay. So the non-inverting and inverting placements can actually go ulta. It can become erroneous. So you should know what is the consequence of that. Now, do we require really 3 electrodes? That's another question that I have. Do we really require 3 electrodes? Yes. What is the purpose of non-inverting and inverting electrode? Non-inverting and inverting electrodes are placed on the 2 sides of the dipole of the potential, right? What is the purpose of ground electrode? What's the purpose of ground electrode? Virtual ground of the patient. Something goes wrong while doing ABR recording, person should not get a electrical shock. He should be shocked. So he should be electrically grounded. So that is the virtual grounding that we do by placing the ground electrode. Okay. Now, is it necessary that if the baby is sleeping like this? Okay, I place the non-inverting electrode on the forehead. I place the inverting electrode on the right mastoid. Now, common electrode has to be placed on the opposite side. What do? If I go to turn the baby, my baby will wake up. What do? So what we do at ICC is we place the electrode on the hand. Okay, so the ground electrode actually can go anywhere on the body. The ground electrode can actually go anywhere on the body. So we have actually established that sometimes we do this. You can actually place it on the mother and ask the mother to hold the baby, and the baby is still virtually grounded. All these are smart things that you can do as an audiologist, right? It's not just being an audiologist, it's about you becoming a smart audiologist, right? So these are smart things that you can do. So you can actually place if the baby is feeling disturbed when you go to place the electrode, place the electrode, ground electrode on the mother, ask the mother to hold the baby's hand, the baby is still virtually grounded, and we have seen that there are no differences in the waveforms that we are recording with that kind of an exercise. Now coming to the stimulus. Ajit sir told you that pure tone audiometry is the gold standard. Yes, true. In ABR, click ABR is not the gold standard. It's the tone burst ABR that is the gold standard. You have to get frequency specific information. If you want to do hearing threshold estimation using auditory brainstem responses, it's very, very important for you to do tone burst ABR and elicit frequency specific thresholds. However, because of the time constraint, I'm doing when the baby is sleeping and baby has come from, the parents have come from far away place. They can't stay for more than a day. Therefore, I don't have much time. So what I do as a compromise, I repeat, as a compromise, I do click ABRs, but that is not the gold standard method. That is not the best practice. That's another thing that you should do. Second thing is, masking is not very necessary. For example, Ajit sir was talking about profound hearing loss on one side and normal hearing on the other side. He said that if you use insert, then except for that case, in most cases masking is not required. Now, even if it is normal hearing on the one side, profound hearing loss on the other side, most of the time, 99% of the cases, you won't see cross hearing happening when you're doing ABR. Why do we do masking? To avoid the participation of the other ear. When do you suspect the participation of the other ear? When you suspect cross hearing. Now, when you are using clicks, click is a very short duration stimulus, 100 microseconds in its duration. So when you are using a 100 microsecond stimulus, actually the IA is not same as that of the long duration pure touch. IA is much higher in value. Therefore, the chances of crossover and cross hearing happening in click is very, very weak. Therefore, you in 99% of the cases, even if it is normal on one side and profound on the other side, you don't have to do masking. Now, when do we suspect cross hearing? Again, you have to pay me extra for that, and you can meet me during the tea for that. Transducer. Which transducer do I use? Insert phones are the best because they kind of minimize the interference of stimulus artifacts. Insert phones are the best. But sometimes if you are doing on babies, this area is very sensitive. I'm sure you know. If somebody comes and touches our ear canal, we are never comfortable. Same thing true with the babies. So when the baby is sleeping, if you go and place an insert without actually taking a proper care of desensitization, if you go and straight away put the insert into the ear canal, the baby is likely to wake up from sleep. Okay, so my advice would be, if that is going to happen, or if you are seeing that the baby is waking up with every your attempt to put the insert inside the ear canal, go ahead and do with headphones. You are not doing anything wrong, because we are looking, when I am doing hearing threshold estimation, 99% of the cases I am looking at the fifth peak of ABR, and fifth peak of ABR is not affected by the stimulus artifacts of clicks. Okay, so I can actually go and place headphones. So infants and children, go ahead and do with headphones. You don't have to use insert phones if it is inconvenient to you. If it is convenient to you, please use insert. That's always the best practice. That is the first choice. But if it is not working out for you, please use headphones as an alternate. When you're doing hearing threshold estimation, you're not doing any big mistake. Now, coming to the other parameters, that is, this is how an IHS screen looks. Of course, it is different in biologic, it is different in neuro audio. So I just use this screen to just look at some parameters. Gain. What is the gain that you would set? 1 lakh. Because ABR is a very small amplitude response. Now, if the signal that is picked up by the electrode has to be analyzed by the circuitry, the hardware, then it has to be in few volts. Therefore, it has to be amplified by 1 volt, and this is the setting that we use. Now, a lot of people use 100 to 1500. Can you tell me what is the difference between 100 to 1500 and 100 to 3000? What difference does it make in the recording or the waveform? How many of you have an idea about the effect of that filter setting on ABR? Please raise your hand. I'm not looking at your faces, I'm just looking at the hands. All of you have an idea of filter setting on ABR, effect of filter setting on ABR. Tell me, if I set 100 to 3000 versus 100 to 1500, what difference is it going to make in an ABR? Sharpness will reduce. Okay, if you use a low frequency filter like 100 to 1500, ABR looks lot smoother. But in ABR, accurate, particularly when it comes to space occupying lesion, which you are using to identify acoustic neuromas, you have to see sharp peaks. So the sharpness of the peaks has to be very good for accurate marking of the peaks. Therefore, my advice would be, these are all my advice. Okay, you can cross question me, I'll answer you, justify to you. You may not find it in books. These are my experiences. What's in the books, you can always read in the books and the articles. Okay, so I'm not presenting what's in the books. 1000 to 1500 if you use, you're going to get a rounded peak, because it's only the low frequency information. 100 to 1500. 100 to 3000 if you use, it has got more high frequency information. When it has got more high frequency information, the peaks are going to be sharp. The peakedness of the waveforms. The peakedness of the waveforms is going to be very good, and that will help you for accurate marking of the peaks. For example, we talk of this 4/5 separation, right? 4/5 separation will be good if you use a filter setting of 100 to 3000, rather than you using a filter setting of 100 to 1500. Now, coming to this, okay, this is artifact rejection level. How much will you set this for? This is a very important parameter. How much will you set this for? In AVR, set it to about 25 to 30 microvolts. This is another mistake that people do. Now, when you have set it to, let's imagine 30 microvolt, you started recording, you're seeing a lot of rejections. What the tendency is to go back to avoid rejection, go back and increase the artifact rejection window to 40 microvolt or 50 microvolt. You're compromising. It's like you giving a easy entrance test versus difficult entrance test. In which test will you get a better students? In which entrance test will you get a better students? Easy entrance test or a difficult entrance test? Difficult entrance test. If you want a good waveform, please never compromise beyond 30 microvolts for audio instant responses. Okay, so be below 30 microvolts. If you can be below 30 microvolts, it will be wonderful. We have done a study and we have actually seen that for APR, it varies somewhere between, across individuals, it varies somewhere between 10 microvolt to 35 microvolt. And this is the confidence interval. That means to say in most cases you will be able to set it to less than 20 microvolts and you will still be able to get very good waveforms. So rejections is not, don't get upset with rejections. That's another thing that you should understand. I'm only talking of the AVR, not the other rejections in life. Okay, so don't get upset with the rejections. If you have more rejections, that means to say you have eliminated noise very well. If you have less rejections, that means to say you need to worry, probably there is some noise in the waveform. Our job is to eliminate the noise and record only the signal. For that, a good artifact, stringent artifact rejection window is very, very important. Now, quickly going to the other parameters, repetition rate. Of course, we have standards. Whenever we are doing infants, we do 11.1. When we are doing site of lesion testing, we do 11.1 or 90.1. When we are doing threshold estimation, we do 30.1. Now, any kid after 2 to 2.5 years, you can actually use 30.1. There is no problem because auditory maturation delay, if it is there, it would be complete by 2 to 2.5 years. So you don't have to use less than 11.1 for those cases unless you suspect something like ANST and you may want to do it at a really low repetition rate. Now, analysis window. Analysis window is another ignored parameter. A lot of people, I see that they go to a LLR protocol and change the settings so that ABR can be recorded. You should never do that. If you want to record ABR, go to ABR protocol and make the settings. If you want to record LLR, go to LLR protocol and do the setting. Otherwise, there's something called as number of data points and the sampling rate and all that. All that will be altered and you will not get a good waveforms. For ABR, you need to have very high sampling frequency, more number of data points. And for that, analysis window is only to an extent that is required for ABR. Now, ABR comes well within 10 to 12.5 milliseconds. Never go for an analysis window beyond that. You're actually, if you go beyond that analysis window, you're actually distorting the waveforms. Again, polarity, you can use a rarefaction polarity and condensation polarity. And after that, okay, he's calling for tea, so I got distracted. That's only for me, no, Sundaresh? I'll come, 2 minutes. Okay, so number of averages, again, it's not a set value, 1500, 2000, not a set value. It depends upon your experience. If you think waveforms are good, not shaking much, got stabilized, you can stop at that. Sometimes, you stop at 1000. In infants, I've stopped at sometimes I've stopped at 400 and 450. Okay, so because again they're sleeping, the signal to noise ratio is good, head size is small, you get very good responses, you don't require more than 400 to 450. So number of averages, you need not do 2000 in every recording. At least first recording, always do 2000. At least in the beginning years, always do 2000. Second recording is only to check for the replicability. And by the time you understand by 1000, 1200, if you understand that it is good replicability, you can actually stop at that. I'm not going into details because tea is waiting and it will become cold. So electrical interference, there is electrical interference. one key thing that you should know whenever you are doing ABR in a particular room is the plug point to which you are connecting the ABR equipment should have a ground voltage of less than 1 volt or 0.5 volts. That is very, very important. Generally, all these rooms have got a ground voltage of about 5 to 6. But for a room in which you want to record ABR, that particular plug point should have a ground voltage of less than 1. That means to say, it should have special grounding. Every room where you want to record AEPs should have a special grounding. That's very, very important. And yeah, these are some more tips. You can connect multiple, don't connect multiple equipments. I mean, sometimes we have the habit, connect one junction box and take emittance also from the plug point, audiometer also from the plug point, and OE also, ABR also. Not like that. Whichever plug point you want to connect AEP, it should be only that plug point. Otherwise, again, ground voltage will get altered. Generators, sometimes, if you are working on generators, they will have a different line frequency and you can actually have electrical interference because of that. Stimulus artifacts, again I'm not going to details, use alternating polarity to cut down the stimulus artifacts, and of course insert phones you can use for cutting down the stimulus artifacts. Okay, coming to quickly analysis as to what I should do and don't do in analysis. Again, here you should know, that ABR can be analyzed subjectively or objectively. Subjectively, thankfully, because only wherever it is subjective, audiologists have some value. When it becomes objective, we don't have a value. Anybody and everybody can actually do the interpretation. So till now, ABR subjective analysis is the gold standard. Now, this is a response with PAM. I'm trying to analyze, but what is happening is the response is showing very weak because there's a large PAM. So what I do is, the next thing that I do is, I just restrict the analysis window. Instead of 12 milliseconds, I restrict it to 8 milliseconds. So analysis window is restricted till this point. The same waveform is shown here. Okay, so if you have PAM, there is nothing to worry because PAM is coming after ABR. It never interferes with the ABR. It will interfere with the visualization of the ABR. So what you can do is set a scaling factor for the visualization window, or what you can do is restrict the analysis window to 8 milliseconds and you will be done away with the PAM. Now coming to some tips for the ABR analysis. Yes, you can see that you tell me which of these waveforms are good, which recording is good. Forget about waveforms. Which recording is good? Set 1, set 2, set 3. Rate them. Rank 1. The best is what? Which is the best one? Set 1, set 2, set 3. Set 2 is the best. Next. Set 1. Then the last one is set 3. Why did you say that? Obviously you are seeing in the visual inspection that there is more noise in this recording compared to this, and there is more noise in this recording compared to this. Are you able to understand? Yes. Okay. So the first prerequisite when you want to analyze an ABR is always do a good recording. Only analyze the response if the recording has got good signal to noise ratio. Now this is an absent response. Now this is also absent response, this is also absent response. Which one are you more confident? Last one, right? That's because it has got a good signal to noise ratio. Now there are criteria, objective criteria for you to judge the replicability. One, the size of the response should be more than 4 times the average distance between the replications. Other one, size at least 2.5 times more than the noise. These are objective ways of you defining the signal to noise ratio of the response. And of course you can look at the FSP. FSP value generally has to be 3 or more for you to consider it as a good response. Now, one of my colleagues marked this as a response. Do you think there is a response here? Fifth peak. Yes for green card, no for red card. Is there a response? How many of you say yes? Please raise your hand. How many of you say that there is a response here? where my colleague has marked. All of you say there is no response. Okay. So the point that I'm trying to say is never search for the response. That's a common mistake that we do. If you search for something, you will get God also. If you search for God, you will get God also. Many people got in history, no? Okay, you have so many people who went in search of God and they got God, right? What is there in getting a fifth peak in ABR? If you search, you will get it, right? Okay, so that's not the thing. Only if it is very evident to your eyes, mark that peak, take that peak as a fifth peak. If it is not evident on its own, if you have to search for it, don't take it as a response. That's a very important point to be noted. Now, people have given some more tips to judge the replicability. Okay. Now, what you have to do is just look at this waveform and what do you call this? When you do this, it's called squeezing the eyes. Okay. Squeeze your eyes and look at this side of waveforms. Squeeze your eyes and look at the left-sided waveforms. When you do that, are you seeing it like a one waveform? Of course, you see it like four waveforms. I mean, there are two waveforms. There are two waveforms in each set. So when you do that, does it appear like a one waveform? Okay, if it appears like a one waveform, then it is a good replicability. So that's another way of judging the replicability. Now coming to hearing threshold estimation, some tips. Okay, in hearing threshold estimation, one very important point is presence is what counts. It's not the latency, it's not the amplitude. It's not the first peak, it is not the third peak, it is not the fifth peak. It is the presence of the ABR. Even if first peak is present, other peaks are absent. If you are doing a hearing threshold estimation, track the thresholds based on the first peak. Okay, so it doesn't matter which peak is present, it doesn't matter which latency. I mean, what is the latency of that peak that is present? What is the amplitude of it? If it's a good replicable waveform, take it as a response and track the thresholds based on that. It may be first peak, it may be a rare case a third peak that is more robust compared to the fifth peak. So whichever peak is robust, take it based on that. So in this case, can you tell me the threshold, ABR threshold? ABR threshold is defined as the minimum intensity at which ABR is present. What is the minimum intensity at which ABR is present in this case? 30 dB. Okay, so what will be the estimated behavioral thresholds in that case? Estimated behavioral thresholds? 15. Okay, you did 30 minus 15. Okay, so why did you do 30 minus 15? Why not 30 minus 10 or 30 minus 20 or 30 minus 5? That's another thing that I wanted to stress. It's not always 20 dB. People have a 20 dB concept. Yes, during the initial years when you are in second year, third year UG, please take 20 dB. But as you mature, please make sure that you look at the other test results. If you see that it is more of cochlear hearing loss, it is not 20 dB gap between behavioral threshold and ABR threshold. It is only 5 to 10 dB gap. If it is a conductive hearing loss, it's more of conductive hearing loss suggested by the emittance and all, then it is 20 dB difference between the behavioral threshold and the ABR threshold. Okay. Now, sometimes this is a very clear-cut absent response. Now, in this case, I see that there is replicability, there is negative slope, and it is getting repeated also. So I can actually, but it's a very small amplitude response. So there's nothing wrong in you calling it as a query presence of response at that particular intensity. So there is a scope for calling it as a query response. Now there are some more tips. You can actually take my slides and refer to it as to how to mark the first, second, and third peak, and some morphological variations. Of course, each one's ABR is different. There is nothing called as a standard ABR. Each one's ABR is different in terms of morphology. So you have to do hundreds of cases, form templates of normal ABR. Only then you will be quickly able to identify a abnormal auditory brainstem responses, which I will demonstrate to you in my next talk. Okay? Theory is not practice. This is for all students, not for the practicing clinicians. Theory is not practice and knowledge is not skill. You have to do practicals. Okay, it's not enough if you learn the theory properly. It's not enough if you just crack the entrance test. That's not sufficient. We are all clinicians. We have to be extremely good in our practicals. Practicals in terms of understanding the effect of different parameters of ABR on the waveform, understanding the clinical interpretations, making strong clinical interpretations and everything. Okay, so with that, I thank you all for this opportunity. Sundareshan is coming for the 5th time. Please run for the tea. Thank you. If you have doubts, you can come back and meet after the tea.
Thank you, sir, for your session. Now let us break for tea.
Oration Award at Indian Speech Association Conference 2022 and Asian of the Year Award at All India Institute of Speech Engineering in 2018. He has received his bachelor's, master's and PhD degree from the prestigious All India Institute of Speech Engineering, Mysuru in the year 1999, 2001, 2007 respectively, following which he pursued his postdoctoral fellowship program at Northwestern University, Illinois in the year 2007. He is currently working on few projects that involves looking at training-related brain plasticity in learning the non-native language in adults, neural mechanism of speech perception and localization in individuals with hearing disorders, role of auditory afferent system in hearing. 7 students for PhD. Before joining as teaching faculty at All India Institute of Speech Engineering, Mysuru, he had worked as faculty at Kasturba Medical College for hearing disorders. In addition to the above, he has been exploring the various factors influencing speech perception, such as psychophysical abilities, noise exposure, and effect of training on speech perception. He also explored the cortical mechanism of speech and music perception using fMRI. Wishing him a success in all future endeavors. Sandeep is currently working as Professor of Audiology at All India Institute of Speech Engineering, Mysuru. He was awarded the Asian in year 2019. He has received his bachelor's, master's, PhD degree in speech engineering in the year 2001, 2003 and 2008 respectively from All India Institute of Speech Engineering, Mysuru. He has 10 research projects with intra and extramural funding with total extra funding for 1.3 crores. He has published 60 international and national paper publications. He has guided 5 students for PhD and 41 dissertations. He has 4 book chapters published. He has 94 research paper presentations in both national and international conferences. He has won 22 awards for his research papers at national and international conferences. He has been invited as guest lecturer, resource person for 64 conferences. He is currently serving as Joint Secretary of Indian Speech Engineering Association. He has served as General Secretary of Mysuru Chapter of ISHA and founder member. He served as editor of American Journal of Audiology for the special issue of 50th ISHA-Con, compounding on research funded by AISH Volume 1, 2015 and dissertation-based publication Volume 8 and Volume 10. He has served as Assistant Editor of Journal of All India Institute of Speech Engineering and Audiology section of Journal of Indian Speech Engineering Association and is currently serving as Associate Managing Editor of Journal of All India Institute of Speech Engineering. He has been an expert reviewer for several national and international journal research funding agencies. He has served as HOD of Audiology of AISH Mysore between January 2016 to January 2018. He is currently serving as HOD of POCD AISH since January 2023. He has initiated and established 4 training and research laboratories at AISH: Practical Lab, Psychoacoustic Lab, Electrophysiological Lab, Facility for Advanced Auditory Research. His research interests include diagnostic audiology, electrophysiology, and efferent auditory functioning and speech perception. Wishing him success in all endeavors.
Thank you. Thanks a lot for the honor that's shown. It meant a lot. Thank you. You have heard me morning when I spoke. I have nothing much to add on. Hopefully, you would learn out of this seminar and go and implement in your day-to-day clinical activity with which your patient or your students or whoever gets the benefit. And whatever you learn, I hope you would do a good use of that and be a good audiologist, be a professional audiologist, maintaining all the professional standards that are mandated or required by our professional organization, ISHA or RCI. All the best. Do well.
I would like Dr. Sandeep to say a few words.
I've already spoken for 1 hour. I have one more hour of talk, so I'll keep it very brief. First of all, I'm humbled by this. I didn't expect this. Whatever narration that you saw with respect to my biodata, I think it's just God's grace, and the credit should go to the right mentors. I think I was there in the right place at the right time, and that's what made me kind of do whatever I've done till date. Of course, I think this is just a beginning. There's a long way to go for all of us to work for the community that we are meant for, and we have a long way to go in terms of where we have to take our profession as an audiologist. I'm an audiologist by profession. Of course, I did my SLP in my bachelor's also, but yes, we have a long way to take the audiology profession in our country, as well as serve the community. Whatever little work that I've done, if it kind of motivates the youngsters here, I think I'll be very. I will think that that's a very satisfying job. Once again, thanks a lot for this humble gesture. Thank you so much.
I request all the professionals to assemble for the RCI photo. I request all the professionals to join us for the RCI photo.
अभी अंदर सेट अभी ओके अंदर प्रॉब्लम
Okay, so what's the motivation? Last session, huh? That's the motivation. Okay, you learned about do's and don'ts of multi-brainstem responses. You learned that we have to do everything right and ensure that we don't do anything wrong to get the right kind of waveforms, so that we make the
right kind of interpretations, and whatever wrong has happened in the auditory pathway, we get to identify that, right? So you know how to, you have an idea as to how to have a good ABR recording. But after we have the ABR recording, what information does it provide, or how informative is the ABR? That is what is going to be dealt in this particular talk. So it's about scope and the challenges. I'm not going to talk much about the challenges. Okay, I'm going to talk very little about the challenges. I'm going to talk more about the scope. I want everybody to look at me. Okay, scope is very important because ABR is a very powerful tool when it comes to hearing threshold estimation and identifying space occupying lesions. Okay. So I've narrated this story through few case presentations. Let's see what's in the bucket. So you already know the amazing facts. AEPs are in microvolts being picked up and visualized, and ABR is only 1 microvolt, whereas noise is about 200 microvolt. Therefore, it is very challenging to record ABR. Still, we have been able to successfully record, and it has got unmatchable precision, temporal precision, and it is useful both for hearing threshold estimation as well as the identifying the lesions. And we have got electrophysiological counterparts of all behavioral tests. Okay, so it's the same points that I started with in the previous presentation. What are the challenges? Challenges, of course, we do ABR for infants as well as adults. Challenges are more in infants, and you know the reasons. The challenges are in terms of, broadly, you can actually categorize the challenges under these headings. Challenges are in terms of achieving the optimum protocol, in terms of getting a good electrical impedance, good electrode placement. Challenges are in terms of muscle artifacts, electrical artifacts, stimulus artifacts, how you get them and still get a good auditory brainstem responses. Challenges are in terms of the recording time. This is a big challenge. I told you, in simple words, I told you that tone burst ABR is the gold standard, but it's not practical, right? If it is not practical, what is the point in talking about it being a gold standard? So how can the recording time as a challenge be actually taken care? And of course, differential diagnosis of pathologies is a challenge in auditory brainstem responses. Now, with all these challenges, how many of you think ABR recording is challenging? ABR recording, analysis, and interpretation is challenging. How many of you think it is challenging? Raise your hands. Those who don't raise, I will ask questions. How many of you think ABR is not at all challenging? How many of you think ABR is challenging? Many of you, right? Okay. But be happy, you are not one of them. This is a picture of 1937, where you are seeing that Erna Gibbs along with Frederick Gibbs. You know what is this? This is an ABR equipment. Whole room, okay? The equipment occupies the whole room. This is an ABR equipment. And do you know who is this? Hallowell Davis, one of the very prominent personalities in AEPs. Hallowell Davis and his PhD student, they are recording ABR. Do you know who is the subject? Yeah, there is a rat here. They are recording all AEPs on that rat. Okay, so this was the AEP equipment. Imagine if you had to do ABR in this particular equipment, how difficult it would have been. Okay, they will record, but the recording will come like this in these paper rolls. Big paper rolls. It's not averaged waveforms. They are looking at each sweep that is recorded. It's not average response. Looking at each sweep across this whole paper roll, they will identify whether the response is present or not. Now tell me, is ABR recording for you challenging? Even if it is challenging, definitely not at all as challenging as what it used to be in the 1930s. With the invention of the technology, we have done wonders. And today, whatever we have in terms of science, we are placed best for ABR recording, efficient recording, and efficient analysis of the responses. Now, coming to scope of ABR, One, of course, we can use it for hearing threshold estimation. And we already discussed that, only do it if the behavioral thresholds are not reliable, not in every case. Now, there are few aspects that you should take care when you are using for hearing threshold estimation. One, of course, it should not be a case of ANST. Any case where you are suspecting retrocochlear pathology, do not use ABR for hearing threshold estimation. Use ABR for hearing threshold estimation only in those cases where you are suspecting conductive hearing loss, where you are suspecting cochlear hearing loss. Not in those cases where you are suspecting retrocochlear pathology, be it a case of acoustic neuroma, be it a case of ANST. 1 point. Second point. Now, the slope of the audiogram is a very important variable when you are recording auditory brainstem responses. Most often we are recording click ABRs, we are not recording tone burst ABR, and click ABRs give you information only between 1 to 4 kilohertz region. It is not giving frequency specific information because click is a broadband stimulus, and clicks give you information primarily between 1 to 4 kilohertz. Which means to say, if a person has got steeply sloping sensory neural hearing loss in the high frequency region, ABR is going to overestimate his hearing loss. Similarly, if the person has got a raising configuration, low frequency hearing loss, as in case of Meniere's disease, if the person has got a raising configuration, more hearing loss in the low frequencies, less hearing loss in the high frequencies, ABR is going to underestimate the hearing thresholds. So be aware of these facts when you are using ABR for threshold estimation. Number one, never use if you are suspecting RCP component. Second, if it is steeply sloping hearing loss or a raising configuration, you are not going to get the right estimate of the hearing loss. It gives you good estimate in case of gradually sloping or maybe flat kind of a hearing loss. It helps you in the diagnosis of ANST. One of the diagnostic criteria, the very diagnostic criteria of ANST is absence or abnormal auditory brainstem responses and presence of normal cochlear functioning, either reflected in terms of presence of photoacoustic emissions or reflected in terms of presence of cochlear microphones. Okay, so only if cochlear functioning is normal and you're seeing absent or abnormal auditory brainstem responses, in majority of the cases it is absence of the auditory brainstem responses, you will see that you can diagnose ANST. The beauty of diagnosis of ANST is neurologists will also miss because it's a functional damage. There is nothing that is abnormal that can be seen in a CT or an MRI. How will the neurologist identify? Neurologists will go by the clinical symptoms. The clinical symptoms is the reduced hearing sensitivity or poor speech understanding. They don't understand this much. Neurologists don't understand this much. They generally don't have too much of giddiness. They generally don't have, some of them can actually report of tinnitus. In all these cases, to confirm, the neurologist sends them for MRI or CT. Everything comes normal in CT and MRI. So neurologists will miss this. Only one professional who can identify ANST is the audiologist. Okay, we should be proud of our profession. We can identify ANST that can be missed by neurologists. I've tried to make many neurologists understand about this. Some of them, on the very first instance, call this as aphasia. Okay, if they're not able to understand, they're able to hear, but they're not able to understand, then it must be aphasia, they say. They don't even know the concept of ANST. So, ABR plays a significant role, or it's a very, very important tool for the diagnosis of ANST, which can be missed in many other tools. Detecting auditory maturation delay. It has got immense scope in the detection of auditory maturation delay. Detecting acoustic neuroma. All these things I'm going to tell you through case histories. Okay. Now, when it comes to acoustic neuroma, you should know few things. That is, you know that most of the time acoustic neuroma starts in the vestibular nerve. Okay. If I have to weigh ABR and VIMs for the detection of acoustic neuroma, I will say VIMs are better than the ABR because acoustic neuroma, most often the origin is in the vestibular nerve. Now in the vestibular nerve we have superior vestibular nerve and inferior vestibular nerve. You should know the susceptibility as an audiologist. So most often acoustic neuroma starts in the inferior vestibular nerve. As the tumor grows and it compresses the cochlear nerve, that is when the auditory symptoms starts. Okay, till then it will be only the balancing issues. If it is starting in the, it's not that it is not impossible for the tumor to start in the cochlear nerve, but it is a very rare occurrence. Most often it is starting in the vestibular nerve. So if you look at the internal auditory meatus, I think all of you are familiar with the internal auditory meatus. So if you look at the internal auditory meatus, we have 8th cranial nerve, vestibular part, 8th cranial nerve, cochlear part, and you have the 7th cranial nerve, and you have vestibular artery, or the not vestibular artery, it is the blood supply to the cochlea. Okay, so now what is important is it's most often starting in the vestibular nerve, and as the tumor grows in size, it starts compressing the cochlear part of the nerve, and that's when the auditory symptom starts. That is when ABR can actually detect the acoustic neuroma. Now, if it's a vestibular damage and not impinging on the cochlear nerve, you will not find any abnormality in the speech identification scores. You will not find abnormality in ABR. You will not find any abnormality in the hearing sensitivity. Only if it impinges on the cochlear nerve, auditory symptoms can be expected. This is something that you should know. Carotid artery. That's what I wanted to say. Okay, now coming to the first one, case 1, ANST. What do you expect ABR to be in ANST cases? Loudly. Absent in most of the cases. I've seen that, if I take 100 cases, about more than 95% of the cases will have absent auditory brainstem responses. A rare case can actually have some peaks, but deviant in their latency and amplitude and mortality. Okay, more than 95% of the cases it is absent responses. Now this is a very clear-cut case. Okay, do you see ABR present? None of the peaks are present, so ABR is going to be absent. But a lot of cases you might see waveforms like this. That is, you actually record ABR. The patient is suspected to have ANST because of the speech identification scores and the pure tone audiogram results. And you see that there's something like an ABR coming, at least in the initial portion. Something like a first peak is coming in the initial portion. Always cross-verify by doing the ABR in the opposite polarity. So most often, as a standard protocol, we use rarefaction polarity stimulus. So you would have recorded ABR in the rarefaction polarity, repeat it by using condensation polarity, and you will see that whatever waveforms that you are getting in the initial portion will reverse. Okay, so that is a very clear indication that it is cochlear microphonics. There are two things that reverse with stimulus polarity. One is cochlear microphonic, other one is stimulus artifacts. You need to differentiate these two. Now, if you take stimulus artifacts, what happens? Stimulus artifacts will have the same characteristics as that of the stimulus. So if you use a click, it is just one cycle of a click. So you won't see multiple cycles like this. You actually see one cycle coming down, again another cycle, and again another cycle, again like this. Okay, you're seeing multiple cycles. Now, a stimulus artifact won't have a multiple cycle because click that you have presented has got only one polarity, that is either condensation or rarefaction. Now, this is a very clear indication. If it is going till here, it is a very clear indication that it is cochlear microphonics. Do it in the opposite polarity to further confirm. You will see a straight line like this because the cochlear microphonics will get cancelled, ABRs are absent, therefore you will see a straight line like this. Okay, so you might find a lot of cases with ANST where they have robust cochlear microphonics, which we call as ringing cochlear microphonics, or sometimes it is also referred to as long ringing cochlear microphonics. Generally, cochlear microphonics are of what latency? 1 to 2 milliseconds. Okay, in ANST patients, you can actually have cochlear microphonics. I have seen a cochlear microphonics going up to 11 milliseconds. That's one rare case that I have seen, but I've seen many cases where it, on a frequent basis, we see about 2.5 to 3 milliseconds. Easily, cochlear microphonics will be ringing in the case of ANST. Now, why does cochlear microphonics come in ANST patients? That is usually not seen in normal case. That's a question to be pondered. Okay, the reason is because of the abnormal or the deviant efferent auditory functioning. Okay, the oligocochlear bundle actually is also abnormal in that in terms of its function. There is no suppression that is happening by the efferent auditory pathway. Therefore, the outer hair cell activity will be robust. Okay, there is no suppression of the outer hair cell activity. Activity of the outer hair cell will be robust. That leads to robust cochlear microphonics, or in other words, ringing cochlear microphonics. So how to suspect CM? We have already talked about. Now, can mimic AMD, auditory maturation delay, because in auditory maturation delay, what is the classical sign of an auditory maturation delay in terms of ABR? Earlier peaks are better than later peaks, right? Generally, a classical auditory brainstem response will have later peaks better than the earlier peaks. Fourth, fifth is better than the first, second, and third, right? Now, what happens in auditory maturation delay is first earlier peaks are better than the later peaks. Now, when I record ABR in a single polarity, I can actually see that I might actually perceive this is a first peak and a second peak, and I might think it to be an auditory maturation delay. So I can actually get confused looking at a cochlear microphonics. I might actually get confused and call it as AMD. But cross-verify using the opposite polarity stimulus, and you will find that it is not AMD, it is ANST. Now, the second case is a suggestive of. So this is a classical ABR I showed you in my previous presentation also. This is how you see in a matured brainstem. Okay, matured auditory nerve on the brainstem. You find that the later peaks are better than the earlier peaks. Now look at this waveform. What do you see? A prominent first peak, third peak present, fifth peak present. But as you go to later peaks, the amplitude is decreasing. So earlier peaks are better than the later peaks. I've actually done it in the opposite polarity also. It makes no difference. It comes the same way. And look at the beauty of this. Now this is an AMD case. Okay, classical AMD case, where earlier peaks are better than the later peaks because of the delayed maturational development. Now look at this. I have actually tracked the thresholds of ABR in this case up to 30 dB, and this is 90 dB, 70 dB, 50 dB, and 30 dB. And what I'm able to see is the first peak remains still the lowest intensity. Fifth peak is not present in the lowest intensity. Okay, so normally we see fifth peak is the lowest intensity. In this case, I'm seeing the first and third peak is the lowest intensity. Now, this is what I told you. The presence of the peak is what matters. It doesn't matter which peak it is. Did I estimate ABR thresholds in this case accurately? Yes. I estimated using the first peak. Okay, so this is a classical waveform of an auditory maturation delay. Now, in this case, I've seen till 30 dB, but you may see that in many cases you may not see till 30 dB. You may see only till 50 dB, even in a AMD case. Now, which are the cases where you suspect auditory maturation delay? I mean, see, it's not just looking at the waveform, right? Before you do ABR, you should have suspected auditory maturation delay, and accordingly you should have refined your protocol. You should have tailor-made your protocol to tap the auditory maturation delay. So, what are the indicators of auditory maturation delay? That is high-risk indicators. If you look at the Joint Committee for Infant Hearing, they've actually given 12 high-risk indicators. So some of them that are likely to lead to auditory maturation delay or ANST is one most common or most spoken high risk indicator is, what is it? Hyperbilirubinemia, okay, or the neonatal jaundice. So jaundice can actually lead to auditory maturation delay, or sometimes people consider prematurity also as an indicator of auditory maturation delay. So if there are high risk indicators through which you get to suspect auditory maturation delay, refine the protocol, tailor make the protocol in such a way that you will be able to tap the AMD. Now, case 3 is something like AMD. Look at the waveform. Is it an AMD? Does it have a classical sign of AMD? Yes or no? Green card, red card. Yes or no? Are earlier peaks better than the later peaks? Okay? Then it is suggestive of AMD. But this is a case of 3.5 years. In 3.5 years case, I don't suspect AMD. One common misconception that we have, when we were all taught AVR, we were taught that AVR becomes adult-like up to 18 months, right? It doesn't mean that AVR is not adult-like up to 18 months. Our teachers did not teach us wrong. We learned it wrong. Our teachers taught us AVRs can become adult-like up to 18 months. They didn't say AVR takes to become adult-like up to 18 months. There's a lot of difference in it, right? AVRs are adult-like even in infants of 10 days old and 15 days old. Understood? Suppose you have a case of auditory maturation delay, a rare case where there is auditory maturation delay and AVR is not developed, you can wait up to 18 months for it to mature. Don't wait beyond 18 months. If you are seeing a case who is suggestive of AMD even after 18 months, for example, in this case it is a 3.5-year-old case having signs of auditory maturation delay, earlier peaks being better than the later peaks, suspect something more. It is not AMD. Now this is a case where it is a Leigh syndrome case. Okay, a Leigh syndrome is a case where there is a progressive neurometabolic disorder of infancy and childhood, and it's a heterogeneous disorder due to abnormal mitochondrial function. So if you find abnormalities like AMD beyond 18 months, don't just restrict it to AMD. There must be something more than AMD. In this case, it is Leigh syndrome. It could be something else in another case. Case 4. Now, generally, when I'm given a talk to talk about scope for AVR, the tendency is to tell only good things about AVR, but I don't want to do that. I want to give you the right idea about the strength as well as weakness of the auditory brainstem responses. Now, this is a case where I'm going to tell you that AVR is not always helpful. Now, unusual clinical signs in this case: a 16-year-old female complains of hearing loss in both ears since 2 years, tinnitus in the beginning. Okay, there was, when the hearing loss started 2 years before, there was tinnitus. Now tinnitus is not there. Poor speech perception. She is not able to understand anything. We did the audiogram. What do you see in the audiogram? Right here shows dead regions on the higher frequencies, and I told you click AVRs give you primarily information between 1 to 4 kilohertz. Do you expect right ear AVR to be present? No. Left ear has got about severe hearing loss, 80 dB plus. Do you expect click AVR at 90 dB to be present? Less likely, right? So in this case, we got absent auditory brainstem responses, which means to say AVR was not helpful for me to understand whether it's a CP or RCP. Understood? Next, we did immitance. Immitance is normal. So A type with absent acoustic reflexes. You can expect absent acoustic reflexes for this degree of hearing loss. Otoacoustic emission shows normal outer hazel functioning. Okay, OEs are present in both ears. Outer hazel functioning is normal, which means to say whatever severe to profound hearing loss that I'm seeing, it has to be retrocochlear in origin. Right? It is not cochlear because OEs are present. OEs are present. Poor speech identification scores, severe to profound hearing loss. So it has to be retrocochlear in origin. But was I able to assess it tap it through AVR? I was not able to tap it through AVR. Now, how did I understand that it is an RCP? That is the beauty of this case. So AVR is absent. Interesting thing was, while I was doing, while in the clinic, student was doing otoacoustic emissions and Sharat sir was supervising. I was taking Wow, what a coincidence. I was taking VII in Holy Cross when this case was being tested by a student and supervised by Sharat sir. Sharat sir called me while I was taking Viva and we discussed about this case. So he said that we can't record OEs in 1 year and it is showing noisy. Same audiometric room, same patient, same tester, same equipment. 1 year they are able to record out acoustic emissions. Other year they are not able to record because it is showing noisy. That means to say noise is getting recorded when they are recording OEs in the opposite ear. Now, how can there be a noise in 1 ear and no noise in the other ear? It cannot be attributed to any of the external factors, right? External noise factors. So, we suspected that there must be objective tinnitus. There must be tinnitus getting generated within the ear, and that must be getting recorded by the OEE probe as noise. So what we did is, first thing, easiest thing to do is, we took the step and inserted this tube into the ear, both the ears, and we found that in 1 ear we are not able to hear any noise. In the other ear, we are able to hear a pulsating noise. Okay, we are able to hear a pulsating noise. Pulsating noise, pulsating tinnitus is a symptom in which case? Jugular? Jugular tumor and one more condition. Wonderful, patulous eustachian tube. So two conditions where we see objective pulsating tinnitus is, one is jugular tumor, other one is patulous eustachian tube. So over 4, we discussed that we will try to test for glomus jugular tumor. How will you test for glomus jugular tumor? Sharat sir is feeling bad sitting in the front.
What sign is there?
Schwartz sign. Schwartz sign is rotosclerosis. Rising sun sign. Rising sun sign is an otoscopic finding. You tell me as an audiologist, which audiological test will tell you glomus jugular tumor? Sharat sir told you that there would be, you can actually tap it through tympanogram or you can tap it through acoustic reflexes. See the variation in the admittance over time. You can either use record tympanogram at a very slow rate, or you can do a reflex decay test, is what Sharat sir taught you. So we did that. Okay, so I'll come to that results later. But there's a video there. Can you play? Yeah, look at the OE there. You're not able to see? See here. Look at the noise indicator. Can you see the pulsating noise going up and down, pink color? Okay, so that is why recording audioacoustic emissions. So because of that, OEs are not getting recorded properly. So what special test did we do? We did a test for patulous eustachian tube, and there was no perturbations. Okay, this was the recording that Sharat sir got it when he did reflex decay test. There were no perturbations. That means to say it is not glomus jugular tumor. And then he also did this one, breathing for different breathing patterns. He recorded reflex decay, and across different breathing patterns there was no difference, which means to say it is not patulous eustachian tube. What next? Then we referred the case for MRI, and what we found was this. Can you see a large tumor here? Can you appreciate a large tumor here? Yes or no? White color? This is a 16-year-old female having a large tumor, brainstem tumor. It could have been fatal. The patient would have collapsed anytime because it is in the brainstem. For 2 years, she has gone around different parts of the country to find out what is the problem. Nobody was able to find out, and Sharat sir was able to find out. So give him a big round of applause. So the point is, sometimes you have to. APR is not always helpful. There are other clinical signs that you have to look for, and there can be unique clinical signs like this. Source of noise, yes, of course, there's a gushing of noise. How many of you have heard how the OAE probe, at the OAE probe, how the acoustic environment is there while recording acoustic emissions. You can actually go through this YouTube video. There actually Hudspeth. Okay, Hudspeth is a very big name when it comes to mechanics of cochlea. So he has actually recorded acoustics of the ear canal, and you can actually hear very nice heartbeat. You can hear the person breathing and all that. So if there is a tumor in the brainstem, it will be highly vascular in nature. The gushing of the blood inside and outside the tumor, no, that is what was being recorded as pulsating tinnitus. So if there is a pulsating tinnitus, you should suspect a tumor. You can suspect a vascular looping. We have found another case where there was a vascular looping. I've not included that here. So there are many things apart from the glomerular tumor. Now coming to case 5, where ABR is a powerful tool to detect acoustic neuroma. This is a success story, I mean, as an audiologist, when you find such cases, you actually feel very proud about yourself. Now, this is a case, you won't believe this is a last week case. Sharat sir knows about it. Okay, so this is a last week case of 40-year-old female. She was a sister of our security guard. She happened to come with a complaint of reduced hearing sensitivity. We did audiogram and we see that the right ear is normal hearing sensitivity, left ear is minimal hearing loss. The speech identification scores are, you can see 100% at 55 dB in the right ear and it is 96% in the left ear. But when we did spin is 96% in the right ear and only 16% in the left ear, which means to say in SIS we would have missed. But because we did spin, we could actually tap the speech identification disorder in this case. So we did acoustic reflexes, not very informative. I'll come to that later if necessary. OEs we did, otoacoustic emissions are normal, which means to say cochlea is functioning normally. Whatever minimal hearing loss and poor speech identification scores in noise is there, that is not because of the cochlear damage. So then we do ABR, look at the waveforms. 30 seconds for you to look and appreciate the waveforms and identify the abnormality. These are classical cases, and I must tell you, AEP is that's where my heart is, I would say. That's my forte. I've always worked with a lot of love in AEPs. I've been teaching AEPs for many years now, but this is the first case where I saw a classical ABR like this. I'll explain that to you. Could you observe the signs? Abnormal signs? No? Which class are you in? The check shirt person next to white shirt? Inter. Okay. Do you see asymmetric ABR? One ear ABR poorer than the other ear ABR? There's a right ear ABR that you are seeing in red color, left ear ABR seeing in the blue color. Do you see are you seeing them as symmetrical or asymmetrical? Asymmetrical. Okay. Hearing sensitivity being comparable, one is normal, other one is minimal. Hearing sensitivity being comparable, ABR being asymmetrical to such a large extent itself is a very clear indication of RCP. Okay. So you see that ABR is beautiful in the right ear. All peaks are present, absolute latencies are normal, interpeak intervals are normal, and this is the 11.1 waveform and this is the 90.1 waveform. In 90.1 actually you see first peak, third peak as well as the fifth peak. Okay, I may not go for the first peak very confidently, but third and fifth is definitely there, and the fifth peak latency is only 5.73 at 90.1, which is fantastic. So right ear ABR is normal, but look for the left ear ABR. What are you seeing in the left ear ABR? You see the first peak, you see the later peaks are abnormal, you only see among the later peaks, you only see the fifth peak, and that too with prolonged latency of 7.23 I think, or 33, I'm not very sure of this. Okay, I'm 40 plus now, so I've developed some visual acuity issues. 7.33 or 23? 33? Okay, 7.33. Sharat sir proved that it is below 40. Okay, so, and this is the 90.1 waveform, and you see the 7.95. There's not much, if you look at 11.1 to 90.1, there is not abnormal shift. There is no abnormal shift. But this is what I told you. I've been teaching ABR for a long time, and I always teach in the class that a classical sign of brainstem tumor is the first peak is normal and the later peaks are affected because distal portion is usually spared and the later portion is affected. But I have not seen a case myself in our clinic where first peak is very much normal and later peaks are abnormal. So I happened to see probably this was a destiny before coming and giving this talk in HCC FlaSH. First peak was normal and later peaks are abnormal. The beauty of this case is, okay, it's asymmetrical. So we suspected acoustic neuroma and we sent for neurologist. So this is ABR results, whatever I explained to you, same thing in numericals. Okay. The beauty of that case is, that case went for MRI yesterday and MRI results came normal. And so I have a friend, radiologist, and I told him that I strongly suspect acoustic neuroma in this case. I'm 99% sure of it, but MRI is showing normal. And he told me, you ask them to collect the CD of the recording and get it to me. And today he has seen the CD of the MRI and he has found that there is a small intracanalicular tumor that is got missed out in MRI also. Okay, so the regular MRI can actually miss out tumors, small tumors. Contrast MRI is required. Okay, and unless you specifically tap for a small acoustic neuromas, small tumors of less than 1 centimeter in size can actually be missed out even in a MRI investigation. Okay, so this is a case where we were confident based on ABR that it is acoustic neuroma and MRI missed, and on re-investigation it has been found. I'll get the reports and probably share with Sundaresan and he can circulate to some of you. So where we found a small intracanalicular tumor detected in acoustic neuroma, detected in auditory brainstem response, missed out in MRI also. This is where you have to understand that audiological tests are really powerful. It's about you developing that skill and the knowledge to ensure that you don't miss out on anything. Now coming to, there's something called as contralateral effect of ABR, which happens in large size tumors. Now this is a case very similar like the previous case that I showed you. Normal in the right ear, minimal hearing loss in the left ear, identification scores are 100% and EOEs are present in both ears, and this is the ABR finding with the case having only minimal hearing loss, having 100% speech identification scores, has got absent ABR. In the previous case, we found that first peak is present, later peaks are abnormal. In this case, for the same minimal hearing loss, the ABRs are absent. So we sent this case for MRI, and in MRI we found that is a large tumor. This MRI was done on 26 December 2019, and there's a large brainstem lesion. This again can be fatal. Now, what I'm trying to explain here is, in case of a large tumor, you actually find that the abnormality is not just on this side, on the tumor side, you can actually find the abnormality on the opposite side. When I say opposite side, I'm not talking about the contralateral waveform of the left ear, I'm talking about the ipsilateral waveform of the right ear. That is what I call it as contralateral effect of ABR. That is, the ABR on the opposite side, the ipsilateral side of the opposite ear shows abnormality, opposite to the tumor side. So in this case, the tumor is on the left side, but actually this was an investigation before. There was a 6 month gap between this and this. We repeated this case. Observe the date. Okay, this is in December. This is December 26, 2019, and this is September 2020. About 9 months gap between these two. And we did ABR. We repeated the ABR, and what we found was this. Observe the latencies here. Of course, left ear ABR was absent that time also, left ear ABR is absent this time also. Now, in the previous time, the right ear ABR 1.70, 3.55, 5.75, absolute latency was normal, 1.80, 2.20 and 4.05, relative latencies are also normal. Now, in this case, after 9 months of MRI, when the tumor had actually grown larger, we found that there is a abnormal interpeak latency going up to 2.45 and 4.58. Okay, so if you see abnormality, see, I always explain this in the class also. A case comes with profound hearing loss on one side and normal hearing on the other side. We do ABR on the normal side, and then we do ABR on the profound side also. Why do we do ABR on the profound side? We know it is profound. Do you expect ABR to be present in a profound case? Still, why do we do ABR on the profound side? That's because we want to look for the first peak of ABR. Even if it is profound, if the tumor has not impised on the distal portion of the auditory nerve, you can see the first peak. And if you see the first peak, even in a profound hearing loss, if you are seeing the first peak, it's a clear indication that it is acoustic neuroma. Okay, I do it on the profound side to look for the first peak of the ABR. Why do I do on the normal side? I do it on the normal side for this, to observe the contralateral effect of ABR. The third to fifth interval can go abnormal if there's a large tumor. It can go abnormal on the normal hearing side if there's a large tumor on the opposite side, which is called as contralateral effect of ABR. Now, case 7, it hints at the presence of pathology. ABR hints at the presence of pathology, but doesn't really point out as to what lesion it is. It's a road traffic accident case. Road traffic accident had happened 4 years back. 50-year-old female, reports of hearing loss since 4 to 5 months only. Accident happened 4 months back, but hearing loss is reporting only since 4 to 5 months. Has moderate hearing loss on the left ear. Speech identification scores are only 48% on the left side. Now, if there is a moderate hearing loss, do you expect 48% speech identification scores? You expect better, right? If it is cochlear hearing loss, you expect better. If it is 48%, that means say it hints at the RCP. Okay, so right here is minimal sensory hearing loss with good speech identification scores. This is what happens if you type it in the last moment. It is good, not goof. Okay, so this is the ABR research. 1 minute time for you. There are some unique things. Observe in the paper. How much was the hearing loss on the left side? How much was the hearing loss on the left side? Moderate. Okay, hearing loss on the left side was moderate. Right side has minimal sensory hearing loss. First, look at the normal side. Everything is normal. Okay, 1, 3, 5. Everything is normal. Look at the left side. In left side, we were actually seeing. Look at the first portion. I mean, generally tendency is to look at the 1, 3, 5 peaks. Okay, but you should not be, as a good audiologist, you should not be looking just at those 1, 3, 5 peaks. You should look at the waveform holistically. So we actually observed there was something like cochlear microphonics on the initial portion. We repeated it in the opposite polarity and the cochlear microphonics came in the opposite polarity. Do you expect cochlear microphonics if it was cochlear hearing loss? No, right? It is a flat hearing loss, moderate hearing loss. I wouldn't expect if it is cochlear hearing loss, I wouldn't expect cochlear microphonics. But actually I am seeing something like cochlear microphonics and I repeated it in the opposite polarity and I confirmed that it is cochlear microphonics. If the left ear has got moderate hearing loss and cochlear microphonics present, what do you suspect? RCP, right? Okay, so in this case, we actually suspected RCP. We don't know what is the RCP because the client has to go to neurologist and come back with MRI reports. So we are waiting for that. This again was 15 days old, 2 weeks back. Okay, so 2 weeks back we saw this case. It may not be related to his road traffic accident. There must be something else that is starting probably in the last 4 to 5 months. But there is a clear indication of RCP, cochlear microphonics present, moderate hearing loss, ABR present. We even did threshold estimation, and threshold matches with the behavioral threshold. Behavioral threshold showed moderate hearing loss. ABR thresholds of the left ear also shows moderate hearing loss. So ABR results are matching with the behavioral thresholds in terms. ABR thresholds are matching with the behavioral thresholds. Cochlear microphonics are present. Clear indication of RCP. We don't know what is the RCP. Okay, we are yet to arrive at the exact pathology in this case. Just based on the audiological profile, I am not able to derive it. That's what I told you. Sometimes it hints at a neural pathology, but it may not be precisely. It may not be a precise indication towards one. It can also detect diffuse lesions. Okay, this is my last case. This is also again a road traffic accident case. A 36-year-old male. He would work in an income tax department, and this was the audiogram. Okay, with this being the audiogram, you see that identification SRT is 110 dB NR and 0%, 0%. What do you suspect first? Road traffic accident, normal to minimal hearing loss. Okay, and speech identifications are 0%. What do you suspect? ANST, na? Okay, normal hearing sensitivity and 0% speech identification scores. I suspected ANST. I means it's always a teamwork. I should not say. We suspected ANST. We did acoustic reflexes. Look at the acoustic reflexes. Beautiful acoustic reflexes. What do you understand? If you got a beautiful acoustic reflex, nothing wrong with till the SOC, right? Okay, till the SOC pathway. Sharat sir told you about the ipsilateral pathway and contralateral pathway. Till that pathway, I'm not bragging him. Don't. Okay, so till that pathway, everything is normal, right? If you got a beautiful acoustic reflexes. OAE results, otoacoustic emissions are present. Okay, normal otoacoustic cell functioning in both ears. Again, indication of RCP. ABR results. Look at the ABR results. I don't have the waveforms, or maybe I have the waveforms. I'll just check. Okay, so 1.49, 3.68, 5.98 vary. That means to say I'm not sure of the response being present. That is true for both sides. So I find that fifth peak is abnormal, third peak is present. When we talk about the generators of the ABR, first peak distal portion, second peak proximal portion, third peak cochlear nucleus, fourth peak SOC, fifth peak lateral numbness. Everything is still SOC is normal. Fifth peak is abnormal. That means it is something at the level of the lateral numbness and above maybe is abnormal. We sent him, this is the LLR results. LLR are coming nicely for the right ear as well as left ear. All latency and amplitude characteristics are normal in that case. We actually sent him for MRI and it showed diffuse axonal injury. Okay, so when there's a cowp and counter cowp contusions, when there's a sudden hit to the head, there would be cowp contusions and counter cowp contusions. That time there could be damage to the white matter, okay, which they call it as diffuse axonal injury. Diffuse axonal injury, the prognosis is generally very poor, and ABR was able to tap a diffuse axonal injury. There was no space occupying lesion like a tumor. Okay, so that's another thing. So it can actually detect a diffuse lesion also. Now that's about the power of ABR. One of the challenge in ABR is the long recording time. So I actually thought, in the scope of ABR, I just wanted to tell you that, there's a scope for improvising the way we record ABR, cut down the recording time. So this is a method that we actually kind of formalized on our own. See, we generally do ABR for the right ear and the left ear, right? Okay. And if we present a stimulus at 30.1 per second, between one stimulus to other stimulus, there's a gap of 33.33 milliseconds. So what we did is, instead of doing ABR once completely for the right ear and then doing for the left ear, what we did is, we alternated the stimulus between right ear and the left ear. Okay? And after, instead of 33 milliseconds gap, the stimulus came at 16.5 milliseconds gap, and the second stimulus that was coming was going to the opposite ear. Third stimulus to this ear, fourth stimulus to this ear, fifth to this ear, sixth to this ear. Stimulus alternated between the 2 ears. In an individual ear, the repetition rate was 30.1, but overall the repetition rate was 60.1. Simultaneously or alternatively, I am stimulating the right and left ear, and we recorded auditory brainstem responses, and we found that whether it is a conventional auditory brainstem response recording or we call it as VII ABR. VII is a very famous dish in Karnataka. Okay, so we thought we will name it after VII. So we called it as VII ABR. That was on a lighter note. Okay, so we called it as brainstem response simultaneously. Okay, VII. Okay, VII ABR, and we were able to record the same ABR in half of the time. Okay, so it doesn't require any great technology, but it just requires little working out with the stimulus, and we were able to record simultaneously from the 2 ears without one ear interacting with the others. If you present a binaural stimulus, one ear will interact with the others. That's not the way. You have to alternate the stimulus between the 2 ears. In many instances, these are just scope for modifications or improvisations in the ABR record. Okay, that I'm telling you. Now you may find that many a times two babies will sleep simultaneously in the clinic. It used to happen in our clinic when we used to have less number of equipments, less number of students, and more number of patients. Two babies will sleep simultaneously. By the time you finish one, the other one will get up. Okay, patients would have come from different distances. So we actually thought we will work out something where we can actually simultaneously record ABR from two babies simultaneously. So what we did is, we had these 2-channel equipments. A channel we placed on one baby, B channel we placed on the other baby, ground we placed on one of the baby's hand, and we made the two babies hold hands with each other and recorded ABR simultaneously. We first verified it with adults. Okay, that's how it works out. So you can actually place A channel with one person and B channel with the other person electrodes, and this shows, one shows the individual ABR, the conventional method, other one shows the simultaneous method, and you can actually see that the ABRs are almost the same. So we could actually record from two people simultaneously. In the previous technique, we could record 2 ears simultaneously in an individual. In this, we could actually record 2 people simultaneously. Now, there are babies like this who wants to see what is happening around when you are doing ABR. Okay, they don't want to sleep. So what to do with these babies? One, you can use weighted averaging. So Vibosonic actually has a technique called as Kalman filtering, which uses weighted averaging, and you can actually do even when the babies are moving. I think many of you are aware of this. It has got two techniques. One is Bluetooth technology, and the other one is the weighted averaging. So if you have weighted averaging in your equipment, you can actually do even if the babies are awake and moving around. This is another method we worked out. Now we do click ABRs, and whenever click ABRs are absent, we do tone burst ABR. That's a protocol that AISH follows, because there could be some cases with sloping hearing loss, better low frequency sensitivity. So every case with click ABR, because click ABR gives only information between 1 to 4 kilohertz, it may not tell us anything about the low frequency sensitivity. So every case who has got absent ABR, we do 500 Hz tone burst ABR. So instead of doing first click ABR and then 500 Hz ABR, and then to the opposite ear also, first click ABR, then 500 Hz ABR. So what we did is, we'll do simultaneously, we will do click as well as tone burst. So what we did is, we made a chain of stimulus where click came first, 20 milliseconds gap, and then the 500 Hz tone burst came. And we recorded ABR. See how beautifully you can record click ABR as well as 500 Hz ABR simultaneously. So you can do two different stimulus simultaneously you can record and reduce the stimulus recording time by half. The last one, tone burst ABR. This, of course, it's a gold standard. Tone burst ABR is a gold standard, I've told you. But tone burst takes 4 times more time than the click ABR. So, what to do? I'm not able to do. We are a premier institute, but we don't do best practices. That's not acceptable, right? So, we were actually thinking as to how to do it. So, what we did is we took 4 tone bursts, made it into one chain, and recorded ABRs for them. And this is the ABR that we get. Isn't it a good ABR? And these are individual tone burst ABR. And this is for 400 Hz, this is for 400 Hz. You can actually see that it is exactly same. So, we used a chain stimulus paradigm and recorded 4 frequencies simultaneously. So, instead of using 2 hours, instead of recording ABR for 2 hours, what we did was, we were able to record ABR just in half an hour with the same kind of accuracy. So what I'm trying to tell you is, there are a lot of challenges in ABR, but you actually sit and discuss with a group of people, you can actually find out methods to overcome those challenges. These are some of the methods that we devised to overcome the recording time, to significantly cut down the recording time, to improve the efficiency of ABR recording. This shows the threshold estimation in the chain paradigm. You can actually see this is at 110 dBSPL, 90, 70, 50, 40. You get ABR like this, as good as the individual tone burst ABR. ABR can also be used to tap APD, auditory processing disorders. I'm not going into details because of the constraint of the time. There are many studies where they have shown that a subgroup of CAPD individuals have got abnormal ABR. You can design stimulus paradigms of ABR to tap speech perception in noise. I've already told you this. Gap detection test, binaural integration, binaural separation, temporal resolution. Whatever auditory process that you are tapping in the behavioral test, you can actually design a stimulus paradigm even in the ABR also. And most importantly, a big window of opportunity for ABR in tapping the auditory processing disorders opened when Meena Cross recorded ABRs for speech syllable da. Okay, so she showed that some things that the subtle auditory processing deficit that cannot be identified using click ABRs can be tapped using complex ABRs. Complex ABRs, when I say ABRs recorded for complex stimulus, one of the complex stimuli that they used is a speech syllable. Okay, so there's a big window of opportunity to tap APD using auditory brainstem responses. In fact, ABR has even been used to identify, to recognize the corticofugal pathway. We know olivocochlear bundle. Contralateral separation of photoacoustic emission assesses olivocochlear bundle. There's something called as corticofugal pathway, another different auditory pathway from cortex to brainstem, and we can actually assess using a unique paradigm. We can actually assess the corticofugal pathway also using brainstem responses. So with that, the take-home message is ABR is a powerful tool for threshold estimation. It's wonderful. However, understand that there are exceptions like ANST and cortical deafness. It's powerful in detecting acoustic neuromas. I gave you examples where it couldn't be detected even in MRI. It's not that MRI cannot detect, but somehow it has been missed out in the MRI, I would say. It is definitely required as part of the diagnostic criteria. ABR is required to diagnose ANST. It is sensitive to detect audio maturation delay. It is sensitive to detect deviant neural processing as in case of CAPD. But one can appreciate all the above advantages only if the audiologist is skilled. Okay, audiologist has to be skilled. He has to have the sufficient knowledge required in ABR. He has to have the sufficient skill to do a good recording, efficient recording, good responses, and of course, interpretation is the key in identifying the pathologies. It is a big boon to audiologists, but it's all about how we can exploit the strengths of it. With that, thank you. I can answer questions for the previous session also. No questions? Too late for a question. I totally understand that. Sitting for the whole day. One thing I can tell you, speaking is always easy. Listening is difficult. Okay, so it was a very nice opportunity for me to interact with all of you. Hope these are just few case examples. We can go on and on with lot more case examples. I've just picked up few cases which are tapping different things. In acoustic neuroma, I can show you at least 10 to 15 different cases. Okay. In ANST, I can show you another 5 to 10 cases with different ABR patterns. These are because of 1 hour slots. These are different varieties that I tried to show you. If you get involved in your clinic also, you will be able to find a lot of them. You can always get in touch with me. My ID is very simple. The first one, can you go to the first slide? I'll give you the slides. Yeah, that's my ID. So if anybody wants to get in touch with me, you can. Thank you so much. Thanks, sir. I thank the organizers.
Thank you, sir, for your continuous support since HCC FlaSH. We are profoundly grateful for your presence at this FlaSH Series 7 conference too. Your involvement and support made it a truly exceptional conference, sir. Thank you for sharing your views on the area's do's and don'ts, its scope and challenges, and turning all our audiologists into smart audiologists. Thank you, sir.
Play is our brain's favorite way of learning, and fun-filled activity awaits for you all. I request all the delegates to take out their phones and open your Google Chrome and type quiz.com. Please follow the instruction on the stage and the screen. I request all the delegates to be seated. It will just take 5 to 10 minutes, not more than that. Kindly type the pin in your batch. Are all the delegates entered the game? As per the request from the delegates, we will continue the game tomorrow. I request Dr. R. Sundaresan to felicitate Dr. Sandeep.
you. Dear delegates, kindly note how we break for the banquet. The banquet starts by 6:30 and it will be till 8:30. Buses will be arranged, so they will take you to your respective hotels. So, hope to see you soon in the banquet. Thank you. With this note, we would like to end the day 2 of our conference. Thank you. Dear delegates, kindly note, banquet will be in the basketball ground. You are all requested to assemble by 6:30. Thank you.
ரூம் போய் லேட்டா வராதீங்க 8:30 மணிக்கு தான் லாக் பண்ணிடுவோம் இங்க லேட் கிடையாது அலௌட் கிடையாது ஒன்று ரூம் போய் இல்லாட்டி இங்கே நோக்கோ இங்கே கிரவுண்ட்ஸ் இருந்துக்கலாம் இன்னைக்கு கரெக்டாக ஷார்ப்பாக 6:45 ஆரம்பிச்சு 8:30 மணிக்கு முடிஞ்சுட்டு வாய்ப்பே